The organizing committee and my mentor Dr. Gautam Pallit for giving me the opportunity to present my talk today, which is on medication safety. So I decided to talk about this medication safety in this very scientific gathering, because this is the final destination of pharmacology. Medication safety, the clinical aspect of clinical pharmacology, or even experimental pharmacology, or pharmacology as whole. The final destination is the clinical outcome and the medication safety. So today my topic is medication safety, the translational aspect of clinical pharmacology. So translational clinical pharmacology, what do we understand by translational clinical pharmacology? It is a simple, vertical under pharmacology which aims to move the drug discovery or the regulatory approval into the real world clinical practice. So this is what we are trying to, emphasize, and this is what my objective is here today, to put across this point that the final destination would be clinical outcomes for any pharmacological, lab experiment or even animal experiments. And then coming to medication safety. So medication safety represents a critical vertical within the translational framework of clinical pharmacology, emphasizing the prevention of medication errors, adverse drug reactions, and therapeutic failures across the continuum from bench to bedside. So this journey from bench to bedside is very important and very, tedious exercise. But the final destination is the bedside, and that is where the final focus should be. And this is an area which is, often I would say neglected as pharmacologists, because we believe this is the clinical domain and this is where the journey ends. But this is not actually where the journey ends. This is where the journey culminates, and these hardcore pharmacy researchers, everybody knows about drug safety. So drug safety, when we talk about drug safety, we talk about drug development, animal experiments, microdosing, other alternative experiments, clinical trials and regulatory, all these processes, and everybody is well versed with this. And then there is another term which is medication safety. We use it synonymously with drug safety, but it's something different. It's clinical oriented. So when we talk about medication safety, it is pertaining to clinical pharmacology. And what are the things that we are looking at? We are looking at good prescription practices. We are looking at good pharmacy practices. And we are deliberating about the... So this is beyond pharmacy, drug administration, and finally drug monitoring and surveillance. So if you weigh drug safety, which starts at the bench, and then you have the medication safety, which is the final destination at the bedside, so how would you weigh it? Definitely the main objective at the drug safety section is to develop a drug which is safe. So this is about developing something which is safe, and we have lot of regulations for that. But when it comes to medication safety, what does it mean? That finally this safe drug, which took you millions of dollars and so many years to develop, is it being used safely? Finally, this safe drug, is it being used safely at the bedside? And we do have regulations for it. but they are not, very stringent, and they are not being followed, and we do not have, sensitization on these regulations pertaining to medication safety at the bedside. And I'm glad that we have now NABH accreditations and other accreditations which make it mandatory to implement these medication safety policies. And I'm going to, take you briefly through this journey of medication safety and how to ensure the safe drug that you have produced is actually safe. So let's try to see the significance of the issue. So patient harm due to unsafe medical care is a leading cause of death and disability worldwide. So this is the significance. Then 1 in 20 patients globally experiences preventable medication-related harm. Preventable harm. So this safe drug is not actually in safe hands. Almost 50% of preventable harm is related to medicines and therapeutic interventions. And then a quarter of preventable harm is considered severe or life-threatening. So imagine this safe drug is not being used safely. So what do? So in NABH accreditation standards for hospitals, these are set of standards, and there is one complete chapter, management of medication, MOM. This one complete chapter is dedicated to medication safety, and it has 11 standards: safe prescription, uniform prescription, safe drug administration. So these are all regulatory policies that are there in the NABH management of medication chapter. And I would urge all people who are involved in drug safety must go through this, especially people working in the clinical sites. You must go through these standards, because this is where all the efforts of the pharmacologist, this is where it will rest. So once we have these regulatory policies and guidelines, what are the indicators which show that the drugs we are using are being safely used? What are the indicators? So we have indicators for good prescription practices. So we have minimum prescription criteria. So whatever prescription is being written by the prescribers, there is a criteria for writing the prescription, and the minimum criteria should be met. The drug names, this is the regulatory law by Indian government, the NMC, that the prescription, the generic names should be in capitals. They are preferred to be in generics. Then error-prone abbreviations should not be used. And 98 to 99% times we do use them. Then the prescriptions should be rational. And who would decide what is rational? Again, we have standards to decide what is rational. We have the guidelines, the ICMR standard treatment guidelines, to decide whether the prescription is rational or not. But do we really check? Is anybody concerned? So next we come to good pharmacy practices. Myself being, heading a lot of clinical pharmacology activities, but I'm myself looking forward to mentorship when it comes to pharmacy practices. And when we look at the stalwarts of pharmacy, so even they look towards the clinicians to support them for clinical pharmacy practices. And there is a huge gap. We are not well versed with pharmacy, and the pharmacy people are not well versed with the clinical aspect. And who will meet the two ends? So this needs to be taken care of. And I would like this gathering to discuss and deliberate upon these issues, these lacunae. So next we come to, and here all of you must be knowing from the pharmacy domain, that we have look-alike, sound-alike drugs, and they are very important. They cause a lot of medication harm. High-risk drugs, so what do you mean by high-risk drugs? When should you be cautious about prescribing a drug? So you should know what is high-risk drug. What are the rules and regulations pertaining to psychotropics? So many of us were using tramadol for pain. So now tramadol has become, again restricted drug, that which we were using, judiciously in our outpatient clinics. So recently it has been again put into restriction by the government of India. So again we need to know about these regulations. Then reserve antibiotics. Do we have an idea about what are the reserve antibiotics? Although we do not have any regulations about antibiotics, leave alone the reserve antibiotics. So we need to discuss and be aware about all these. Then the rights of drug administration. All of us know that. Right indication, right drug, dose, route, frequency, duration, and how important they are. you need to ask a clinician, especially a clinical pharmacologist, who goes and audits and sees the 90% of non-compliance. And what is the way forward? The way forward is sensitization right from the grassroots level. And then we have the monitoring and surveillance of the patients. Again, very important area. So good prescribing practices. So as you can see, I have highlighted this. 70% of medication errors that could potentially result in adverse effects are due to prescription errors. 70% are due to prescription errors. So this is where the clinicians need to be sensitized about the good prescription practices. And these good prescription practices, we do have many workshops and guidelines on these good prescription practices. But again, an area which is completely ignored and not given due attention. But it's leading to 70% of the harm. So that is what is important. That is what should awaken the pharmacology fraternity. And when it comes to audits, it is we who audit. It is we who plan and recommend the policies and recommend what should be done. The way forward is given by the pharmacologist. So we ourselves need to be sensitized. Only then we are going to make sure that drugs are used safely. So this is the minimum requirement of a prescription: patient details, drug details, and doctor details. So generally you will see there are patient details, there are drug details, although not always drug details are there, not the complete details, but the doctor details most oftenly. An area which is, you have a signature, you hardly know whether it's a signature or it's a tattoo made there, it's just there. So this is an area where there is majority of non-compliance, doctor details. Because remember, prescription is a medical legal document. It is a medical legal document. Again, we have to know that the doctors have to refrain from prescribing medicines of other medicine systems. So we need to stick to our domains. And this is the standard prescription format, and the students must have seen it in our, the basic textbook, CAPSM. This is the standard prescription, although we do not follow it. This is the prescription format given by MCI, NMC, and you can see the pharmacy details also need to be there. Pharmacy plays a very important role, not only in international setup, but even in Indian setup. And I think in Indian setup, he plays a more, larger and important role, because the doctors are already overburdened. So it is the pharmacist who would, at least spend 2 minutes deliberating to the patient, what exactly needs to be done, which would, ensure compliance and proper use of the drug. So that is what is the standard, and this is what is being practiced. These are our prescriptions. Even if we have, prescriptions on the HIS, the Hospital Information System, again you will see there are all the columns are left blank. So even on HIS, these are our prescriptions, these are our practices, and these lead to medication errors, these lead to patient harm. So what are the indicators that we keep checking? And we, we present them in the audits, and we present them before the auditors from the NABH. And finally, the outcome is that we keep on presenting these audits with no deliberations and no policy forward. So we capture the data for drugs not in capitals, and as you will see that 99% of the times the drugs are not in the capitals. Then error-prone abbreviations, most of the time, 89% of the times you will see that the error-prone abbreviations are always written CST, continuous same treatment, continuous same treatment. And what happens that antibiotics are continued for months, CST, continue and continue whatever was continued in the previous page and the previous page, and you keep on continuing the antibiotics for 15 days, for 1 month. We have seen antibiotics being continued for months because CST was there. So when it comes to drugs, there is another, drugs and prescription writing. There is another vertical which is antimicrobial stewardship, which is something being, focused now by the international agencies, and also in India we are focusing on antimicrobial stewardship because we have an action plan, we have a national action plan. Unless and until we do not have someone with a stick, we do not comply. So this is the new stick, we have antimicrobial stewardship. Stewardship means just to make sure that the antibiotics are used judiciously and rationally. So what are the goals? The goals again, better patient outcomes, patient safety, and reduce antimicrobial resistance. So these are all pharmacy practices, clinical pharmacology pertaining guidelines which need to be put in practice. Only then the efforts that are being put to develop a new drug would be actually useful. And these are some of the strategies that we use. We do pre-authorization of reserve antibiotics, that we restrict the antibiotics. Nobody is allowed to prescribe them. Only a clinician, a consultant and above could prescribe them and fill a form before prescribing them. So that is restriction, pre-authorization. And then we have prospective restriction, which means prospective audits, that we go do audits and then present the audit report before the clinicians. And when the clinicians see that, oh, 98% times I am using reserve antibiotics and there is non-compliance in 50% of the cases, only then when he sees his report, he is going to change his practices, probably. We hope so. The next is de-escalation. Again, the nursing staff here needs to be a part of this. And who will train the nursing staff? It is the pharmacologist who is going to train the nursing staff on these strategies. So again, it falls upon us. It is our duty to ensure that every segment of the healthcare professionals is doing his best, is practicing the best practices to ensure the drug is safe. So de-escalation, it is the nurses who have to ensure that de-escalation takes place after 48 hours, after you get the culture and sensitivity report or any other lab report, say procalcitonin levels in case of sepsis. So it is the nursing staff who has to ensure that there is de-escalation, review, IV to oral switch, and other strategies would be, important strategy is infection control, hand hygiene. This is how you prevent the resistance, the antimicrobial resistance being carried forward. Otherwise, everybody is like, it's my life, it's my way. I would like to take the antibiotics for 10 days. How does it bother you? It does bother because you are spreading this resistance. Okay. So these are some of the forms that we use for antibiotic reviews. We have this antibiotic review form. This is from the WHO. This is the list of antimicrobials. Only when we know what is the list can we ensure that there is restriction. Again, what are the indicators? The appropriate prophylaxis for antibiotic. This is an indicator for medication safety. Again, how many reserve antibiotics are you using? This is an indicator for medication safety. Coming to pharmacy practices, very quickly. I hope all of you from the pharmacy domain know about good pharmacy practices. Again, it forms the cornerstone because when you are dispensing the drugs to the patient, the compliance comes from here. Again, the way you are storing your drugs to ensure that they are safely stored. The look-alike and sound-alike drugs. We have recently, Trental and Tegretol. Trental and Tegretol, do look it up. They were prescribed synonymously. Patient को Trental दिया गया था और Tegretol दिया गया after 2 days. And you can see the consequences. You can look it up. How important is look-alike and sound-alike drugs? And that is why WHO tells us that you need to write them in a particular manner. The tall man's, way of writing them. These are the look-alike and sound-alike drugs that need to be stored and prescribed by double-checking. And high-risk drugs, all of us should be aware. Every pharmacologist or pharmacy student must be aware what are high-risk medicines with narrow therapeutic index and drugs which have consequences when it comes to adverse effects. Say anticoagulants, insulin, which would lead to severe consequences. So this is how they are labeled in red and double-checked, and every time you prescribe them, dispense them, double-checked. This is how you store them. Red, high-risk at the top. And LASA, look-alike, sound-alike, in pairs but in diagonals. And these are the practices which lead to safe medication use. And they should not go unnoticed. Then what are the emergency drugs? What are the crash cart drugs? This is again an area of discussion. Crash cart and emergency. Is it safe? Again, this is a life-saving cart. And you should know what is there, what should be there. Then narcotics and psychotropics. Why it's important? Because it's estimated that iatrogenic opioid dependence in the hospital is 4.7%. So the patients in the hospital are getting abused by these painkillers. So we need to take this seriously. This is an area which has gone, unnoticed, and these are all the, these forms are to be filled, and they are given by the government of India, that we should be, the ones who would give training to the healthcare professionals on how to fill these forms. But we ourselves do not know what are these forms and what are the verticals that need to be captured for prescribing narcotics. Even when you are disposing the narcotic, you need to have a evidence for disposing of the narcotic, and sometimes return the empty vials to the government. Administration, again, so important, because maximum of the errors take place at prescription and then at dispensing. And I always tell my students, whenever you are giving an IV, remember that it's something you are putting into the body. You think that you have a gun in your hand once you're giving IV. Always go slow and be vigilant. Always be vigilant with IVs. And the last segment is monitoring and surveillance. So whatever practices you have in your hospitals, in the clinical sites, somebody needs to monitor it. Who is going to monitor it? It's the pharmacologist. It's we. It's our job. Whether pharmacy or pharmacology, we are the ones who are, the leaders to take forward and train others. To train the clinicians is also our job. So we know post-marketing surveillance is through pharmacovigilance, and now we have another very important domain, materiovigilance. All these, IV drip sets, these syringes, all of them, they are part of the medical devices. So we have high-risk devices, low-risk devices, medium-risk devices, all of them are. They need to be highly calibrated and standardized so that we do not have medical device associated adverse effects. So we do capture adverse event prevalence, we do capture medical device adverse events, how many adverse events are there, and as you can see, what is the burden of medical device errors. And finally, coming to medication errors. What is medication error? Any error that takes place in the clinical domain is medication error. And again, all over the world, international and global world is focusing on these medication errors, because we only think that, during the drug development, we need to be very cautious. No, we need to be cautious while this drug is being used. And this is prescription error, transcription error, patient response. How is patient responding to you? You need to have good communication skills. Administration, storage, packaging, and dispensing. So yes, we have high workload, but that does not, make us inert to being vigilant. Medication error rate, again, highly important for any hospital to be NABH accredited. You need to have this very much limited, the medication error rate. It should be below 3%. And now in the new standards that NABH has added now, these new standards, but I keep on telling them, have you made sure that the previous standards are met? In the Indian practices, do we prescribe in capitals? Do we prescribe general in generic names? Do we have we stopped using error-prone abbreviations? And how can we shift to these new indicators? Are we ready for these new indicators? So this is where I would like, the stalwarts of pharmacology and pharmacy to deliberate upon. How do we make the use of medication safe in Indian setup? So I would conclude by saying that medication safety must be included in routine clinical pharmacology practice. It should be practiced, and then again be a part of the pharmacology curriculum in a phase-wise manner. We should take it into our practices. Pharmacology rounds should be made mandatory by the government of India, and by I would request this August gathering to take this feedback forward. So again, these organizers, this is my humble request, that not only presenting these talks, we would also like to sit and deliberate upon these issues. Thank you so much.
Does AI-based prescription auditing shows measurable benefits in reducing the medication error?
AI-based audits. AI-based, well, I do not know much about AI-based audits, but I would say, HIS, Hospital Information System-based audits, yes, they do help. If your IPD or OPD prescriptions are on the HIS, the Hospital Information System, even now in India, most of the tertiary care hospitals also do not have HIS system. In our hospital, we are also now starting HIS in IPD. OPD mein to hai, IPD mein. Yes, but again, a human touch needs to be there. Somebody has to be there to devise this AI system, and then again somebody has to be there who will run this system. Finally, we have not come to that stage that AI will be let free on its own to assess. We have not reached that level. Somebody has to check and balance and then assess that AI application. Who will do that? Who is trained on that? And I was just discussing it with ma'am. When the clinical part, we as pharmacologists in the hospital. So we take the lead role, and we depend on the pharmacist to tell us about the pharmacy practices. And when a Pharm B clinical pharmacist, an expert comes to us, so he is not well oriented, because he says, ma'am, I have come to learn from you, because you are in the clinical practice. So there is this gap. I am a pharmacologist and he is a pharmacist. But where do we meet? Who will ensure that we have the training to train each other? I am not trained to train a pharmacist. And the pharmacist has nothing to give me, because when he comes with all his knowledge, but he does not have knowledge on clinical practices. I was talking to Dr. Y.K. Gupta sir also about this. Who is going to train? There has to be a task force initially. Who is going to train the pharmacist to train us and train us so that we can deliberate and tell them what are the lacunae. But both of us do not have that expertise to give to each other what we are looking for, that particular thing.
Once if the train is, it will be better, we can be able to reduce the medication errors by using AI.
Yes, definitely. Say, when it comes to these indicators and audits that we do, yes, we are trained on that. But when it comes to pharmacy practices, the actual pharmacy practices, we are not trained on. So we ourselves want someone to train us so that we have the full knowledge of pharmacy practices.
Congratulations for your lecture. The question is like tramadol, as you have discussed that it is a risk-bearing type of medication. So what's the risk, or you can say any type of these things that you have find out that what the tramadol was doing? Because from the last 8-9 years, I established so many models when I get some clinical reports experimentally. So what you are thinking on the basis of clinical practice about tramadol?
Yes, about tramadol, I would say, no, tramadol has not been put into high risk. Tramadol has been put into narcotics now. We would prescribe tramadol in hospitals, and the doctors would be able to prescribe, freely tramadol. Now tramadol has been put into narcotics list and restriction of use. So now, because of the abuse of tramadol, I know, in my own family.
I just said it was interfering with the dopamine. That I said experiment. I completely in my data, so I wrote down so that.
Okay, that's nice. It is interfering with the dopamine. Yes. So why it has been put now into the narcotics? This is because of increased abuse. Because of increased abuse. Because I know my people around me are also using tramadol for every pain. So that abuse that was leading to
So this goes for about 10.
No, not about 50 mg.
That I have
Yes,
experiment.
the experiment. But in clinical practice, the tramadol was being used, for any pain and every pain. That's why it has now been. But again, the doctors do not know. So we have to, every time, send them these mails and alerts that this is now being, put into narcotic. But we are not aware. That is what my discussion was today. My talk was that.
Ma'am, we are really sorry to interrupt, but we have a time constraint.
Yes, definitely. I want we need to.
Now I request Dr. Itagi, please kindly felicitate our first speaker, Dr. Nusrat Ram. Please. Next speaker we have Dr. J. Archana.
Second speaker, Dr. Archana M.Com PhD, is a professor in pharmacology at RBVRR Women College of Pharmacy, Hyderabad. Her expertise spans pharmacology, pharmacy practice, pharmacovigilance, systematic review and meta-analysis, medical writing, and clinical research documentation. Dr. Archana has supervised PhD, a master degree, PharmD, and B.Pharma scholars, and has authorized 40 plus peer-reviewed publications, multiple book chapters, and a research-based book on diabetic neuropathy. She has served as an editor and reviewer for international journals, coordinated PVPI approved adverse drug reactions monitoring and center activities.
Very good morning to one and all. Thank you, sir, for the nice introduction. So today I am going with the topic nourishing hope. So this is a nourishing hope on a daily basis because we are discussing about the diet. Role of diet in the breast cancer prevention and management. So as many of you know, breast cancer is the most common type of cancer which can be seen in the women globally. Globocon reports 2.3 million of breast cancer cases, new cases were found in 2022, and there were 0.67 million of deaths due to breast cancer. And the projections are by 2040 there will be 3 million of breast cancer cases and also 1 million breast cancer related deaths. So this indicates how this is a alarming issue. So this is a map which indicates the actual incidence of breast cancer. Here you can see that India is standing in top 3 countries. So India is followed by first one is US, second China, and third India in most number of the cases. And if you see the deaths of breast cancer related deaths in India, it is topping the first rank. And in India, there is 66.4% mortality because survival rate of the breast cancer patients is 66.4%. So that means India is also facing many cases of the breast cancer which should be addressed by one of the lifestyle factors, that is diet. So if you see the risk factors, so these risk factors broadly we can say as modifiable as well as non-modifiable risk factors. Being a woman is the biggest risk factor along with aging, but you should know that 16% of the breast cancers we can see in the women below 50 years. That means there is still increased risk of breast cancer below 50 also. And this 16% may increase still more, maybe because of these dietary factors. Next, family history. But family history is also one of the risk factors, but there is no strong link because 85% of the breast cancers are not related to family histories. And as you know, there are germline mutations which may lead to breast cancer. Mainly BRCA1 as well as BRCA2 gene mutations are found. But apart from these germline mutations which are inherited, we can have many somatic mutations. These somatic mutations may happen because of environmental exposures, radiation, and these somatic mutation can also happen because of the lifestyle factors. So you can say that lifestyle factors can promote this type of somatic mutations which may lead to breast cancer risk. These lifestyle factors, there is a clear evidence that 1/3 of the breast cancer related deaths are attributed to 5 major lifestyle factors. These are having 5 are less physical activity and high BMI, alcohol consumption, smoking, and also the very important one is having less vegetables and fruits in your routine. That is also one important lifestyle factor which is contributing to the breast cancer. So these are the different dietary goals in different phases of breast cancer. So first one is prevention, where here you have to look at maintaining the healthy weight, have much of plant-rich food, take healthy fat. So take always unsaturated fats rather than the saturated fats, and limit the red meat as well as processed meat, and also have limitation in the alcohol consumption. And if you see the treatment, because treatment there are so many side effects due to treatment, and there will be low energy levels because of the chemo, radiation, all these very powerful treatment during the cancer. So the main goal of the dietary approach is you have to maintain the calories as well as the proteins. That is, you have to maintain the weight there. So actually weight is also, high BMI is directly proportional, or it is directly linked to the breast cancer. In time of treatment, the weight should be properly managed, because most of this chemotherapy treatment, it will lead to weight loss. So that maintaining the weight is also very important during the treatment, which can be fulfilled by the proper diet. Next one is managing the side effects. This is also one of the very important thing, because chemo is causing so many side effects, ranging from loss of appetite to weight loss, or even vomitings, like so many side effects. There are a lot of side effects will be there, and in order to manage each side effect, you should have different dietary approaches. Generally, so nowadays there are so many dietary patterns are recommended for this breast cancer prevention as well as management, which we will discuss in the next further slides. And if you see the next phase, that is in the remission or in the survivorship, again you have to follow the same rules which you were following for the prevention. So embrace the prevention, have the most of the, and especially in the hormone positive breast cancers, chemo, radiation, surgery, all this will be followed by anti-estrogenic drugs or anti-hormonal drugs, which may have deleterious effect on the bone health. So that you have to protect the bone by giving proper dietary approach. Managing the fatigue and also chemo brain. So in some cases in some patients you can see these some cognitive impairment after the treatment, which can be also treated by using different dietary approaches. So these are the recommendations given by American Institute of Cancer Research. These are the 10 lifestyle recommendations given by AICR. So if you see these recommendations, most of the recommendations are dietary. So these are most of the recommendations are dietary recommendations. So you see the first one, that is eat diet rich in whole grains, vegetables and fruits. So by this you can reduce the breast cancer risk by 20% and have a healthy weight. So there is evidence that in postmenopausal women who are high BMI, they are having 12% more risk. Next one is be physically active. There is evidence that by having moderate physical activity, you can reduce the breast cancer risk by 12%, and by very active you can reduce the breast cancer risk by 13 to 14%. And here you have to, as I told earlier, we have to limit the consumption of the red meat as well as the processed meat. Instead of that, go with the lean proteins which you can get from the poultry as well as the fish. Limit the consumption of the fast food, sugary, high sugar foods, and limit the consumption of the sweetened drinks. So instead of that, you can have the hydration by plenty of water, and you can have the unsweetened drinks. And we should not use the supplements. So that is also one important recommendation given by AICR. So that is, you should not depend on the supplements to prevent the breast cancer. So always go with a whole diet. That is the best approach. Next, those mothers should feed breastfeed the children. That is also one of the recommendation. Next one is, so here whenever the cancer is diagnosed, so follow all these, if possible follow all these recommendations. This is also the last recommendation by the AICR. So if you see these, most of these recommendations are linked to the diet. So by managing the proper diet, you can manage the cancer properly. So here if you see these are some of the dietary risk factors which are already discussed. How they are useful to manage the cancer, or how they are reducing the risk. It is recommended for the breast cancer prevention, where 2/3 of your plate should be of plant-rich food and 1/3 of your plate should be proteins, that is lean proteins. So it is a little bit alteration for that American plate. And during the treatment, so here although treatment is the foundation for the prognosis, the other factors like diet, physical activity, self-resolution, these are also the other 3 pillars, and in conjunction only they can have the proper prognosis. So this is one meal plate which is recommended for the treatment, during the treatment, which includes again everything, so where you can have different dietary approaches. And here these are the patterns, different dietary patterns. So these days, instead of discussing about different diet, we can go with the different dietary patterns, where the first 2 dietary patterns are very, very famous. The plant-based diet as well as Mediterranean diet. So if you see this one, these 2, and Mediterranean diet, it is reducing the risk by 12% by 1 unit increase. And DASH diet, this is actually prescribed for the antihypertensive activity, but this is also, as it is reducing the obesity, it is also having some role in the prevention of the breast cancer. And also ketogenic diet, but there is some complex relationship with that ketogenic diet as well as the breast cancer, because ketogenic diet, where you will be consuming more and more fat, it may lead to some adverse effects in TNBC like cancers. So TNBC can be aggravated by high fat food, or it can be aggravated by high lipid profile. So whenever you want to go with the ketogenic diet, you have to consult the oncologist. Dietary fibers, they can reduce, so these are the some good diet where you can improve the breast cancer prognosis. So here estrogen, so the fiber can cause the estrogen expression from the body, thereby it can reduce the estrogen. So this fiber food is very much recommended in ER positive cancers. Omega-3 fatty acids, so these are having very good anti-inflammatory activity, so that they are also recommended. But there is some here there is some myths over this omega-3 fatty acids. Here you can have this linoleic acid. As we need fatty acids, generally nowadays we are depending on the vegetable oils compared to the animal-based oils, because they are more promoted. As anti-hypertensive activity is there, vegetable oils are more promoted, but these vegetable oils are having so much of linoleic acid. So the recent evidence shows that linoleic acid can bind to FABP protein, FABP5 protein, which is triggering the cell proliferation. It is in TNBC. So that we have to limit the consumption of vegetable oils, or you just go with the, in TNBC patients it is recommended to have the vegetable oils which are having low linoleic acid, like you can opt for the butter as well as coconut oil like oils. So these are the phytoestrogens. So there are some myths about the phytoestrogens. Phytoestrogens are, as we are calling them as estrogens, they can increase the estrogen levels and they can cause they can increase the risk, but it is not true. So actually these phytoestrogens are very weak estrogens which are not having any evidence to increase the estrogen levels. So it is recommended to have the phytoestrogens not as supplements, so you can include them in the whole food. So these are some of the vitamins which are having role in breast cancer prevention treatment, and these are some of the micronutrients which you can include or you can have from different diets. So these are different components which you can have from diets which are having a specific role in breast cancer prevention. And here these are some of the dietary implementations and proposed solutions. So you can have, there are different cultural preferences, socio-economic disparities will be there which can be met by different solutions. So coming to the conclusion, so overall diet plays a meaningful role in the breast cancer management, and understanding the whole dietary patterns, it is important to mitigate the risk of the breast cancer. And there should be more and more studies which will have evidence. So we have to plan for more randomized studies as well as cohort studies, and even we can use the emerging technologies like biomarker as well as women's research in order to correlate the dietary effects on the breast cancer. And also the professionals, the healthcare professionals, they have to take an active role in order to include the dietary recommendations in the treatment. Thank you very much. Any questions?
How do cultural dietary habit in India influence breast cancer prevention?
Sorry, sir.
So how do cultural dietary habit in India?
Okay, so that depends on the, so that's why sir, there is one slide where I included. So here each and every country or each and every community will have their own cultural habits, dietary habits. So that we should go with that, we have to plan such a dietary pattern, which should be recommended by ICMR like the institutions, so that are NIN. So they have to develop one pattern which can be followed by the Indians. Any more questions? Thank you.
Thank you, ma'am. Thank you, sir. Now, I request the chair kindly facilitate to ma'am. Next speaker, we have Professor Shamsher Singh.
Professor Shamsher Singh is a leading neuropharmacologist and head of the neuropharmacologist division in the Department of Pharmacology at ISF College of Pharmacy, Moga, Punjab. His research on neuropharmacological disorders such as Parkinson's disease, Huntington's disease, and neuroinflammation. His research spans clinical neuropharmacology model, hypertension-induced cardiac injury, and the neurotoxic effects of environmental metals, and he has contributed to nationally funded projects and peer-reviewed publication.
Thank you, sir. So very good morning to all, and thank you for inviting me, and I congratulate to all the organizing committee members for the wonderful event. So basically, you know that from the last approximate 10 years, I am working to establish the new models of animals like zebrafish and rodents. So likely I have discussed with the madam that she was talking about the tramadol, that I have established the tramadol model and got project from the government of India, ICMR, that it was interfering with the dopaminergic neurons in the brain of animal, that we have proved in the experimental model. So I will talk today on the current challenges in the herbal drug discovery and opportunities, that how the animal models of zebrafish are validated and how they are useful. So basically coming, okay, sorry. So moving forward, we can say that currently we are basically going on to, or we like to take the herbal drugs. And you know that they are the multi-component drug, and basically you know that even though we talk many a time that these drugs are very safe, but you know there are great challenges that if you are using the herbal drug and if you are taking them and if you are not exploring its toxicity profile and if you are not looking about the safety profile of the herbal drugs. So basically how we can say that currently if you see several of the scientists worldwide, they are working on the herbal drugs and they are using in various problems like neurological disorder, GIT problem, or even the endocrine or some cancer or other studies. And they have proved that these type of drugs are found to be safe, and yeah, but you know it is a challenging that which could be the safe dose of the drug that we people can take, even though nowadays you know that we are mostly suffering from some major issues like cancer and some other problem, and we are more liable to take the herbal drug, even though several of the videos on the YouTubes are available that people are taking so many antioxidants that could be useful because looking to their safety profiles of these type of the drugs. Now coming to this herbal drug discovery, what are the current challenges? Because whenever you are going to select any plant, it is very difficult that how you are recognizing on the basis of the various constituents that are present in the plant. Because you know that all the plants, they carry various type of flavonoids, alkaloids, glycoside, tannins, or retaining that how such type of the plants which contain these type of the multi-constituents, for which particular constituent you are looking to go for the further animal activity, or you are looking for the safe dose that you want to move the drug for the clinical trial. So basically, if you will see here that after the identification there is a big challenge that how we will move for the screening of the herbal drugs. Because you know that many of the constituents, they are not active at all at the similar temperatures. They are mostly inactive depending upon the temperature situations. And even though it is very difficult that we should have some standard references that how you are comparing the herbal drug with a particular standard drug. Because in case of allopathy, it is very easy that you want to select the allopathic standard drug, and either on the basis of mechanism or either on the basis of dose regimen or their dose of their mechanism of direction that you can select. But in case of herbal, it is a big issue that how you are going to select some standard components that you want to compare with some of the active drugs that you have. So due to the lack of references, we are having a big challenges. So that's why it is difficult that whenever you are looking for the herbal drug, you should look that there should be some standard references that you should compare the safety profiling, pharmacological action, either going on using the animal model or further. So this is basic to zebrafish, that why I am going to talk about this fish, that because you know that nowadays alternative to animal is a big challenge, that we avoid the use of large animal. Even though we cannot use very safely the dog, we cannot use very safely pig and frog, even though we were using some rodents, but now CPCSA recommended that you should move for the alternative to animals. So what's the alternative to animal we have? Either we can move for the zebrafish or either we can move for the organ on the chips, that you know that we can move for the simulation studies. So such type of chips, or by the help of artificial intelligence that has been designed, that type of the chips could be used to find out the particular problem based on the various markers. So basically marker is required over there. Likely you can go for the analysis of pregnancy, that by the use of chip method. So that strip what you are using, it is basically dependent upon the marker which that chip is having. So this is the big issue. That's why the zebrafish is nowadays preferring instead of rodents. And even though several benefits of the zebrafish is having, so if you want to recognize that, it is also a big question that how we can differentiate the male zebrafish from the female zebrafish. Because if you see this here in the lining of this zebrafish, that this zebrafish is little bit straight, you can see here. Oh, very sorry. So you can see here it is a little bit straight from the bottom side, that you can easily recognize that this is a male zebrafish. And if you will move for the female zebrafish, and you can see here that from the belly side, from the lower bottom side, it is a little bit bulky. That means it retains some of the eggs there. So eggs will be light up by the female. So that means how you can easily recognize based on this, that whether you are using the male zebrafish or female zebrafish, you can easily find out on the basis of this. And even though you can see some stripes which are present on the bodies of the zebrafish. Male zebrafish carry more black stripes, that is a melanin containing pigment is there on the body of the zebrafish. So that's why some of the people can do some studies using some model which can affect the melanin formation in the zebrafish, because you know that vitiligo is a big issue also. So that means it is very easy to use these type of the fishes there. So why zebrafish is preferred as an animal model, even though you know that rodents are having, we are having some non-rodents also, but you know that the similarity issues are there. For the behavioral similarities, we can consider rat could be a better. But considering the genetic or some regeneration studies, then the zebrafish is on the supreme level. They are, down regulating, they are down suppressing the rodents. Instead, the zebrafish could be a better, because it is more than 70% genomic similarities. And you know that the genomic system, genetic system is very simple too. Because species is small, the genes numbers is less. That means we can easily find out that any issue where there could be any kind of genetic mutation is there. So in case of various problem that nowadays the zebrafish has been tried in case of neuro problem, cardiovascular, endocrine, and some cancer study or regeneration study. It is a good approach that you people can move at a low budget also, because in case of rodents a large budget is required. You should have CPCSC approval of animal house, and all these type of facilities are required. So basically these type of the property, zebrafish is having regeneration of the heart, tail, retina. You know that zebrafish can regenerate the heart in within 1 second, and you know that in case of clinically cardiac mortality, myocardial infarction is the big issue, where the person or the patient is unable to regenerate that particular tissue which is damaged on the heart side. Now the scientists are looking for the protein which is responsible for the regeneration in the zebrafish, that can be isolated and translocated to the human being, so that myocardial infarction or the death related to this can be reduced. So this is also a good beneficial example of the zebrafish that we can do. So this is the advantage that I have already discussed, because we are having a time restriction. So that means that these all the advantage zebrafish is having. If you see that zebrafish can be used for at a large scale, it lays large number of eggs, because rodents only lays 3 to 4 pups, and it lays approximate 300 to 500 about eggs, and then a lot of larvae could be there. So then it is more beneficial. This is some of the limitation, that is genomic mutation could be there, mortality could be there, and you know that it is very difficult to retain, because temperature is must for the breeding of the zebrafish and for the retention of zebrafish. That should lie near to the 24 to 25 degrees centigrade. Now coming to one of the study that I have conducted many of these study. This was one of my study that one of the students, she did under me using the aluminium chloride model. I will just lay out with you that she did PhD under me, and now she moved for the postdoc in the Paris. Now this was the aluminium chloride exposure to the zebrafish. That means how aluminium chloride is responsible for the memory, and some of the learning issues are there. So in case of novel diving test, with some of the apparatus, I have also got patent from the government of India related to the zebrafish studies. And here we saw that the novel diving, exploration time was reduced with the high dose of aluminium chloride. So how dose of the aluminium chloride was used? 50 microgram per liter and 100 and 200. I have used 250 also, 500 also. During the 500, whole of the zebrafish were dying. पूरी death हो गई थी उनकी. 250 पे भी there was a 20% death was there, but safe dose was 200 microgram per liter. So that's why this model was, we tried to establish this model with the help of my PhD students. So this is the another study that we do novel diving test, and then we do team-based test for the learning and memory in the zebrafish. For the novel diving, we look for the anxiety in the animals like zebrafish. So this is the team-based result. How you can see that activity was altered, total number of entry that was increased, and you can see here there was alteration in the GABA and glutamate level in the brain of the zebrafish. That was done with the help of HPLC containing ECG detector that we have in our lab. So here you can see that level of serotonin, dopamine and noradrenaline. This we have also seen that it was affecting aluminium chloride. And now you people know that we basically use aluminium foil for the food. हम food भी aluminium foil में लेके आते हैं. Its exposure through the water could be there. पानी में भी ये present होता है. So this is the antioxidant enzyme that we have analyzed in the zebrafish. This is the histone we found. This is the amino histone we found. The here we saw that the expression of NRF2 was increased in the brain of the zebrafish exposure to the aluminium chloride. So this is the current challenges that due to the lack of time you people can discuss with me if any issue related to the zebrafish you have. Then this is our animal house. We have more than 1200 rodents also in our ISF College of Pharmacy, and I am looking for that in the Department of Pharmacology also. So this is our zebrafish lab. You can see some of the students, those who are working with me, and thank you very much for any questions.
I have one question related to polyherbal formulation. If you don't mind, I will ask the question. So because since it's consisting of different polyherbal formulations, we are facing a difficulty in standardization of the drug.
So basically basically, sir, the issue is that we always say that herbal drugs are very safe, but you know that they contain several type of metals. So some type of inorganic components could be there. So basically, whenever these type of drug we should take, we should look whether they are safe or not, and then we should explore the toxicity profile. I got some of the project from the Shri Ravi Shankar ji lab or some other, they are doing such type of drug. Their drugs are coming to the market. But whenever they talk to me for the toxicity, they don't know. Sometimes we can say there is a big issue that what type of components are present. Firstly, we should see that then on the basis of component we can go for the safe dose and toxicity dose, because ultimately we have to use the animal for the analysis.
Thank you, sir. I request the chair kindly felicitate Dr. Shamsher Singh. Next speaker we have Dr. Siddharth Mehan.
Hello.
Professor Siddharth Mehan is a prominent neuropharmacologist in the division of neuroscience in the Department of Pharmacology at ISF College of Pharmacy.
Yes.
Moga, Punjab. He leads research on neuroprotective strategies, mitochondrial dysfunctions, signaling pathway in models of cerebral hemorrhage, neurodegenerative disorders, and stroke. His work has demonstrated therapeutic effects of brain permeable compounds such as in preclinical rodent models. He has also been recognized with multiple awards at ISFCP, including the Young Pharma Researcher and Young Scientist Award.
Thank you, sir. Thank you so much. A very good morning to all of you. So, first of all, I would like to thank Organizing Secretary Professor Dr. Anil Kumar and Indian Pharmacology Society to invite me to express and show my results. So, the title of my talk is ALS Challenges, Diagnostic Approaches and Therapeutic Solutions in Neurodevelopmental Research. Today I will talk about the basic results of my lab, which we perform on amyotrophic lateral sclerosis. Basically, in my lab we are working on motor neuron disease, especially multiple sclerosis, amyotrophic lateral sclerosis and autism. So the title ALS, amyotrophic lateral sclerosis. So the problem is, brain illness presents a significant challenge for doctors and researchers in terms of treating, diagnosing and confirming the severity of disease development. What is happening? All of this encourages researchers to discover selected diagnostic markers and also preventive treatments for various brain diseases. What we are doing? Our preliminary findings strongly suggest that multiple cellular and molecular targets can be employed as biomarkers in the diagnosis and treatment of neurological dysfunctions. So let's start this journey. Rational. Are we aware, especially in case of disease, misdiagnosis, lack of therapy and lifetime suffer? What we are doing now? As a researcher during PG or PhD program, we perform the experiments, thesis submitted, either it may be go for patent, either it may go for publication, and then thesis lastly enter into the library. Now what is next? In this case, the two specific biological biomarkers we are missing in CSF and the blood plasma, and I am proudly said that we are the pioneer in India who are working on the cerebral spinal fluid in rodents. Amyotrophic lateral sclerosis, it is a motor neuron disease which specifically demyelinate the peripheral nervous system as well as the central nervous system. The motor symptoms are also there, some peripheral and central neurodegenerative symptoms are also there. Basic signs and symptoms of ALS includes pyramidal, extrapyramidal side effects. Group of muscles are affected, paralysis, spastic. Neurons of cranial nerves and nuclei are involved. Single muscles are affected, paralysis and flexing. These are the major symptoms of ALS. This is the basic etiopathogenesis, which ultimately leads to ALS. These are our lab papers that we recently explored all these mechanisms in our papers. So let me explain the first target that we explored in our study. First we rationalize these cellular and molecular targets. Suppose the basic function of cell is synthesis, storage and release. When a cell behaves like abnormal cell, when the synthesis, storage and release may be high or may be low. But in that case, very specific cellular and molecular targets are involved which are involved in the progression of the disease. So first we rationalize and hypothesize that these targets NRF2, KEAP, H1 and SIRT1 pathway, P70 NTR, PI3K, AKT, MAP kinase, they are involved in the neurodegeneration. This is the exploration and the rationalization of the pathway. This is another paper that we explored, especially Klotho, SIRT1, NRF2 and HO1 in neurological health. We also rationalize how these pathways are involved in the neurodegeneration and neurocomplications. Another is that was published in the highly reputed journal in Mutation Research, Reviews in Mutation Research, unraveling the multifaceted insight into amyotrophic lateral sclerosis, genetic underpinning, pathogenesis and therapeutic origins, where these are the glimpses and the images that I pasted here. These are from the original pictures from our papers, that by using these targets, how we explore and rationalize that these targets are involved, how these targets are involved in the progression of the disease. That is another paper. That is the role of icarin. This is a active phytoconstituent in the modulation of neuronal pathways, treatment of neurological disease. Another review paper, that is involvement of dysregulation of IGF-1 and GLP-1 signaling in the progression of ALS. Another review paper that we explore the dysregulation of ERK1/2, overactivation of ERK1/2, how these targets are involved in the progression of ALS. NRF2-HO1 in ALS, molecular approaches in ALS, drug targets for clinical and preclinical findings. This is exploration of these targets. Another review paper that involved the overactivation of JAK-STAT, mTOR and the dysregulation of PPR gamma signaling in neurological dysfunctions. Another cellular target that we identified, CJNK and P38 MAP kinase signaling in ALS, potential drug targets and influences of neurological disease. This is the pathway exploration. Now come to the results. This is the paper that last year funded by the Cell United States of America with grant of 28.14 lakh. The title of this thesis is Neuroprotective Potential of Sulforaphane in Methyl Mercury Induced Experimental Model of ALS in Adult fish targets. The beauty of this paper is, we select multiple biological samples, where the first biological sample was the brain, and in brain we isolate the 5 different parts: cerebral cortex, hippocampus, striatum, midbrain and cerebellum. On the other side we also isolated the cerebrospinal fluid. On the other side we analyzed these biomarkers in the whole blood as well as the blood plasma as well as the skeletal muscle. So these are the results, that how these targets are modulated by the phytoconstituent sulforaphane. These are the results. These are the results of PI3K, AKT, mTOR in the brain homogenates, and these are modulated and prevented by the active moiety drug. The targets in the CSF, cerebrospinal fluid, that we analyze in the NRF2-HO1 and SIRT1 in CSF. This is also the CBC profile in whole blood. You will get very few papers where they are performing the complete blood count profile in rodents. So we have a very specific instrument in our lab that is known as veterinary autohematoanalyzer, where you can perform 25 types of blood parameters in rodents also. So these are also modulated by the sulforaphane. The mercury levels in brain homogenates and CSF also modulated by the sulforaphane. These are the Western blot results. This is the HND staining of cerebral cortex, hippocampus, striatum, cerebellum. This is the LFB staining. LFB, as you know, Luxol fast blue staining, that is designed for the particular purpose to stain the myelin. The myelin sheet that is present surround the neuron. specific for that myelin sheets. So these are the pictures of the different parts that are reversed by the protocol drug. We are also checking the effect on the liver, because methyl mercury is a very toxic to liver. So we explore whether there is any peripheral protective effect of drug in liver or not. This is the gross morphological analysis of the whole brain. Here you can see the D. It is a disease group, and by treatment the brain becomes restoration. We not only stop here, we coronal sections of the B portion. This image represents the cerebral cortex, hippocampus striatum. C represents the midbrain and the cerebellum, and D represents the cerebellum and the pons area of the brainstem. This is the gross morphology of the liver. This second research paper that is also patented, the effect of caffeic acid in ALS. These are the results of caffeic acid, that how caffeic acid modulates the Klotho, SART1, NRF2 and HO1 in brain homogenates and CSF. This is the CBC profile, homogenates, HND staining, that it restores the structural part of the brain through HND. This is the LFB staining. This is the gross morphological analysis of the results. Now come to the next paper, therapeutic potential of olenolic acid in modulation of PI3K, AKT, mTOR, STAT3, GSK3 beta, neuroprotectionase, methyl mercury induced neurodegeneration. Here we select the target PI3K, AKT, mTOR. We analyze these targets in the brain as well as in the CSF also. CBC profile, HND staining, LFB staining. These are the gross morphological results of midbrain and the striatum. Here you can see the D. This is methyl mercury, complete demyelination of the white matter neurons in the midbrain. But after the treatment, you can see E, F, G, H. These are the treatment brains. And in H, you can see the complete restoration of the myelination. Another paper that we explore, the icarin, which prevents methyl mercury induced neurodegeneration. As you can see in the title, evidence from CSF, blood plasma, brain samples and in silico investigations. SART, NRF2, HO1 are activated by the icarin. Gross morphological results. Another paper from my lab, that is role of glucosteron by modulating STAT3, mTOR and Twitter. 5 minutes ago. These are results of that. Another paper in ALS, role of alpha mangosteen. These are the IGF GLP-1, 4-hydroxyisoleucine. These are on the same model by modulating the different targets in different biological samples. Another paper of apigenin. These are results of caspase, BAX3, P38, MAP kinase. Another acetyl 11 keto beta phospholic acid in ALS, where we are targeting NRF2 HO1. Another paper, we are modulating the adenyl cyclase, CAMCRAB and mitochondrial coenzyme Q2 with the help of potential forskolin. So let me explain one another example from my lab, that is known as translational neuroscience. Ma'am, I also want to mention here that this project was funded by the Cellogenics USA, and this was the only product that is available in the market that from preclinical trial to clinical trial we proceed this target, and now this date this is a 50 crore project for this project. This was the paper that we published. Efficacy and safety of Ultibrain as an adjuvant therapy for autism spectrum disorder, and open label trial targeting core symptoms. These are the MD neurologists from throughout India. We conduct the clinical trial, and now this product is in market. You can mention and type in your Google. The product name is Ultibrain, that is available for autistic patients. This is the formulation that is available in the market. This is my lab, my PhD and PG scholars. Supporting and funded by various funding agencies which provide the funding: DSP Sub, MSME, ICMR. Also thankful to our chairman Parveen Garg, Director Dr. G.D. Gupta, Professor R.K. Naran, and special my mentor Dr. Achan Narula, Chairman Narula Research, North Carolina, USA. And the most heartfelt and sincere thanks to those little rats who sacrificed their life for our future. The credit for the clinical and preclinical results presented in my talk belongs to the hard work and intelligence of my all research scholars, not me. Thank you. Any question?
I request the chair kindly felicitate Dr. Siddharth Mahel for his research outcomes. Now it's time to felicitate chair of this session. I request Dr. Nusrat, Dr. J. Archana, Dr. Shamsher Singh, Dr. Siddharth kindly felicitate to our chair.
में ले आया हूँ। ठीक। अब स्पेस कितनी है? 35 के करीब होगा। चेक करो। हाँ 35.2 अभी चेंज कर दिया डेट पे। पहले किस पे था? WMP। हाँ WMP। तो मल्टीपल मैंने करना रह गया ना, तो ऐसा करा ये 2 भी है। ठीक है। ये थी ना, ये कल वाली है। हाँ ये भी कर लो, ये भी कर लो, ये भी कर लो। अभी वाली कौन सी? ये अभी वाली है। हाँ ये अभी वाली है ना। ये क्या नाम बता दीजिए, रीजन क्या नाम है? कटी कर तो सर सीधा कॉपी कर दीजिए बाद में। ये है तेरा ऑल 3। इसका सेल मिले कि नहीं मिले? 10 साल में आपने कभी नहीं चला? क्यों नहीं चला? ये तो ठीक आया था ना। इसके बाद में क्या होगा? ठीक है। तुम्हारे सामने खोल देते क्या पता सामने ये 4 आना चाहिए और भी सेटिंग करना लगेगी कैसे चेंज होता है क्या करें
कहाँ पर हो आप? Light on करो, light on करो, light on करो। बेटे आप आगे आ जाओ, come on this front side, come। अभिलाषी यूनिवर्सिटी वाले आगे आ जाओ, please। ये फर्स्ट एक सेकंड रो छोड़ दो, थर्ड आपको बैठ अरे चलता हूँ ये पीछे बैठ लगे मिल गया आपको हार्डी से आगे यहाँ जो हमारा भी बेटा अवार्ड में
Good morning to all of you and a warm welcome. So it's our huge pleasure to have amongst us one of the most highly elated, appreciated and honorable Professor S.K. Kulkarni. pleasure to host you, sir. I'm standing in front of you. It's my huge privilege. So, starting the event, I would like to invite our chair for the session, Dr. Milind Parle, Professor Milind Parle. Please grace the dais, sir. Dr. Milind Parle is a distinguished pharmacologist serving as a Dean, Faculty of Medical Sciences at Guru Jamdeshwar University of Science and Technology, Hisar, India. His major research interest includes neuropharmacology, behavioral pharmacology, cognition and memory disorders, phytopharmacology and autism. He has authored over 150 publications and contributed to patents, and he serves as an expert to regulatory bodies such as Pharmacy Council of India. His work definitely bridges the traditional medicine systems and the modern drug discovery. Sir, it's a pleasure to host you. So next we have our very own Professor Kanwaljit Chopra. Ma'am, please take the time. Professor Kanwaljit Chopra is a distinguished pharmacology at IPS Chandigarh. She's a professor and a former chairperson of the department. Her research spans neuropharmacology, metabolic disorders, inflammation, menopausal complication, with more than 300 publications and an H index exceeding 60. She has made huge impact in her field. Over to Professor Kanwaljit Chopra.
Thank you so much, dear Dr. Amita. So, first of all, I want to give a very warm and a hearty welcome to each one of you who has made an effort and come here to attend a very special session.
Clap for yourself.
Which has been organized to celebrate the enduring legacy of 50 years, 5 decades, 50 years of neuropsychopharmacological research in Department or University Institute of Pharmaceutical Sciences. So students, when I say enduring legacy, if you look into the literal meaning of legacy, it is, a very rich tradition or excellence that is passed on from generations to generations. So now the question comes, who has created this neuropharmacological research legacy in the department? And these 50 years, in these 50 years, the institute has produced hundreds of masters and doctorate students in this area, around 1,000 international publications in very high impact international journals, many books, one antidepressant molecule, and few patents. So again, a round of applause. So now the question comes, who is the man behind creation of this legacy? Who is that person who started from the scratch? So students, I want to tell you, those 3 labs which you look at the, where you do the experiments at the end of the corridor, none of those labs existed. And who was this person who started, who was given a clean slate? And he wrote a beautiful story on that. And that story still continues. So that gardener, he planted few seeds with his passion, with his determination, with his grit. In spite of the funds crunch, in spite of having nothing there, and today this hall is, half of this hall is full of the fruits that he, planted there. So that man is none other than a stalwart pharmacologist, Professor S.K. Kulkarni. His brilliance, his perseverance, his dedication to 4 long decades of teaching, research and mentorship in the area of neuropharmacology have created this strong legacy, and he is an esteemed teacher, a dedicated researcher, a visionary and an efficient leader under whose stewardship the Department of Pharmacology was put on the world map. So sir, it's a very rare honor, lifetime opportunity and a proud privilege to offer our salutations to you. So as you all can see from the slideshow, the awards, the accolades, endless list. You name an award which our sir hasn't got. He has been bestowed with many, many prestigious awards. And we all know that. So I will not go into the details of that, but I will really like to tell all the students that he has been ranked as the top pharmacologist of India. He is consistently ranked very high on the Stanford list of top 2% pharmacologists. Top 2% pharmacologists of the world. So one of the popular Japanese proverbs says that one day, just one day with a great teacher is better than 1,000 days of diligent study. And Professor Kulkarni has mentored hundreds of masters and PhD students, inspired them, unfolded their hidden potentials, honed their strengths, and they are occupying top positions in academia, industry, and pharmacy practice, not only in India, but all over the globe. Out of the rich diaspora of neuropharmacologists community that has been created by Professor Kulkarni, we are fortunate to have a galaxy of them here today morning, and they have made a mark in the profession, and the pharmacology department and UIPS applauds their success and is proud of each one of them. They are the guiding stars for our young pharmacology students and researchers. So now I will pass on the baton to the senior most among them, Professor Milind Parle, who has retired as head and dean, Department of Pharmaceutical Sciences from Guru Jambeshwar University of Science and Technology at Hisar. So over to you, Dr. Parle.
Thank you. Wonderful beginning. You know. I see the audience, everybody has become emotional. You know. Professor Kulkarni yesterday when having dinner, he said, let's have a bite. ये आपका हमारा सेशन
information we need to the level of most of the elements. Dr. Ashutosh, magnesium.
Thank you.
Hello.
Okay. I'm a small person, you know. I'm not visible. Okay, I think this is a good idea. तो ऐसे है विकसित भारत empowering young minds for Viksit Bharat is Chak De India. This is our session. You forget the hierarchy, seniority. You know, even Madam Kawalji Chopra I have taught in Punjab University, Chandigarh. Most of the, except for, say, my guru, Professor Kulkarni, and a very few selected senior persons, most of you are my students. So, let's have a special session. Let's enjoy this session. It's our session, and today I'm not going to tell you what is your role. You know what Shah Rukh Khan says in Chak De India? वो 70 मिनट कहता है, हमारा सेशन 80 मिनट का है। 80 मिनट 80 मिनट आज आपके पास है। ये 80 मिनट आपकी जिंदगी के लिए बहुत अहम हो सकते हैं। अब इस 80 मिनट में आपने क्या कहना है, कैसे कहना है, ये मैं आपको नहीं बताऊंगा, क्योंकि इस 80 मिनट में ये 80 मिनट आपसे कोई नहीं छीन सकता, खुदा भी नहीं छीन सकता। अब ये आपके हाथ में है। अब आपने मुझे बताना है कि हमने कैसे ये अच्छे 80 मिनट बिताने हैं। So let us stick to the time without wasting. I just add one or two things. जैसे परिवार में एक पिता होता है, पिता, दादा, परदादा, परदादा, और फिर पितामह. We have पितामह with us. So what we will do is, I know most of you are occupied. We have several sessions going on. जिनका immediate next session है, I change the order what is published, and I want to invite everybody here. And we will have Dr. Bobby George as the first speaker. You first introduce yourself, because we are 5 generations here. मैं यहाँ एक बच्ची प्रिया जून को देख रहा हूँ, गरिमा को देख रहा हूँ, तो huge gap, lot of change, in generation. I will not take much time. You introduce yourself first, tell to the audience who you are, how you became what you are today, and what was the role of UIPS in your life. Right, go ahead. We'll begin with Dr. Bobby George first.
Good morning, everyone. This is Bobby George. I come from the industry. Many of you are the faculties in different universities, so I'm slightly different from the rest. I have been with the Punjab University since my MPharm. I joined in 1992 for my MPharm here. So before that, as Dr. Milind said, let me introduce from where I come from. So the Reliance Life Sciences is a biotech company. We are into blood products. We're into biosimilars. We are the largest number of biosimilars approved for any one company in the world. 23 of them which are commercialized. We are now into vaccines and also slowly entering into gene therapy and blood products. So we are into a diverse area. So without taking much ado, so I did my DPharm from Manipal. The next slide, can you just, or you can give me the remote, I can operate it. You don't have presentation. So I came from Manipal here, that was 1992. So at that time, I had an aspiration of doing my pharmacology under, I knew that the best pharmacologist in India, if not the world perhaps, was and was quite determined to do it. So that's where I picked up a very good score in the GATE and came over here. At that time, Manipal, we had the Bangalore University, And the last student who had come from Manipur to join under Punjab University was someone who had come from Mysore University. So between Mysore and Bangalore University, that recognition had to happen. And that took some time. But when I came here, I was so impressed with the way Sir had carried out the entire structures, whether we were taking classes, the level of confidence he gave us, whether it was the writing skills, because I was not used to getting manuscripts out. That was the first time. And then I had quite a few publications with Sir. I also ended up writing a couple of books and book chapters, again thanks to Sir for his inspiration. We also hosted the IPC here in that was 1994. That also gave us a lot of interactions with people, getting coordinations done just like the youngsters are doing right now. And then also the kind of skills we got, whether it's the speaking skills, because we used to take classes for the masters and sometimes labs for the masters students when I was in university. Professor Kulkarni was always there. Same time Dr. Kamalji Chopra was doing a PhD. So we had a good time, and even after the time when I left the university after PhD under Sir, I joined our research foundation for 5 years in clinical research. I was in constant touch with Sir and Ma'am. I used to always make it a point to call them on Teachers' Day. So that was one thing. That's one connect. Other than that, personally, family also, we had a great connect. Because when Bombay, that's when Sir moved to, I was in Reliance from 2002, and since then I've been here. So when Sir was the director of Bombay College of Pharmacy, we used to have good interactions. I had gone and given few talks there as well. On the personal front as well, when I got married, Sir made it a point to come and wish me and my family. That was in 1996. When my daughter got married last year, Sir and I had accepted our invitation and come down to Kerala and attend her marriage. So it was a great blessing for me, and I look forward to interactions as the years go by with both Sir and Ma'am and all the faculty. So I will not take much time and leave the mic for others to speak.
Thank you very much. So, one resource person, Harna ji हमारे साथ है. He was 1 year senior to me, and there are many things, you know. One day he told me, मिलिंद पता है मेरा नाम हारना क्यों है? बताइए. He said हारना, जिंदगी में कभी नहीं हारना, इसलिए मेरा
Thank you, Doctor. Good morning to everybody. You are my most respected teacher, I joined pharmacy profession in 1972. Did my diploma in pharmacy from Punjab University. Then I served as a hospital pharmacist with the government. Resigned and came and joined the BPhil course in Punjab. And I did my M.Pharm in 1981. That period has been really very golden era for me, because I came in touch with very able, noble and kind-hearted teachers. Professor S.K. Kulkarni Sahab is one of them, whom I adore, I respect, I love. And I am always attempting to be in touch with him whenever it is possible. Today also, I really feel very honored to be present before him and talk from the stage. I have learned several things besides his teaching in the classroom, and which have always attracted me to his very calm, very composed personality, and you learn many things. Giving you a lot of things in your life. After M.Pharm, I had joined LMB Chemical Baroda in production as management trainee. Thereafter, I joined R&D when vaccine laboratories in Delhi. So R&D center was in Delhi at that time. And after working there for 5 years, I joined FDA Haryana. I joined as a drug inspector. I was posted at Hisar. And I had a opportunity to meet Professor Kulkarni Sahab whenever he visited Hisar. along with Professor Majid. I have always been looking forward to see how to do excellent work with the free administrator. And he's one of the inspiration for this purpose to be. I served in the drug department up to 2011, and I retired as assistant state doctor in June 2011. Then I joined industry again and served for some time as a technical director there. And thereafter, I entered into law. I did my LLB and entered into practice as law. All these years, I always travel wherever I have been. I go to deliver lectures in several places, and currently Central Drugs Control Organization from India is taking around 14 drugs to give training to the regulators. And everywhere what I tell is that you must remain in touch with your teachers, because they have updated themselves in the profession, and they are the source of knowledge and latest solutions. I have kept it along and have been very much benefited, and especially to my alma mater, which has given me so much today. And today, I really thank him from my core of heart that whatever I have today is because of him, as well as teachers like him in this university and wherever I am. I advise to the young professors that they should revise whatever they can by being in proximity. You can read the research papers at various sites, but the proximity of good teachers is a really blessing of God, and I am one of them who has been blessed. Thank you.
देखो जनरेशन जब चेंज है ना, आज हर कोई अपने घर में अकेला है, अपनों को अपने घर में ही ढूंढ रहा है। अपनों से प्यार तो बहुत दूर की बात, अपनों का साथ मिल जाए यही बड़ी बात है। We invite now, we have another Milind with us. Milind Zo, he is the CEO. Please come on.
Good morning, everybody. I am the other Milind from the department under Dr. IPSCON in 1982. It was so confusing to the people here that they called us Parle Milind and Joe Milind, thinking that Milind is the surname. There is a lump in my throat, so probably I am going to read it from you. Let us start again. Good morning, all distinguished guests, respected faculty, researchers, industry leaders, and dear students, past and present. It is my profound honor to stand before you in this moment dedicated to celebrating a man whose influence has quietly shaped the trajectory of pharmacology education and research for his students for more than 45 years. My informed thesis guide, Dr. Srinivas K. Today, as part of this felicitation ceremony, I want to share not only what he has accomplished, which everybody of us is aware of, but what he has built generations of scientists to carry his values, his rigor, and his way of thinking into research laboratories, hospitals, universities, and companies across the world. When we speak of scientists, we often speak about their publications, their discoveries, and their awards. But today, I want to speak about something even more enduring, the human impact of a teacher. Allow me to introduce myself before I embark on it. I am Milind Jo, a former MPharm pharmacology student under Dr. S.K. Kulkarni way back in 1982. I worked on facilitation of diazepam action in picrotoxin-induced convulsions and involvement of GABA receptor complex. After completing my MPharm, I worked as a lecturer for 1 year in my native place Solapur, in College of Pharmacy, and then I joined Glaxo, my first law before the second law of pharmacology began. So I joined Glaxo in production in their Nasik plant. The task was to set up the factory from scratch. It was under construction when I joined. In 1983, good manufacturing practices or GMP was in its infancy. And like an infant, it had many names. One of the most popular names was gross manipulation practices. We had to change the mindset, and here what I imbibed from Dr. Kulkarni came to my head. I was the team leader, and along with 2 more MPharms, we embarked on the task of making the factory fully GMP compliant. And in 1.5 years, we accomplished that, both on the hardware side as well as on the software side. When we say hardware, it is the facility and the equipment and systems there. That is easier, because once it is set correctly, it remains like that, like your home washing machine. It runs on uninterrupted for years. But it is the software part, the people who are the most notorious variables, and the procedures. People have to be trained to follow the procedures, which first have to be created and installed, verified, and then that verified material is given to the people. But every day people change. When they come from home, बीवी के साथ झगड़ा हुआ या husband के साथ. So that spills over into your work. But that is not supposed to happen, because there is patient at the end of the line, and for whom we are doing all this. So that had to be instilled into the minds of the staff. And to do that, we started Journal Club, sir. So again, one legacy, I took it from here and used it in GSK. In Journal Club, we took topics one at a time, and for 1 hour, all the relevant staff and the management, because to do anything of this kind, you need management support. So management was part of the audience, and then we had a Q&A session, and I was taking the notes, which were then implemented into our daily activities. After spending 12 years in Nasik, I moved to Glaxo, Saudi Arabia, where another new plant was being set, and they thought it fit for me to lead the team there and do likewise. And in 1 year, we again set up the facility and made it running smoothly. Then I came back in 2002 and started my own consultancy, first as part of another company for 10 years, and then our own company for 5 years in partnership. Then my own company, all on my own. And in those last 22 years, we have updated nearly 60 facilities across the world, including India, Morocco, Bangladesh, and most of them are either USFDA approved or USFDA approved. When I first joined Sir's lab, I was a product of our marks-driven education system. I had crammed so many things without truly understanding them. Sir took upon him as the task of sorting me out, separating the chaff from the wheat, as the very first step towards unlearning. A teacher gives you what you need. A guru, on the other hand, takes away what is not needed. Our journal club was one such crucible where ideas were subjected to the fire of questioning, and whatever was not required melted away, leaving behind the true part of the speck of knowledge. He supported us in every possible way when I needed access to international journals for my thesis, he arranged for the access to the PGI library. And of course, he encouraged us to balance work with recreation. After all, one does need a break after long, demanding days in the lab, and he understood that perfectly. He, even in his retirement, is always in touch with his students and ready to help them in whatever issues they face. This is the hallmark of a true guru, that is Dr. S.K. Kulkarni, a guru personified. I am so blessed to have been under his tutelage. Thank you very much, sir.
In Maharashtra, we write father's name in between. So we had issues. Yes, next session, resource person. Has Dr. Naveen Jain arrived? Yeah, Dr. Yeah.
Thank you. So good morning, and thank you, Milan. And it is a great privilege to memorize all my academic journey under the esteemed direction of the Professor Kulkarni. So first, I just wanted to salute the Professor Kulkarni. Whenever I just wanted to start some background. Whenever we buy apartment and a plot, we always need some architect. So I'm blessed that he is my architect to design my career. So just to introduce, I'm Dr. Naveen. I did my M.Pharm and PhD from the Punjab University. So I graduated in the 2003. So you can say I'm the Gen Z. And so my academic journey, next slide. My academic journey here started in year of 1996, and I did M.Pharm under Professor Kulkarni, and it was great to say that I was gold medalist here. Then I continued my education here in the PhD under Professor Kulkarni, and I explored the pain in inflammatory pathways by the COX-2 enzyme in his direction, and published a lot of molecular pathway mechanistic papers in the good research journals. Then I moved on and pursued the postdoctorate in the same area in the COX-2 research, and did my postdoctorate at UCLA, Los Angeles. And so my achievement is there. I am the translational pharmacologist, currently working with the Venetia Biotech. So I work with how the mechanistic product can be converted into the real product. So I am happy that several products are in the phase trials right now, and a lot of products, at least 3-4 products have been already commercialized, including several pediatric vaccines and the pile medications. The pile medication was discovered at the Punjab University, and Professor Kulkarni was the architect for the transferring that technology to our company. Yeah, next slide. So I have in the morning time, I got a time in the train, and I written some dedicated words from my deep insights. Yeah, what is the greatest contribution of Professor Kulkarni to me and to the several students? So Professor Kulkarni is a quadrant expert. Mastering the theoretical classroom teaching, that is a cultivation of the talent. So we are seeing here the fruits. So he is the master in the cultivation of the talent. Then exploratory laboratory research, that practical marketplace, industry collaboration, and the critical bridge of the innovation diffusion, that is the know-how and the technology transfer. In his time, in the research time, the several industry collaborations happened, and several students have done the PhD and the M.Pharm under the industry collaboration. Either it was Himalaya, Felicia, Dabur, or the several other companies, Labs. And I owe a significant part of my current career success to the time I spent in your classroom teaching and your guidance, sir. Your commitment to every student, coupled with your genuinely inspirational and visionary approach to research, set a standard for me that I carry forward every day. Next slide. So there are the three takeaways from in my life. That is the visionary approach from the Kulkarni, sir, and intellectual rigor and compassionate support. These three continuous blessings from this sir was able to design my career at the level of where I am. Thank you, sir, and thank you very much. And I wish for always your good health and continuous blessing to all the students, not me, to every student. Thank you, sir.
Thank you. Thank you, Dr. Naveen. You know, there's a law of harvest. When you sow a seed, you get a big tree, flowers, fruits, and many seeds. Same is to with action. Karmic philosophy. This is the legacy. You sow a good action, you nurture one student, and his entire life is transformed, and he further transforms lives of many. I tell you, just, be grateful to the universe where we are. Be grateful to those people who have nurtured you, and your all stress would be over. Whatever you do in life comes back to you. It comes back multifold with interest. So do good things. Vice versa. You try. I'll tell you with my life's experience. I had colleagues, हर डिपार्टमेंट में कोई ना कोई राजनीति पॉलिटिक्स होती है. It speaks on your physiology. It speaks on your health. We have an autonomic nervous system working in opposite directions. If you are positive, you get positive fruits. If you are negative, so some such friends, colleagues, seniors, either they are bedridden, crippled, or no more on this planet. So learn from the experience of seniors. Do good things. Be supportive. Be helpful. Look at the nature and be like nature. May I call? Yes, please. Yes. Okay, fine.
My name is Professor Ishaq. I'm from Srinagar, JNK. I was just attending a session in Hall 1 when I read this schedule, and I got to know that there's a session going on here to honor and regard Professor S.K. Kulkarni, sir. So it just came to my mind that I would like to know, all looking at the heartening, the presentation on the regards and respects by his scholars and students. I was wondering that there are so many lakhs of people, students of pharmacy, who have never met physically Professor S.K. Kulkarni like me.
Very true. See, you all are privileged. So,
I'm meeting you for the first time, but you have been living with me for the last 35 years. Right from the time when I joined BPharm way back in 91, that small booklet of experimental pharmacology has been my guide till today. And that is the case with lakhs of students all across India. Every day, there is hardly any day when I do not open that booklet written by Professor Kulkarni and guide my students on experimental pharmacology, notwithstanding his immense contributions in research in neuropsychopharmacology, that of course is known to all, and for that his own students are paying regards and bestowing their respects to him. But I would like to thank him on behalf of the lakhs of students all across, teachers all across India who have been benefiting. And I told him yesterday that till today there is no parallel to that small booklet. So many have been written by so many authors. But trust me, till today we haven't found a parallel to that small booklet written by Professor Kulkarni. Thank you very much for coming.
Thank you, Dr. for adding. I want to give opportunity to each one to speak, but we are shortage of time. I call you. There is something in my mind. Just to tell you the history, मैंने किताब की बात छेड़ी है, experimental pharmacology. So I will not take much time. It was only in Punjab University, Chandigarh, where experiments in vitro, in vivo, in animals were carried out. When I joined at MPharm, my senior was Dr. Ashok Mehta, very senior. 24/7 he was working, passionate in pharmacology. एक दिन कुलकर्णी साहब आए लैब में और कहते हैं अशोक, his name was Ashok, I was also there, Milind, whatever experiments we are doing here, why not publish a book? Why not write in the book? So you look into the preface of the book of experimental pharmacology. I was privileged, my name and Ashok Mehta's name is there. The experiments which you wish to write in the practical book, aim, apparatus, procedure, diagram, observation table, all that we wrote. There were no computers, we used to type on typewriter. I learned typing. Professor Kulkarni had a typewriter of his own. You will not believe those days how we did it. एक गलती हो जाती थी, पूरा पेज फाड़ के मेमोरी होती नहीं थी, दोबारा टाइप करना पड़ता था. But I will not take much time. Dr. Mahendra Vishnavi, please. वो जमाना बिल्कुल अलग था. This generation cannot imagine the kind of संघर्ष, struggle we have taken, in those days.
Okay. Yeah. So good morning, everyone. It's working. So I am third generation, I suppose. Okay. So again, Gen Z. So I passed out my PhD with Kulkarni sir in year 2004. Just to introduce myself, I am Chandrasekhar Patil, so I belong from Maharashtra, Kolhapur. And presently I am working with Panesha Biotech, in the field of pharmacology, toxicology and medical affairs. So that is a key department which right now I am handling with Panesha Biotech. So, respected Kulkarni sir, madam, Kawaljit ma'am, my seniors, and I can see my colleagues who were pursuing MPharm PhD doing, I can see Amita, Nilima and all. So it's really a great honor to have you all. And it is really a great privilege for me to speak about Kulkarni sir. So he has been guiding me and I've been in touch with him since long time. So I joined pharmacy, M-Pharmacy from in 1997 after completing my graduation from Government College of Pharmacy, Karad. So if I recollect those days, of course those days the pharmacology what we used to study and what the curriculum which used to be there at Punjab University, it was totally different. So actually I should say whatever pharmacology I have learned is after MPharm, during the MPharm and the PhD, because the curriculum which was designed here was totally different from one which we used to study. So talking about my professional experience, so I started my career after completing my MPharm. I started my career with academics, and then I shifted to the Nicholas Piramal, and then I got the opportunity to join Panesha Biotech. And I was one of the few luckiest students who got a PhD with Professor Kulkarni under the Industry Institute Partnership Program. So basically it was a collaborative work between the company and the Punjab University, and I happened to learn lots and lots of diversified experimentations during that my 4-year tenure. So that was a 3-year tenure, that was from 2001 to 2004. So either it was a neuropsychopharmacology or inflammation, pain, diabetes or herbal pharmacology. So those were the diversified experience which I got during those 3 years of Industry Institute, under the Industry Institute Partnership Program. So my topic basically was on the sildenafil. So you know what the sildenafil is basically. So whenever you talk sildenafil, you feel that it's something, but we work on the other indications of sildenafil, and we published many publications. So either it is a PD5 inhibitor, so we concentrated on the either pain pathways, neurological disorders, then in the diabetic condition. So those were the key researches which we pursued, and even now if you see multiple publications which are coming on the PDE5 inhibitors, they are targeting these therapeutic segments, right? So talking about the Industry Institute program, so Dr. Naveen just mentioned regarding the molecule, the Euphorbia prostata, which we developed. So which has been commercialized now. It is by the brand name Sitcom. That is, it is indicated for hemorrhoids. So hemorrhoids, the condition wherein there is a bile mass. So every person with hemorrhoids always finds it discomfort while sitting. So we gave a brand name as Sitcom so that the person can sit comfortably, right? So it was a Euphorbia prostata, which was a molecule which was developed here under the supervision of Professor Kulkarni only. So I, Dr. Naveen and Sir were the key person who did extensive pharmacological study during that period. That was from 1998 till 2004. And we launched this product after completing the clinical trial in 2011. Now this product has been commercialized. It is commercialized across the world. It is present in African countries, Asian countries, and many other developing countries. So this molecule, actually, I always, I even take the medical training for the international sales force also. So during a monthly training, I always narrate this experience regarding how the molecule was developed, how it was screened, and how it was marketed. So further to talk about, yes, Kulkarni sir, it is real my pleasure to be associated with you, and I thank you for the opportunity. And Kulkarni madam, yes, I'll never forget you for your always good wishes and the South Indian food which we used to enjoy during our college. Thank you madam, thanks a lot.
Thank you, Chandrasekhar. We have another Chandrasekhar, you know, he's in New Jersey today. Very close to our family. And he wanted to make it to this event. He is watching it on YouTube. There are some good news. Let him declare himself, you know, for the young B.Pharm and M.Pharm students. He has sent his video message. So, आप ध्यान से सारे ये वीडियो मैसेज सिर्फ 2 मिनट का है, जरूर सुन लेना, जरूर. He is a pharmacist there, and he had to struggle, you know, in his life right from his childhood. So let him, like, you can put on.
Namaskar, madam, and warm hello to the distinguished audience of Indian Pharmacological Society. I am Chandrasekhar Deshpande, pass out of 1996 from Punjab University under Professor Kulkarni. It is indeed an honor for me today to speak in front of this august gathering of my teachers, including Professor Kawaljeet Chopra, my colleague and chairman, Professor Anil Kumar, who helped me establish this award, and my super senior, Professor Milind Parai, the mastermind behind this felicitation. But most importantly, it is indeed a profound honor of my life to speak about the person who helped shape the very core of who I am today, my revered teacher, Professor Srinivas Krishna Kulkarni. Today, all of you might see me speaking freely and fluently, but the truth is, there was a time when I struggled deeply with stammering. As a stammerer, my childhood was a long corridor of humiliations and despair. Even the simple act of saying President Sir or President Madam was a difficult task. And then one day, Sir, I met you. You did not tell me to be confident or to be positive. You did not rush me. Instead, in fact, you never really tried to fix me as you find some kind of problem. Instead, you simply said, go out and look at the sky. Those words changed everything. You taught me to stop staring at what I couldn't do and to look up at what I could become. You helped me see that life is bigger than some of all my dreams and that my possibilities were always wider than my limitations. Your monthly journal club sessions were not just an academic exercise. They became my training ground for courage. Courage to speak. Sir, I have rarely encountered wisdom as deep as yours. I still remember that quiet evening when I confided in you about my struggle with study. You didn't just offer advice, you gently reminded me that clarity of mind is far more powerful than the speed of my words, and that true clarity can only be found when we discover our purpose in life. That deep insight became the compass and the guiding star of my journey. And today, here I am, managing my own community pharmacy practice in the state of New Jersey, serving thousands of patients and striving every day to make a difference in their lives and in the lives of people around me. That purpose, the purpose of care, has become the heartbeat of my work and the meaning of my life. Sir, to honor your remarkable legacy, we are instituting a special award in your name to celebrate your pioneering contribution in establishing the Pharmacology department at University Institute of Pharmaceutical Sciences at PU. Your dedication, vision, and unwavering commitment laid the academic and ethical foundations that will continue to guide generations of students and researchers at UIPS. This award will recognize individuals who embody your spirit of curiosity, discipline, and consistency. But this award is not merely a gesture or token of recognition. It is a living tribute to a teacher who didn't just teach pharmacology, but taught life. It is a tribute to gentle and profound ways who shaped the lives of countless students, including you. It's also a tribute to Madam, your better half, for her generosity, warmth, and kindness. Her constant support allowed you to give so much to so many. Sir, thank you. Thank you for seeing me when I couldn't see myself. Thank you for believing in me when I doubted myself. Thank you for helping me see beyond the baggage of my own struggles and for giving me the most precious gift of all, my voice, not just in speech, but in self-belief. I know that you can do that. Some days are too simple to say. Sir, I'm moving to the same way. And whenever life becomes easy and difficult, I close my eyes and there you are, whispering in my heart, go out and look at the sky. Thank you, please.
Shekhar, our eyes have been swelled up. You have echoed the sentiments of almost all of us. And as a teacher, what a great responsibility we have. We have many young teachers sitting here. Such is the profound impact of a teacher on one life. We really have a lot to imbibe and lots of responsibility on us. Thank you, Shekhar, for instituting this award, and we can he has instituted an award to honor 2 best graduate students and 2 best postgraduate students. So the graduate students will be awarded on the basis of top marks in pharmacology and allied subjects, right from first semester to 7th semester. And post-graduation mein, if all the pharmacology topper, 1 male, 1 female. So he has instituted 4 awards in honor of his teacher. So we can. I'll request sir and ma'am to please come and present the awards to the to this year awardees.
Good morning to all of you. Good morning to all of you. I think you all of you made emotional, everyone here. I did many things in this university which was unusual. That's how things are, everybody is remembering. I know we admitted Naveen Jain without getting his final year marks card for B.Pharm examinations. So there was a rule here that when you apply for M.Pharm admission, you should have final year marks card. He was a graduate from Rajasthan University. For some reason, they didn't have a final year mark sheet at the time of admission. So the admission committee disqualified him and his 2 other classmates. I said I will take an understanding from them. If they don't pass in the final year, we'll cancel their admission. So I admitted all the 3 of them. I'm very happy to see that all of them are industry leaders today. So they got. There was another girl, very shy girl, Gurpreet Kaur. She's in Germany now. Whenever she used to cross my room, she would ask other person on the other side, "Sir, hai kya kamre mein?" She was so scared, and not scared. She was, kind of a respect. And one day she came to my house. And unfortunately, her mother was on deathbed. She had cancer. They used to live in 47th sector. And she was in 2nd year of her PhD program. So she said, "Sir, मम्मी से मिलाना है आपको, घर चलिए." तो हम, myself and my wife went to their house in 47th sector. Her mother was on the really, after our visit 3-4 days later, she passed away. She was so happy to see me, and she asked me, "Give me a promise," she said. I said, "You ask what do you want me to do?" She said, "You send Gurpreet," Punjabi mein bola unhone, "You send Gurpreet abroad." So I said, "No problem, she will anyway go abroad." She, after completing her PhD program, she got a postdoctoral fellows. Most of the people who are working in our department, everybody got a PDF and they went abroad. She went to USA. There she met her life partner and they got married. She was married to a South Indian, and they are settled in Germany. And there are so many such small incidences which make a teacher different than the other teacher. So when I started teaching here, I'll take 2 minutes. The department was a classical department, so they had a traditional practices because the then head of the department, Professor Harkishan Singh, was a strict disciplinarian. He was a graduate from Punjab University, but he had all his education from Banaras Hindu University, so he had the traits of all Banaras practices. He was very strict. So the day I came to join here, if I say this, nobody would believe. I didn't have an appointment letter, a conventional appointment letter from the university. I flew in from US. Next day I came over here. My wife went back to her parents' place. And I joined here next day morning. I met Dr. Harkishan Singh at his residence in Sector 25. He used to live in F27. So on घर गया तो I had lunch with him, and he called Bhushan. Bhushan used to be office superintendent. So they had a room for me in the university guest house. I stayed there. Dr. Singh told me tomorrow morning 9 o'clock sharp in the department. So he was very particular about timings. So I came here at 9 o'clock. As soon as he used to come to office, he would wear apron, white coat, and he took me around the department. Come on in, Dr. Palit. And he showed me the entire department, and that made one room ready for me, room number 9, where I spent next 32 years. Even today it is in my name only because I am an emeritus professor. And there was nothing else. So they used to, in those days, B Pharm was 3 years course. आपके टाइम में 3 साल? हाँ, 3 साल का course था. I settled down in my room. They had kept one chair and one table, nothing else. So my be looking here and there, and then the office superintendent came. He said, "Sir, class लेंगे आप करके?" No, that was my first day. मैंने बोला why not? So he said, 1 बजे क्लास मुझे ना एक फार्माकोलॉजी क्लास होता था between 1:30 and 2:30. Unusually, there was a reason why it used to be between 1:30 and 2:30. I went to the class. In those days, only 15 students used to be in B Pharm. 12 boys and 3 girls. There was a reservation for girls. Nowadays it is a reverse way. There is a reservation for the boys. So, and Harna was in my first class. Rajinder, Harna, and Ashok, and there was one or two foreign students. So we used to have foreign students also nominated by the Minister of External Affairs. So they were also there. And I just introduced myself and talked to them. And after the class, I came to my room, and all of them came after me, and they said they had a lot of grievances to share with me. I said, let me settle down, and then I solve the issues of yours. And yesterday, somebody was asking me, I was telling Milan Joe, it takes about, Punjab University, the system is well in place. I don't know what it is now. So in those days, if you want to do anything, you have to, Dr. Singh told me one day in the beginning, if you want to do anything here, Dr. Kulkarni, you have to start working 2 years in advance. The system is like that. You have to put on the agenda, and then it will go to Board of Studies, then go to Academic Council, then go to faculty. In those days, Faculty of Pharmacy was not there. We were under the Faculty of Medical Sciences, and then it would be approved by the syndicate and senate, and it will take about, it's a 1-year whole program. And after a few weeks, I told Dr. Harkishan Singh, teaching, you have called me from USA, teaching undergraduate is it's not the only thing I have come for. We should start postgraduate course, then I will get some students for research also. And he was a visionary, he agreed. But he said, I don't have any approval. I said, in those days, university में 4-5 senior professors हुआ करते थे who used to guide the vice chancellors. and he said, let's start doing it. So this was in the month of February or March, and next June we wanted to admit the students. I prepared the curriculum and gave it to him, and he told me this curriculum is not approved by the university. How will you conduct the exam? I said, sir, you approve it, rest you leave it to me. So we taught Ashok Mehta, and I don't know whether both the Milan had the same curriculum or not. So we taught them, and then Dr. Singh said, we have not appointed any examiners because the appointment of examiners in this university, it takes about 1 year. You have to approve the list of examiners in the month of October to have examiners next March or April. So we have admitted the students and we have started teaching, and Dr. Singh told me, how will you do it? I said, you don't worry, sir, we will do it. So after the end of the year, I suggested him the name of the examiners. So he said, we don't know them, we don't have them on the panel. Will they agree to conduct the exam? I said, that will happen. And it did happen. After that, we got them all approved, and started the course started regular, and over a period of time we changed curriculum quite often. As things changed, every year we used to get the curriculum updated. The organizing secretary has arrived. So thank you very much. What is more important is do something different than what everybody does. Then only you will find, you will search for the new pathways and get an answer to that. Thank you very much.
For B-Farm, we have Aditi as the awardee this year. Aditi. Yes.
She is the first winner of Professor Kulkarni Award. Sir, the donor has especially made a request that award should be given by the hand of Professor Kulkarni.
So we will next year get the approval. This is the first time it is good to all the best to you. I need to do M.Pharm in pharmacology.
Next Kunal.
Kunal as best B-Farm student.
He also gets cash award, rupees 10,000.
सही बात है. नहीं, plus frame certificate also there.
For M.Pharm, we have Nishika Kapoor. Out of all the awardees, if anybody, we just want to hear one line from all the awardees, if you want to, because we really want Dr. Shekhar to know about it. And if you want to say something?
Good morning, everyone. Today I feel deeply honored and grateful having received this award from Sir. UIPS has shaped me into a person more confident, curious, and committed to learning. I owe a large part of this journey to my mentor and guide, Professor Kanwaljit Chopra. It has been a privilege to learn from someone who carries forward the legacy of Professor Kulkarni himself, the person who set the foundations of pharmacology at UIPS. I owe to live up to this recognition and carry forward this legacy with integrity. Thank you.
So we have two more official speakers left out, and in case we are running out of time, we have tea session. We all can discuss with Professor Kulkarni. He is with us tomorrow also. So Dr. Mahendra Bishnoi. You have to be brief, please.
Hello. Yeah, I'm kind of getting emotional. So, respected sir, ma'am, and Professor Kanwaljit, Professor Parle, all the teachers here and students. So, I am through and through UIPS. So, whatever I am today, it's because of UIPS, and the major role is from Sir and also Dr. Kanwaljit also. So I am a faculty, a scientist and group leader at one of the DBT institutes in Mohali. So I am still privileged to be associated with UIPS in some form or another. I have collaborations, I have students working in UIPS, and every time when Sir is around, I have this also privilege that I can come and meet him every time, and ma'am also. So when we are talking about shaping our careers, most of you have spoken already, and that echoes what I feel. but sir, you started shaping mine before I met you even. So I was doing B Pharm at GJU, where Professor Parle was a professor, and I had an interest in pharmacology per se. And then during the 4th year, it was like, if you want to do pharmacology, you want to make a career in pharmacology, you should be at UIPS Punjab University. So, and why at Punjab University? Because there is a professor, Professor S.K. Kulkarni, whosoever works with him go abroad. So, it was like such a passion of that thing that I have to work in pharmacology and I have to do PhD with sir. And luckily, we got higher ranks in our GATE examination and we could get admission with sir. And so it started like, I will tell you a couple of incidences that might inspire you. When we joined MPharm, we were 5 students. Sangeeta is here, she was my classmate. And Anurag is also now faculty at UIPS. He was also my classmate, and a couple of more, Ashish and Abhinandan. Sir might remember all of them, I don't know. So we 5, so whenever we have class, it has to happen in sir's room. And we have to go to his room with our stools. He will sit on his chair, we will sit in front of him, and then he had a projector. Nowadays, I don't know whether new students know about it or not. You have to make slides on those transparent sheets and OHP sheets, and sir had so many slides. Every class will be almost 1.5 and 2 hours. Every topic will have so many slides. It's kind, you can say Goodman and Gilman on your slides. And it was so much, and we were so, it was so kind of overwhelming when we come out of the class, 2 hours, but it was such an experience. It was like, you could see the passion of teaching, passion of making you learn, passion of making you better. And in a way, that helped a lot, and we could learn a lot from those classes, and even practicals also. Those practicals were also really kind of very seriously done. What I would say, we will come at 8 o'clock, go back at 6 o'clock, and this was almost every time. And after first year, I will just narrate an incident which was also, after first year, we used to have this guide allocation. So everybody will go to sir's room, and then sir is there, ma'am is there, and at that time, it was first time they were deciding that Professor Anil Kumar will also have a student. Okay, so everybody was so scared. Sangeeta will also accept this. Everybody was so scared that who will go to Dr. Anil Kumar? No offense to sir if he is around, but it was like that because he was starting a very junior faculty, and then we were like, okay. So we were all so scared that, okay, who will go there? And it was a lottery system, and I was the one who got Professor Anil Kumar. At that time, he was assistant professor. So I was like, okay. I was dreaming of something else. Now I'm reaching somewhere else. So I was depressed. I can smile and tell these stories now, but I was not happy at that moment. And then next morning, I went to sir. And I was like, sir, I want to do it with you. And that's what I said to him. I don't know whether sir remember it or not at the moment, but I was like, sir, I have to do it with you. And sir just said to me, it's okay, you will work with me only, but there is a procedure and all this, we have to follow this. And but then sir took it in a very positive way, and then sir took me under his mentorship. He said that I will be guide, Anil will be co-guide, and then he made me work with Dr. Patil. He is also there. We worked on one of these Panacea's product, boswellic acid, and I did MPharm with that. And then I also did PhD with sir, 2005 to 2008. So you can say I'm the youngest one of the lot here. And because of the PhD and all, I got good postdocs, and now I have a good job. And there are two things which I learned from sir, which is helping me still to date in my now in my academic career more. One is you have to set an example. It's not, you cannot not do and preach. You have to set an example. If you want your students to come at 8 o'clock or 9 o'clock, first you have to come at 8 o'clock and then show them that you work hard, so that they just follow you and people will follow you. That's what sir did always. That's how we followed him, and that's how I try to do, and hopefully my students do follow those things. And another thing which was most important was you can finish your PhD in 3 years. When from my colleagues and everywhere, when I hear that their PhD was 6 years, 7 years, 8 years, and they were not happy, and even they are saying that, okay, PhD cannot happen before 5 or 6 years. Our student has to work for 5 or 6. I said, I don't have such experience. I did it in 3 years. I want my students to go away in 3 years. They have their life ahead. They should have time to go and make their lives. I cannot keep them here for 6. So I try to push all my students to finish their PhDs in 3 years, 3.5 years at the max. And I can see Pragyanshu is right here. So he finished 3 years, and so these are some of the learnings which I took from sir, and I am following it till date. And thank you very much, sir, for everything what you have given.
When I started teaching here, I was the only teacher in pharmacology teaching all the 3 papers. So it was so difficult to take classes. We started doing seminars. So seminars, we distribute topics and ask the students to prepare and speak. So बाकी sections में classes होते थे. जब हमारे यहाँ सेमिनार होते थे, बाकी students आके विंडोज में देखते थे क्या करते थे. It was so funny, and we told them, you come inside and think you will learn also how to prepare overhead slide transparency for overhead projection and all. So that has big, in the department.
At the onset, to remember sir and ma'am, I would like to express my gratitude that whatever I am today, it's because of your blessings and your teachings. I joined sir's lab, I think, in '93 during M.Pharm, and I did my B.Pharm from a private institute in Maharashtra by paying donation. I don't even mind saying that. So, but when I came here, the totally different environment was there. And at that time, sir was there, and Dr. Manjeet Singh was another teacher to us. And as Mahendra Bishnoi told that he got Dr. Anil Kumar as his guide, we were having other way. Dr. Manjeet Singh left in '94, January, and we all 3 students were with sir at that time. So that way we were lucky. So we don't have to, worry about those things. So that's why we were having, the luck was with us, and we heard that. And regarding learning the things, I think the life of sir is giving many learnings to us. We followed some of the things. We were not able to follow everything, sir. But whatever we have followed, we achieved a lot with that. One thing is his punctuality. 8:30 he is in the department, 5:30 he will be leaving, 1:30 he will be going for lunch, and that is the fixed time. And you can match your watches with his, you can schedule. If you want to know the time, you can watch, you can set the watch. Okay, so he is going for lunch, it is 1:30, he is leaving the department, it's 5:30, leaves the department, it's 8:30. So even he used to come on the Saturdays at that time. Saturdays he was also available most of the time, half day at least he was available with us. Similar things we followed, sir, and we think the work efficacy increases with that when we are punctual. And our students are also following us, and they are doing good job in the lab if we are punctual and we are sincere to the things. Thank you, sir. Yeah.
One minute, Samir and Sita. Just 1 minute. The next 2-3 minutes only. We have a next session. I will take to the time.
I will be brief only. Okay. Respected sir, all the eminent teachers, Kulkarni sir, madam, Professor Parle sir, Professor Kamalji Chopra madam, so and all the delegates, all the faculty members. So very good morning to all of you. So here I am. I'm highly thankful to Professor Parle sir, Professor Nil Kumar, the organizing secretary of the IPS conference, for inviting me for this session, for expressing my deep sense of gratitude to Professor Sir. So first of all, many congratulations, sir. Many congrats for being Lifetime Achievement Award. That is honored by the IPS. That is the well-deserved award. That should be there. So he is a very eminent teacher and distinguished researcher. And I was looking that in 2020, as the madam said, Professor Chopra madam, that he was identified by the Stanford University, USA, as rank 1 pharmacologist of India with global ranking of 132. So I am very lucky to be a student of such a great pharmacologist. So I did my B.Pharm from UIPS in 1991 and my M.Pharm in pharmacology in 1993. And after that, presently I am working at Guru Jameshwar University, Hisar, since 1997. And I got registered with Sir Professor Kulkarni sir for my PhD degree and Professor Parle sir as my main supervisor, Kulkarni sir as co-supervisor, that in 2002. And I completed my PhD in 2005. So after that I am continuing there as a professor. I will tell you some, as the others said, Kulkarni sir has very good qualities as a role model teacher. He used to motivate me and as well as other students. He is a very kind person, very supportive to students. I was highly impressed by his impactful research in neuropsychopharmacology. So he has so much international credibility of research that being his co-author is sufficient for publishing a research paper in reputed international journals. His research work has been cited in reputed books of pharmacology in, I think, Vogel's Drug Discovery and Evaluation, also in Goodman-Gilman's Pharmacology. That is published by international publishers. I tell you one incident about when I was doing PhD. So when he published first research paper under his able guidance, I came to Punjab University to show him the published research paper because I did my experimental work at Hisar only. So he was very impressed and motivated me for doing good research work. So when my PhD thesis was ready for submission, I rang him and he very kindly invited me the next day for giving his final inputs for incorporating in the thesis. So when the thesis was printed, I again rang him and invited me at his residence and congratulated me and gave his best wishes for timely completion of PhD research work. So I remember I had delicious lunch at his residence. I think it was holiday in Punjab University, so it was Saturday. So I am thankful to Kulkarni madam for her nice hospitality. So one more, I want to share. So a few days back, when I received that I have to speak in this session. So I was looking at his Google Scholar citations and observed that my research paper published during PhD under the guidance of Professor Kulkarni sir and Professor Milind Parle sir, has received the highest Google citation. So this is the first research paper. And, so that is among all the research paper of Kulkarni sir. I think there are first 4 review articles and is the first research paper. That is on memory enhancing activity of Glycyrrhizia glabra in mice. That is published in Journal of Pharmacology. So I am really very lucky to learn research skill under his able guidance. So I am trying to follow footprints of Professor Kulkarni sir for doing good research work and academic justification to the best of my abilities. So I am continuing my research work in the area of neuropsychopharmacology. Okay. Thank you, sir. I again express my deep sense of gratitude and thankful to Professor Kulkarni sir. Thank you very much.
From your seats only, you get the mic. 1 minute each. That's all. We are already used tea time also. Yeah, 1 minute.
First of all, thanks for organizing, giving me an opportunity to speak about Professor Kulkarni sir and madam. And in fact, my journey starts with Kulkarni sir from 2015. Okay, before that, Professor G said that all of us, like you Indian pharmacy students, we were great admirers of him. And in fact, when I was doing my PhD under Professor Parle sir, that time I got to hear about the Kulkarni sir. And when I joined the, in 2015, I was working with the University of Studies as assistant professor. One day, director called me in his office and he asked me, Sunil, one of our professors is going for sabbatical leave from pharmacology. Do you know somebody in India, great pharmacologist who can visit to our country? And when he said great pharmacologist from India, the first thing came to my mind is Professor Kulkarni sir. And then in second moment I thought, whether Professor Kulkarni, I speak to him, he will be agree to visit. That was the question in my mind. Then I thought, let me give it a chance. Let me speak to him tonight. And I told my director, okay, next day morning sir, I will come. That day night I told Kulkarni sir and I insisted in my questions of the University of Studies sir. I told him and he was already aware. And sir, there is an opportunity for 6 months if it is possible for you because one of the countries. He said, okay, Sunil, let me see and I'll get back to you. And within 24 hours I received an email and sir gave his consent. And this is how 2015 when we started at the University of Studies, when we get out of the residence, I took it from the residence. And that was the time when I could see both the things, professional front, morning in the office, punctuality, all those things I could see as a colleague. Morning 8:30, sir was ready. In fact, I was late 10 minutes dropping my daughter at school. And when I reached, he was waiting outside the door. I felt so embarrassed that sir is waiting on the gate and I am late on the, I have to take him to the college very first day. And that was the day for another next 6 months. Every day sir used to be at 8:30 on the gate. Then college, when students, they used to praise him a lot, his teaching and other things. My all other faculty colleagues, they got so much praise about him. Kulkarni sir, Kulkarni sir, Kulkarni sir. वो तो स्कूल ऑफ फार्मेसी में कोई दूसरा नाम ही नहीं था, honestly. और जब सर के साथ लगे तो उसके बाद इनफैक्ट वो तक तो अलग ही था कॉलेज का. Everything has been discussed on the personal front. Let me tell you, Madam Kulkarni and sir, humanity is totally a different point. And my personal note, let me tell you, when he visited, though I feel I should share it. My wife, she was almost, pregnant and she was on the due stage. Unfortunately, my mother could not eat, and that time it was the Kulkarni sir and madam who assisted us in the course.
We are already
yes, so I will put it stop here, but definitely they are the best human beings.
Samir, request.
So sorry, and Dr. Nitin, and please, आप
सिद्धार्थ, आपको अभी चाय के
please
बाद
आप
10 seconds.
Maybe stick to 10 seconds only because
10 seconds.
Sir, myself, Professor Dr. Siddharth, working as a professor in Division of Neuroscience, ISS College of Pharmacy. मैं सर के बारे में सिर्फ इतना कहना चाहूँगा, जैसे एकलव्य के लिए द्रोणाचार्य थे, वैसे मेरे लिए सर आप हैं। आपके दिए की रोशनी से थोड़ी सी लो लेकर मेरे जैसे ना जाने कितने फार्माकोलॉजिस्ट ने अपने जीवन को जगमगाया सर। आप हमेशा स्वस्थ रहे, खुश रहे और अपना आशीर्वाद हम पर बनाए रखें। थैंक यू।
प्रोफेसर मिलिंद पार्ले के साथ मैंने 2010 में की थी और उन्हीं से जो सीखा उसके तौर पे हमने आज मैं प्रोफेसर डीन और चेयरपर्सन फार्मास्यूटिकल साइंसेज चौधरी जमशेदलाल यूनिवर्सिटी भिवानी में कार्यरत हूँ सर। और उसी लेगेसी में UIPS की लेगेसी में हम PhD प्रोजेक्ट के अंदर प्रोफेसर कमल चोपड़ा के साथ 2 मेरे स्टूडेंट्स UIPS में ही काम कर रहे हैं, उसी को हमने आज तक सीखा। लास्ट में मैं इमोशनल हो रहे हैं उसमें यही कहना चाहूँगा कि टाइगर अभी जिंदा है और
जो सर के ऑरा में आ जाता है ना एक बार, बस उसी वही ट्रांसफॉर्म हो जाता है, वही चेंज हो जाता है। He has an ability to kindle the spirit of excellence. वो जगा देते हैं उसको, होती है हर एक में, लेकिन टीचर के तौर पे वो जिस तरह से जगाते हैं वो हर कोई नहीं कर सकता। एंड सो लेट अस ऑल प्लेज टुडे, rededicate ourselves to carry forward the legacy that has been created by the tiger. So let us all, now is the time to felicitate our sir and ma'am.
Already done. हिसार में जो फार्मेसी डिपार्टमेंट खुला है ना, I was responsible for opening the pharmacy in Hisar. Haryana, Punjab and Jammu Kashmir to start technical courses, and we had 5 members. Our head of the member was from UDCT का chairman थी, a lady from Mumbai University. We had gone to Kurukshetra University to start pharmacy. उन्होंने बोला we have got an extension center in Hisar, we go and see there. If they want, we can start pharmacy. Then we had gone there, and then they wanted 2 courses, one in pharmacy, another in textile technology है क्या? Printing technology. 2 courses हमने recommend किया, दोनों उन्होंने sanction कर दिया। उसके बाद में आपके यहाँ हरियाणा में मिनिस्टर बदल गया, तो जाते जाते जो चीफ मिनिस्टर था वो फ्रॉम जींद का थे, कहाँ से थे? भजनलाल। यूनिवर्सिटी स्टार्ट कर दिया हिसार सेंटर को, गुरु जम्बेश्वर यूनिवर्सिटी करके वहाँ पे स्टार्ट हुआ। दैट्स हाउ फार्मेसी वाज स्टार्टेड।
Respected ma'am, क्योंकि हम सबको बहुत ज़्यादा याद है, अफेक्शनेटली उन्होंने हमें माउथ वाटरिंग इडलीज और अप्पे एंड सब कुछ खिलाया है, एंड हमने बहुत कुछ सर से तो सीखा, पर मैम से भी उतना ही सीखा है कि हाउ सपोर्टिंग शी हैज बीन।
जल्दी आ जाओ, बैठ जाओ, आगे बैठ जाओ, हाँ।
आना तो आजू बड़े कोई आना चाहे डोंट मिस द अपॉर्चुनिटी डोंट मिस द यहाँ आगे खड़े हो आगे यस फास्ट 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 हाँ वेरी गुड चलो चलो हाँ ऐसे खड़े जाओ बेटा पीछे आ जाओ
You can have two groups. आप एक ले लो फटाफट
बस हाँ चलो फास्ट फास्ट फास्ट
Yes, please, yes. Yes. Thank you.
चलो बाकी लोग बाकी बच्चे आ जाओ जल्दी जल्दी आ जाओ फटाफट फटाफट we just have 2 minutes आ जाओ
बेटा ये फोन बंद करना वैसे जल्दी आ जाओ कम फास्ट बैठ जाए बैठ जाए क्या नहीं है चल बैठ एक्चुअली दूसरा सेशन 20 मिनट लेट हो गया आज निकल आज जल्दी देखता हूँ फास्ट ये सारे हमारे अलग कॉलेज के भी सारे चलो
हाँ मैं तो आगे ही खड़ी हूँ ऊपर की मैं
सिद्धार्थ आ जाओ सिद्धार्थ हल्के मैम आ जाओ मैम आ जाओ
नवीन सर कहाँ रह गया
सॉरी अरे नवीन
अंदर सर
आओ जल्दी अंदर जल्दी आओ ना आ जाओ क्या नाम है पीछे ये चलो चलो आ जाओ अरे दिनेश जी जल्दी आओ बैठ 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 मैम 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 सामने देखो मैम मैम कैसी मैम सामने देखो
ग्रेट बाकी लोग फूड कोर्ट पे आ जाओ
अभी टी ब्रेक है ना फोटो वाले अंकल से
You can see that there are various important clinical questions which need to be answered. You can see on the screen, first question, can you suggest costly treatment to last stage cancer patients? If patient is at the last stage of the cancer and particularly there is a one treatment which is available and its cost is too much, maybe its cost is 2 lakhs per vial. So can you suggest these kind of medicines to last stage of the cancer patients? And of course, we are Indians, we are emotional. If someone in our family or relative are suffering from this type of disease, obviously we will say to the physician, yes, go ahead, whatever the best possible we can do, go ahead with that, we can arrange the money. And there are many examples where people are selling their land, selling their land, taking the loan from the bank to manage these medicines costs which are available for the treatment of particular last stage cancer patients. But if you see, for example, that patient having died within 7 days, so how much financial burden will increase on their relatives or their family members? So that's why these studies are required to guide the physicians and healthcare provider whether these medicines is important for that particular last stage cancer patients or not. And it's not about the survival. If you are increasing the survival for the 1 month, but if it does not lead to increase the quality of life, so it's of no value. Right? If the patient is, you have increased the survival of the patient for 1 month more, but in that 1 month, the patient is suffering from a lot of severe pain. So does it have any value? No. You have to see the quality of life as well, how your medicines is increasing the quality of life as well. So these type of questions you can answer by the pharmacoeconomic studies. Another questions which many of you come across regarding generic and branded drugs. We always there is a debate, some people or some healthcare professionals still think that branded drugs are better than generic. So question is still there, and Government of India is also many times notified that generics are equally effective and safe as that of the branded products. But still there are some incidents where question is asked on generic drugs regarding their quality. So in my personal view, if someone asks you which drug of the which medicine we have to prefer, whether I will go with the branded, whether I will go with the generic, or whether I will go with the generic branded drugs. These are the 3 types of the drugs which are available in the market, right? So, as I said, in my personal opinion, if patient is in severe conditions, so in that case we don't want to take any chance. If there is 0.001% chance that medicines may be of lower quality, so at that conditions you don't want to take chance, so you can prefer the branded drug. But the patients who are suffering from lifestyle disorder or non-serious indications, for these kind of, you can prefer the generic products. Where little increase and decrease concentration of the drug in the blood circulation will not impact that much. You all know there is a therapeutic index of the drugs. The drugs which belongs to narrow therapeutic index, you have to be very careful, right? So these type of questions you can answer by the pharmacoeconomic studies, and these are the stakeholder, provider, patient, society and payer. And this is just a basic pharmacoeconomic equations which will help you to understand what actually we are doing in the pharmacoeconomic studies. So you can see that one side there is a cost and another side there is the outcome. So outcome we are considering efficacy, safety as well as the quality of life. So there is an intervention of interest, and of course you should have the comparator to compare that interventions of the interest which you are doing for the cost and pharmacoeconomic studies. So types of cost. Cost is not only the cost of the medicines. We have to be considered all types of the cost which are associated with the drug, cost of the drug, cost of administrations, consultation fees, standard care of the hospital, ICU, hospital staff, all kind of cost you have to consider. And this cost comes under direct cost, and there is indirect cost as well. Under indirect cost, we have to consider loss of earning, cost of travel to the hospital, not only by the patients but also by the relatives or family members. Then there is intangible cost. Intangible cost is something which we can't measure in the monetary terms. We have to loss of pain, worry of family and patients, which you can't measure in the monetary benefits, but this is also another type of the cost. Measurement of cost, you can do per unit, cost per treatment, cost per person, cost per person per year, so it depends upon your research questions as well. Another thing which is required to do the pharmacoeconomic study is, one thing is the cost. In that one you have to consider direct, indirect cost, and another thing which is required is you need the data with respect to safety and efficacy of the medicines. So for safety and efficacy of the medicines, you all know there is a important, these clinical trials are the gold standards to get the data regarding safety and efficacy of the medicine. So you can get by the clinical trial, if you have a number of clinical trial more, you can go for the meta-analysis as well. So meta-analysis, maybe many of you already knows. To do the meta-analysis, first you have to do the SLR, and depending upon the what kind of data you are getting in the SLR, in the data extraction tree, you can think of whether I can go for meta-analysis or not. But it is applicable when you have a more number of clinical trial, at least 10 clinical trial on particular topic. And these are the different types of economic evaluations: cost minimizations, cost benefit, cost effectiveness, cost utility. There are other as well that we consider as a partial pharmacoeconomic studies. In that one there is a budget impact analysis, cost of illness is another partial pharmacoeconomic analysis. So in cost minimizations you can see that when you have in cost minimization there is an important hypothesis. You should have a outcomes of the one drug should be equal to outcome of second drug. If your outcomes are different, you can't go with the cost minimization studies. So when clinically this type of situation is, when we are comparing the cost of generic drugs among each other. So there is a generic branded drugs, there is a generic drugs which you get from Generosity Kendra, and there is a generic branded, there are many generic branded drugs are also available in the market. So in that case, what we are assuming, our assumption is the outcome of one drug is equal to outcome of B drug. Means there is no difference in their outcome. We are considering they are equally safe, they are equally effective. So in that conditions, you can go for the cost minimization studies, and where we are calculating the percentage of cost variation by simple formula. Whereas other types of the pharmacoeconomic studies, which are cost benefit, cost effectiveness, cost utility, your outcomes of the one treatment is not equal to outcome of B. What does it mean? It means your drug is different in their efficacy and safety, right? So in that case, you can go with the cost benefit, cost effectiveness, cost utility. So now question is when you will go with the cost benefit, cost effectiveness, cost utility. So you can see that if you have a outcomes in terms of monetary benefits, that we call cost benefit analysis. If you are measuring the outcomes in terms of natural unit like morbidity and mortality, we call it cost effectiveness analysis. When we are measuring the outcomes in terms of quality and DELI. Quality and DELI are the very important terms when we talk about pharmacoeconomics, that is we call quality adjusted life years and disability adjusted life year. When you are measuring the outcome in these units, then we call cost utility analysis. So these are the differences between these. So just a cost effectiveness where we have to calculate the incremental cost, and how to calculate the incremental cost, simple formula, you should have the cost of intervention A minus cost of intervention B, you will get the incremental cost. And incremental effect, effectiveness of intervention A minus effectiveness of intervention B. So that ratio we call it ICER, that we are calculating in the cost effectiveness ratio, and that we call incremental cost effectiveness ratio. Cost A minus cost B divided by effectiveness of intervention A minus effectiveness of intervention B. And if the incremental cost is small, then incremental effect will be large. So therefore a smaller ICR indicate a better cost effectiveness. And after that, what we are doing, we have to compare it with the cost effectiveness threshold. And from where we are getting the cost effectiveness threshold, we have to WTP. WTP of the country is different across the globe. It depends upon the GDP of particular country. We are calculating these are the different decision criteria. These are the daily calculations which you can do. These are the queries in WHOs. You can do the quality assessment, quality adjusted life years. These are the modeling, pharmacoeconomic modeling. So every one of you knows that model we are using to predict the future based on the available data. So whatever the data we have today, we can create a model, and these are the modeling which we are doing in the pharmacoeconomic studies, Markov model, decision tree, microsimulations, and these are the steps, different steps to do the pharmacoeconomics. I'm just skipping due to lack of time. And these are the commonly used software, 3As, but of course it's a commercially available software, and pharmacoeconomic industry are using the 3As. But if you want to use the free available tool, there is a WHO choice tool by which you can do the pharmacoeconomic. R package is another one. R package, every one of us can use, for there are a number of packages in the R. You can install it and you can put the command, you can create the projects, and in R there is a module, health economics simulation modeling, that we call HESIM. So by using this package, you can do the molecular this one, the pharmacoeconomic study. And you have to follow the checklist. This is the GS checklist which you have to follow during the pharmacoeconomic studies. And need in India, because India, we have limited resources, most of illness are covered in the private hospital, only few health insurance coverage. So to prioritize and optimize the available resources, pharmacoeconomic studies are required.
And of course, many of you knows about NELM, National Electronic List of Medicines you have to prescribe. So work done so far, what we have done, just 1 minute I will take, sir. We have done the pharmacoeconomic studies with National Heart Institute, New Delhi. And in that one of the studies we have done cost effectiveness of clopidogrel in patients with acute coronary syndrome undergoing PCI in India, and we have done the cost effectiveness analysis. We have created a model. This is a model. This is the model structure which we have used, decision tree, and as well as the Markov model. And these are the results. These are the sensitivity analysis by the Venn diagram. These are the ICR scatter plot. This is the comparison between clopidogrel and ticagrelor. Which one is going to be cost effective? And we found that ticagrelor is the cost effective. These are the protocols which have been published. These are the cost of illness which we have done, and this is the international society. This is the India chapter which we are running from our institute. IPSCON India chapters. I am the treasurer of this IPSCON India chapters from New Delhi, and I would like to acknowledge all the organizations. And again, thank you for IPS and for giving me the opportunity.
Thank you, Dr. Kumar, for this very excellent talk about a very important aspect, that is pharmacoeconomics. Now the session is open for any questions. We have a couple of questions.
Yes, do you have any questions? It looks like you are raising your hand, that's why. You can ask, means time is less, so I can understand, but whatever the doubt in your mind, anyone of you would like to plan pharmacoeconomic studies, and I always say to the students, learn the R package. There are a lot of packages in the R which you can use for your research work. So one of the you can do for pharmacoeconomics modeling as well.
So as a master of courage, I will ask you some
Yes,
questions.
sure,
So how do you think like this aspect of pharmacoeconomics can be translated and implemented in public, like used by the clinician and used by the common public? Because the type of analysis one is done and the outcome which comes out of the analysis, whether it is being in spirit implemented in practice in the market by the clinician and the benefit goes back to the patient. How do you think like this can really take place at the ground level?
Very nice question, sir. Actually, whatever the study result we are getting, we are submitting to the policy makers. Like we are submitting to the ICMR. We are running few projects under ICMR related to pharmacoeconomics. We are submitting these results to the policy maker. They will take the decision on that, whether they have to include that medicine in the national essential list of medicines or not. If I found one medicine which is newly and it's cost effective, so my recommendation will be included in your national essential list of the medicine so that maximum number of the patients will get benefit out of it. So that is the process. We can't give the recommendations directly, or we can't suggest the physician, but we are recommending to the policy makers, sir.
So do you think like there is a possibility of in future technologies like by the kind of mobile sets available with most of the people, where there can be a use of the like some kind of app where the approved medicines can be related which are being prescribed to the patient, to the common man can have a pharmacoeconomic evaluation by himself and see like what are the options available if they are under different brand, as you said, generic brands, and cause those kind of things are there. So
Yes.
do you think that?
Yes, sir. In the coming year, maybe there will be, but there should be a collaborative effort from policymaker as well as physicians' role is very important. You all know that physicians are only prescribing the branded drug. So it's very difficult to ask them to write the generic drugs. So all collective, scenario has to be changed.
One more thing is like important, like since you presented this from the pharmacoeconomics from the patient care point of view, but from the industry point of view, like as you know that from the small molecules, the industry was crowded with small molecules, and small molecules chemicals are more cheaper and affordable to take. Now, but when you speak of cancer and those kind of complicated, more biologics have come into play. Now, when you come to the biologics, then the pharmacoeconomics definitely shifts, and like you see the cost of the medication from some molecule to biologics.
Yes, sir. In biological, we have to comparison. We are doing the comparison among the biologicals, and in terms of if they are more effective than small molecules, and in upcoming, and we are predicting the future. If we are putting the biological today, so after 10 years, whether this biological is going to be cost effective, maybe today he is expensive, but maybe at long run, when I will do the calculation, maybe that biological is more cost effective than my small molecule. Because small molecule may be not that much effective.
and like another area like rare diseases.
Yes.
There the patient population is very
less. Yeah.
So there the pharmacoeconomics, how do you see, because industries usually raise very price, and since it's a rare disease, even if it sells less, even they sell less, they make a lot of money out of it. So how do you think there is a possibility of bridging out down the cost?
So we have time constraint. Can we discuss during lunchtime?
Okay.
Thank you, sir. Thank you.
Thank you,
Sir. Thank you, ma'am. Now I request the chairperson kindly felicitate Dr. Anup Kumar. Next speaker we have Dr. Sameer Dhingra.
Next speaker for today is Dr. Sameer Dhingra. He is an accomplished academician and public health researcher, currently serving as Associate Professor in Pharmacy Practice at NIPER Hajipur. Dr. Dhingra has co-authored over 130 indexed publications, including burden of disease studies. His research focuses on HIV/AIDS, resistance, and real-world health challenges. His expertise in health economics and outcomes research here and health technology assessment (HTA) enables the translation of the policy and clinical practice. His title for today is AMR in Cancer Patients: Call to Action for Collaborative Solutions. So I invite Dr. Sameer Dhingra to give his presentation.
So good afternoon to all of you. So dear students, I have already been introduced. I am working as Associate Professor at NIPER Hajipur in the Department of Pharmacy. And I know, the session just before the lunch are usually very difficult to, manage, because whole day you are sitting here, going from one session to other. And in fact, morning session in this particular symposium hall 3, it was a very, very heavily, I should say, emotionally filled session. Okay, but anyhow, we have to continue with the legacy of science for the better mankind to serve the society. And the topic which I am speaking, that is very, very close to my heart. And in fact, in post-COVID scenario, if we are not prepared well to deal with the infectious diseases, next pandemic may not wait for century, like this pandemic came almost after a century. Okay, so we have to be well prepared, we have to be very careful, we have to be very honest in our deeds when we are working for the vulnerable population like cancer patients, pregnant women, lactating women, geriatric, or the patients who are on immunosuppressant drugs. We have to be more and more careful. And my session becomes very, very important because today we are in the midday of World Antimicrobial Awareness Week. Today is November 21st and November 18 to November 22nd. Worldwide, we are celebrating World Antimicrobial Awareness Week. So my presentations directly coming from the patient settings from NIPER Hajipur, students, PhD scholars, MPharm scholars. They are going to the clinical facility like Mahavir Cancer Sansthan, that is a NGO working for the poor patients who have developed some sort of cancer, struggling with their life, struggling with their disease, struggling with the financial parameters, so many things coming around them. Okay. So coming to the next slide, and if you'll see the last, in last 1 year when I was preparing the slide, I thought let me check few headings, how the world is treating, how the, the social media or global newspapers, they are picking AMR. So starting from our own organization, WHO warns of widespread resistance to common antibiotics worldwide, calling AMR a fast accelerating global health emergency.
So it is published on WHO newsletter in October 2025. Then Financial Times reports 1 in 6 bacterial infections now resistant to treatment, signaling a critical rise in untreatable infections. Again, the news published just last month. UN General Assembly adopts a political declaration on AMR with world leaders committing to decisive global action last year, September 2024, and India has witnessed that event here at Delhi under One Health program. Then OECD urges adoption of One Health policies to curb the rising economic and health burden of antimicrobial resistance. This was another news published in 2025. So my dear students, this is the thing we have to look into. This is the thing we have to see the global scenario in what direction we are going. Yesterday evening I was attending a lecture from a very renowned pharmacologist, Professor Y.K. Gupta, yesterday evening. After medical devices and the topic biosimilar, third thing he spoke about AMR. He said the government of India is critically looking for the AMR. We have to curtail the AMR in Indian population because the graph is uprising. And you know, very few antibiotics we have left in pipeline. We do not have more antibiotics. Our last resort antibiotics are even no longer going to help us. And this is already, I said that, November 18 to November 24, sorry, I said 22nd, but before it is 2025, we are in the mid of today, World AMR Awareness Week. So globally it is being celebrated. And this year theme is Act Now, Protect Our Present, Secure Our Future. Students' legacy has to carry on you. Person like me have almost reached to the mid stage, almost 47 now. And I am doubtful. I don't know how my life is going to go further, but I still feel that infectious disease may be one reason that may take life away from me, how the AMR graph is going up. And that too, another thing is the cancer again. You're getting my point, what I am saying. We are dealing with these two deadly diseases, and when they come together, it is very, very difficult to survive in a clinical facility. I have seen people crying in the clinical facility, husband-wife crying for wife, wife crying for husband, husband and wife crying for their child. Settings are really, if you go to the clinical settings, things are very, very scary. And AMR is accelerating faster than our defenses. Drug-resistant infections are rising across hospitals, threatening cancer outcomes. We have to secure the future. We have to build sustainable healthcare systems. That is the demand this year. WHO is expecting. So we need to invest time in surveillance, research, and One Health response across sectors, then collaborate across clinicians, scientists, and policymakers to safeguard the treatment efficacy. And being a pharmacist, it is our responsibility to be a part of that healthcare team. Then we have to protect the present. We have to strengthen the action today itself. When we need to enforce antimicrobial stewardship in all the oncology units, we need to stop irrational antibiotic use. We need to accelerate our rapid diagnostics for neutropenic and high-risk patients. Then there is a need for a call for action, that is every prescription, every culture, every infection control step matters, and let us act now to save the lives. So do you agree with me, students? So we need to do something in infectious disease area. That is the domain where the government of India is seriously and sincerely looking for. And that legacy has to come from you. Many of you as a pharmacologist or a pharmacy practitioner or a clinical pharmacologist, you have to adopt this domain, infectious diseases, where I see a plenty scope. If you're doing good work, we need people around, industries need people around who can make India self-reliant. If any next pandemic comes in the form of infectious disease, we should be able to manage the pandemic in our own country itself. This is how we dealt during COVID-19 time period. So this was just when I was preparing the slides, suddenly one message pop up through Twitter on my, the desktop, on my laptop, from the Union Health Minister, Shri J.P. Nadda launches National Action Plan on Antimicrobial Resistance to November 18. AMR is a major public health concern that can only be addressed through collective action. That statement is coming from our Union Health Minister. And always remember, when a health minister or a Union Cabinet Minister speaks, we need to listen. The reason they speak about the country, and that country is dearer to me as well as it is dearer to you also as a youth. And overuse and misuse of antibiotics has unfortunately become common practice, underscoring the urgency of corrective measures. Pharmacists, and I know the clinical pharmacologist may be there, but irrational use of prescribing, you go to any community pharmacy, you go to any hospital setting, many times during COVID-19 also we have seen the irrational prescribing of antibiotics like Agithral. You go to any community pharmacy, they will not ask you for the prescription, simply they will, I will not say dispense you, they will sell you. So students, my suggestion to you, tomorrow if you become a pharmacy officer or you go to administrative side as a drug inspector or you work as a community pharmacist or hospital pharmacist, please stop these unethical practices. Please prescribe, please dispense antibiotics against the prescription only. That is the way how we can increase our surveillance. That is the way how we can increase our things. Time is going to be up. How many minutes left? 5 minutes. Time is very little, you know. इतनी देर तो warm up होने में लगती है. Okay. So let us move ahead from our Union Health Minister. I'll go to the next slide. And if you see the confluence of two global crises, one is the cancer, other one is the infectious disease. So the cancer burden, already I spoke, immunosuppression for malignancy and its treatment, that may be chemotherapy or radiotherapy, creates a highly vulnerable patient population. Then the AMR threat, the rise of multi-drug organism turns common infections into life-threatening events. Then there is a collision, and this confluence leads to a critical situation in oncology units demanding immediate and focused attention from the pharmacology community. Then our focus, when I speak about the NIPER Hajipur, many of my research scholars are purely dedicated towards the oncology units where they are working on AMR, they are giving counseling to the patient, they are spending time with the patient. At the same time, they are also doing their clinical studies also as a part of observational studies or interventional studies. Then if you see the impact on cancer outcomes, it increases the morbidity, there is a higher mortality rate among the patients, then escalating healthcare costs, then the compromised cancer therapy. And that leads to delay or interruptions in life-saving anti-cancer treatments. If the infection is underlying, definitely it is going to harm your cancer treatment also. If cancer is prevailing, it is going to reduce the efficacy of your antimicrobial treatment also. And this is one of the studies that was published in Annals of Clinical Microbiology from our own student Akshay Shelke, where we have seen in Mahavir Cancer Sansthan, in adult population, 48% of, when we took the culture, for approximately we collected 541 isolates, 48% of the patient, they had a multi-drug resistant organism we could identify, and approximately 30% XDR, and only 20% of isolates were fully sensitive to the given antibiotics, that in cancer units. Similarly, for pediatric unit, 67% MDR and 16% XDR. So you can well imagine the patient who is going to the hospital setting, if they're dealing with these kind of deadly diseases, whether it's adult or pediatric, you can well imagine what would be the fate. Then surgical site infection, there approximately 48% prevalence we have seen for the multi-drug resistant organisms. And predominant organisms were gram-negative bacteria like K. pneumoniae, E. coli, and Pseudomonas aeruginosa. And if you see the key risk factors, frequent broad-spectrum antibiotic exposure, it leads to prolonged hospital stays, invasive procedures, and immunosuppression. And this is another study carried out by Vishala. It was showing the key risk factors. Those were identified like severe neutropenia with the odds ratio 4.89, then recent chemotherapy or cancer recurrence, then prior radiation therapy. Then healthcare exposure also, like prior antibiotic exposure, then prolonged previous hospitalization, recent surgery, then invasive devices and infection type, presence of CVC, Foley catheter, Ryle tubes, pneumonia, UTI. So these are all become, they came as a key factor, risk factors for our patients. And this is again in terms of, their odds ratio. Then when you see the consequences, we could see that when we assess the 30 days mortality, we could see the higher rates among the MDR patient and XDR patient. Similarly, same case for surgical site infection, and similarly 10-fold higher rate for the pediatric population. And moreover, we could see the prolonged hospitalization for those patients who had MDR or XDR infections for approximately 23 days, surgical site for approximately 23 days compared to the patient without these kind of infections. And so these are the risk factors, and this is the one study carried out by Saib Webby, where she compared the efficacy and safety for tigecycline versus colistin. And we could see that both were equally effective with similar clinical recovery and 30 days mortality. But tigecycline is associated with a shorter hospital stay when we compared it with the other antibiotic, that is colistin. And this is the antibiogram which we developed for the Mahavir Cancer Sansthan for their clinicians to give them the recommendation what kind of antibiotics still they are showing the sensitiveness to the treatment, and the antibiotics which have developed the fully resistance. So we prepared one antibiogram for the hospital setting to assist them for the future cases. Similarly, we developed for them an antibiogram for pediatric population for Mahavir Cancer Sansthan Hospital in Patna. It's a big hospital. And still there are the critical challenges in management in terms of diagnostic delays, empirical therapy dilemma, then limited therapeutic arsenal and diagnostic complexity. And when it comes to the pillar, I should say for a multidisciplinary team, we need to have antimicrobial stewardship programs in every hospital setting. Irrespective of whether it is a small hospital or a bigger hospital, all hospital units must have they should actively run antimicrobial stewardship programs. Infection prevention control committees must be there. Standard therapeutics committee should be there. So all those committees should be there. There is need to enhance infection prevention. There is need to enhance the rapid diagnostic technologies. We need to bring biotechnology based tests, PCR based, RT-PCR based, those things. I think we need to bring those things into the clinical facility also in terms of point of care tests to quickly identify the infection and treat the patient according to the infection. Whatever organism, wherever they are showing the sensitivity, we need to use only those antibiotics. Then tailored and local guidelines are must for every single hospital. Madam, it is almost last slide. So this is the core team: oncologists, surgeons, then infectious disease specialists and clinical pharmacologists, clinical microbiologists, clinical pharmacists, then hospital administrators and the policy makers. And this is a call for action. We need to integrate the surveillance. We need to use the local data like how we use it, Mahavir Cancer, to create real-time unit-specific AMR alerts, promote education among the clinicians, among the paramedical staff, among the people, among the patients. So we need to create the awareness at every level. We need to foster innovation in terms of support research into novel agents and treatment strategies, building on comparative studies. Then we need to strengthen partnerships, implementing sustainable stewardship programs, infection prevention control measures informed by institutional evidence. And finally, coming to conclusion, AMR is not a future threat, it is a present reality of our cancer patients with devastating outcomes as demonstrated by our data. And protecting them requires a proactive, coordinated and data-driven approach. And we must act now using evidence from our own settings to preserve the efficacy of our life-saving treatments. So this is a acknowledgement slide from our students. We have a clinician team also, like very sincere doctors like Dr. Richa Chauhan, Dr. Manisha Singh, Dr. Palvi Singh. All the time they are assisting us in conducting these type of studies, for our patients. And these are our PhD scholar Akshay Shelke, Priyanka, Rampun, Jasina, Sai Webby, Vishala, Bhavna. And eventually, finally, the patients and their families whose participation enabled generation of meaningful real-world evidence. So with this, thank you.
Thank you very much, Dr. Hindra. It's actually a burning topic, and we wish we could have heard more from you on this. And it's an extensive work you have done, really creditable. And that antibiogram, that was really wonderful. And the main thing I feel is that AMR, why it is a burning topic, is because it can't be handled at one level. So at the clinician level, another type of problem, at the patient level, and even at when the patients are just disposing of the medicines, they are going into the soil, the animals are consuming, it is coming into the milk and we are consuming. So cycle is vast. We don't really know where it is actually coming from.
That's why One Health approach now coming into picture. Planetary health, One Health, whole ecosystem we have to consider. That is how we can contribute. Being an animal, I should say, human beings are the social animal who can take the lead. And yesterday we saw one Animal Act cultural program. Have you seen that? So they're also part of ecosystem only, animals, we have to look after it.
Thank you so much.
Okay, thank you.
Any questions? Do you have any questions? We have one.
I agree to you. I also come from a community pharmacy background from a remote town, Haryana, Sirsa district. My father was running a community pharmacy. I've seen those scenarios where if you refuse, they will take the medicine from some other pharmacy. But this is the fact, like most of the pharmacies, because they're scared or they're afraid, if you will not dispense the drug to the patient or sell the to the patient, they will buy it from other pharmacy. But I think that's why I'm here. I'm creating awareness among you. When you go to the field, please don't do those things. Okay. And let me give you an example. Before coming to NIPA, I was working with the University of the West Indies, where I was a clerkship coordinator for student program. Let me tell you, my little son, he got whelp infection. And one of my Indian colleague from Hyderabad, night it happened around 7 o'clock. He told me, Samir, you go to the pharmacy and get one augmentin syrup. Augmentin is a moxiclav. Okay, I went to the chain pharmacy, Messi store. They're running a chain pharmacy in that country. I went up to there. One girl whom I taught just 2 years back, she was on the upfront. She came to me, hello, Dr. Dhingra, how come you are here? I said, see, listen, my son is not feeling well. And one of my Indian doctor colleague, he has prescribed him augmentin. Dr. Dhingra, could you please share the prescription? I said, I do not have prescription at this point of time. But if you want, I can bring it tomorrow. Oh, no, Dr. Dhingra, it is not possible. It is not possible. You only taught us no, so it is not possible. If I will dispense you, I'll be failing in my duties and I will make you embarrassed at one point somewhere. I don't want that. That kind of character we need to build. If your own teacher comes without a prescription, and eventually she waited and she said, sir, you get it through WhatsApp or any mode, please get it. Because I'm here to fulfill my duty, and the words which you have taught me in the classroom, that's still there in my ears. I cannot do that. So that sort of feeling, unless we bring it to our students, our community, our practitioner, things are not going to become successful. That's why I'm requesting you, if tomorrow you enter into any system, please make sure don't compromise with the, the antibiotics. Antibiotics, and the second is the narcotics. We have to be very, very careful in our deeds as a practitioner, because these are the things which are killing our society like anything. Antimicrobials, silently, narcotics, still narcotic department, police department, they look at. But AMR, we are killing on our own. And we are killing tomorrow my own relative may be there in the hospital setting. Somebody may develop cancer. After developing cancer, how much time it takes to develop an infection? Hardly 1 or 2 days. Hospital-acquired infections are very, very common. So we have to be very careful. Okay, and India is a large country with 1.4 billion population. Challenges are very, very tough. But when I speak in front of the youth, people like you, I also come from a safe background. That was the reason I have chosen pharmacy practice. My childhood I spent at a community pharmacy with my father. These are the things which I learned from my father. Never dispensed any narcotic, any antibiotic without prescription. No. For antibiotics, still he was little bit liberal. But he used to tell in neighborhood, one doctor was there, he used to tell him, go there, meet with him, he'll charge hardly 20 rupees, you get the prescription, they will dispense the medication, like that, how we manage. Thank you, ma'am.
Thank you, sir. Thank you, ma'am. Now, I request the chairperson kindly felicitate Dr. Samir Dhingra. Now it's time for the felicitation of our chairpersons. I request Dr. Samir Dhingra and Dr. Amita Sabarwal, please join the stage and felicitate our chairpersons. Kindly felicitate Dr. Manoj Kumar Bharatwal. Please felicitate Dr. Professor Alkabali. Thank you, ma'am. Thank you, sir. Now it's time for lunch. We'll assemble by 2 p.m.
it is my proud privilege to invite our chairperson for the session, Professor Nidhi Goyal. Professor Nidhi Goyal is an accomplished academician and pathologist, presently serving as professor in Head Department of Pathology and Academics Dean at BKASMC, Uttar Pradesh. She completed her MBBS and MD Pathology from Government Medical College, Patiala, Punjab. With experience in hematology and bone marrow examination, she has contributed significantly to medical education and diagnostic pathology. Her current focus lies in strengthening academic standards, fostering clinical pathology, correlation, and monitoring young medical professionals in the field of pathology. We welcome you, ma'am. I would also like to invite another chairperson for this session, Professor Dr. Debashish Hutta. Professor Hutta is the professor and head of the Department of Pharmacology at AIIMS Bhubaneswar. He completed his MBBS from Maharaja Krishnan Chandra Gajapati Medical College, Odisha. His MD in Pharmacology from BHU and DM in Clinical Pharmacology from PGI Chandigarh. Dr. Hutta research and clinical interest include pain medicine and metabolic disorders such as diabetes. He has published extensively in experimental pharmacology and clinical trial in neuropathic pain and diabetes, and has contributed to network meta-analysis and translational research. We welcome you, sir. Ma'am, please join the stage. The first speaker we have Hemant Kumar, Dr. Hemant Kumar.
Dr. Hemant Kumar Boina. The title he presented is Targeting Neurodegeneration through Nature-Inspired Therapeutics. Dr. Hemant Kumar is a professor of pharmacology at the University Institute of Pharma Sciences, Chandigarh University, with over 14 years of experience of academic and research. He completed his PhD in pharmaceutical sciences from Jawaharlal Nehru Technological University, Hyderabad, where his work focused on the neuroprotective potential of natural dietary or antioxidants in experimental models of vascular dementia. He also holds B Pharma and M Pharma degrees from RGUHS Bangalore.
A very good afternoon to all. Myself, Dr. Hemant Kumar Boina from Chandigarh University. So I feel I take honor to present here at Punjab University at IPSCON 2025 on the topic targeting neurodegeneration through the nature-inspired therapeutics. So this topic is how the neurodegeneration strategies are there and how we can target the neurodegeneration, especially in case of the Parkinson disease. So what is the statistics of the Parkinson disease? And introduction to the neurodegeneration, then demographics of PD and how the Parkinson disease will affect the population, and also a small case study or the network pharmacology study which is related to the nature-inspired therapeutics which are there. Especially what are the important technologies used as a nature-inspired technologies, and methodology and small results and conclusion from our studies in the lab. So mainly the neurodegenerative diseases are most common, especially the AD and Parkinson disease, Huntington's and ALS. All these are the common disorders which are mostly seen. And out of these, my area of research interest or the expertise is on vascular dementia, followed by Alzheimer's and Parkinson disease. For this topic, I have chose the Parkinson disease as one of the important area. And mainly, you can see the Parkinson disease, it is having the alpha-synuclein, which is the main protein which is involved in case of the Parkinson's disease. and it also further leads to the neurodegeneration followed by oxidative stress and also the neuroinflammation. So nature-inspired therapeutics, especially what are the flavonoids or the polyphenols or the compounds which are acting as natural antioxidants. So these compounds which will be rich in case of our daily food and act as a functional foods. So these compounds will be selected and how they will be used in case of the targeting this alpha-synuclein, especially the Parkinson's disease. So mainly the pathophysiology of this disease, it is the main, the oxidative stress is very important, so that my criteria here targeting this oxidative stress will be the natural antioxidants and aggregation of these proteins, especially alpha-synuclein and beta-amyloid in case of the Alzheimer's, and neuroinflammation is also the main triggering factor, and synaptic loss. So these all are the important triggering factors which are seen in case of the Parkinson or any other neurodegenerative diseases. So now our interest will be the multi-target antioxidants which are there, which are not affecting the single mechanism. They are targeting the multi-mechanism, so that multi-targeted mechanism is very important here. So in order to select such type of the compounds. So this is the common neuropathology of Parkinson's disease. So here I derived one frame or the compass we can call. So that is called as nature, novelty, and neuro and navigation. So these are the derived from the N. So here we can see 3 different N's and 4 different E's from the neurodegeneration. So N stand for nature, novelty, neuro, and navigation. So based on these particular techniques like the nature, so we'll be selecting some potential phytochemicals which are derived from the nature, and novelty, whether they are acting as a novel compounds which are mostly researched or under researched. So based on that, so some of the novel compounds will be selected, and also the neuro, whether they are targeting these neurodegenerative diseases, and navigation. So especially this particular N, last N which is there. So that will be how we are setting your research, what technologies you are using and what pathways you are targeting. So E stands here like the efficacy, exploration, evidence, and ethics. So all these are the important things. So you can see 1, 2, 3, 4. 4 E's are there in the neurodegeneration based on that. So the efficacy, so whether you are using the drug, so it can be approved easily. So a compound which can be used for the preclinical and clinical trials. And exploration, that is how it will be represented and how it is targeting all these biological pathways and also the genes which are involved in the disease. And evidence, that is the data-driven decisions, especially it is very much necessary in case of the drug discovery. And what are the ethics, whether you are following all the ethics if you are going for the clinical trials. These are very important to study in case of the neurodegenerative studies. So Parkinson's disease, if you take the WHO global statistics, so which was framed by the WHO, World Health Organizations. And here you can see the Parkinson's disease by 2050, you can see 25.2 million people are affected by this disease. And all the age prevalence, it is reaching around 267 per 1 lakh by 2050. So these are the projections which are related to the Parkinson's disease. And even Asia, especially India, is also one of it. And you can see the demographics of this disease. So you can see the India is also coming in that. And these are the main countries where, especially the United States, it stands first. And we can see the India at the 5th position. So these are the age standardized Parkinson's disease incidence by the country wise. So this is the demographics and age standardized Parkinson's disease occurrence. And now we are talking about how to target the neurodegeneration, especially whatever the current treatments are there, like levodopa, carbidopa. So all these which are the drugs which are already established, but there is no proper drug which can easily cross the blood-brain barrier and also target the neuroinflammation or the oxidative stress or synaptic loss or dopaminergic pathways. So mainly we have to target that particular point. So my idea of nature-inspired therapeutics, because nature, it has a lot of polyphenols and stilbenes, tannins, chlorotannins, and marine-derived products, and also the bacterial-derived, microbial-derived, like probiotics, and some of them are prebiotics. We can make them a symbiotic formulation, and also nowadays nanosymbiotics was also used. So a lot of compounds was there, so a lot of technologies we can incorporate in studying this pathway. So multi-target mechanism is very important. So during my doctorate work or postdoctoral work, we have worked on some compounds which are like phycetin and hesperidin. So these compounds have the multi-target mechanism, especially the phycetin, so which is derived from strawberries, and it is mainly potent in case of this antioxidant or anti-inflammatory. And this citrus fruits and other nuts, so they have the compounds, mostly the hesperidin, quercetin, rutin, resveratrol. All these are the important compounds which can be derived. And these will address the multi-mechanisms like oxidative stress, neuroinflammation, followed by these mitochondrial dysfunction. So these are the various technologies which are there, especially nowadays the cheminformatics is very important, and synthetic biology technologies are also there, especially the molecular DNA assembly by using this CRISPR and other platforms, and medicinal chemistry and semi-synthesis. And today's talk, I'm just concentrating on computational design and AI-driven drug discovery. In that, one example is the network pharmacology and ADMET analysis. So our talk will be on that network pharmacology and ADMET analysis of certain selected compounds. And alternative models and translational platforms, after getting the data from this network pharmacology and ADMET analysis, we can go for the selection of the models, especially the zebrafish and Drosophila C. elegans models are nowadays commonly used for the neurodegenerative disorders. And targeted modalities and biologics, all these are the nowadays advanced techniques which are there in neurodegeneration. High content screening and phenotypic profiling, scale-up formulation and regulatory pathways. So these are the important technologies which are existing for studying the neurodegenerative disorders. So natural antioxidants, I have selected some around 10 natural antioxidants which are mostly reported for their properties, and we have screened out the best 2 compounds from that 10 list of the compounds. And here my important goal is to identify the multi-target interventions of those particular compounds and make a combination or use a nanotechnology or other advanced alternative research models and work on those particular compounds as a nature-inspired therapeutics. So study objective is to identify the small molecules, especially for the Parkinson disease, and then integrate the network pharmacology, in silico ADMET analysis, and followed by experimental validation. Then study hypothesis, especially the natural polyphenols, which are mainly targeting the alpha-synuclein, so which is the pathophysiology of the PD. So computational network pharmacology is used here, and we have used certain filters, drug likeliness filters, and also we have performed enrichment analysis followed by downstream validation. So this is all overall pipeline of our work. So disease network construction, that is called as protein-protein interactions, and molecule detection and hub analysis by using the cytohubba, and compound target mapping, in silico ADMET and boiled egg filtering. So this is mainly very important in order to know which of the compounds can cross the blood-brain barrier. So which of them are not crossing the blood-brain barrier, so they can be excluded from the study, and those which can be crossing the blood-brain barrier, those can be included. So computational and data inputs, so we have selected a set of 10 natural or nature-derived compounds. So in this particular study, like pterostilbin, quercetin, naringenin, rutin, resveratrol, sesamol, and levodopa, myrcetine, hesperidin, and piperin. So these are the compounds which are selected for the study. and we have performed, curated some of the gene data sets for the Parkinson disease. All these are the genes which are mainly curated for the Parkinson's disease, which are directly involved in the Parkinson disease. And from the KEGG and wiki pathways and disease databases, we have got some of the enrichment analysis which further suggested for the ADME. So ADME tooling was also done by using these Swiss ADME descriptors and also the BBA prediction and pains likeliness. So these are the filters which we have used here. So these are the compounds which are selected based on their previous reported studies, and the references you can see, all these are reported for these studies earlier. So based on these data, these compounds were selected for our study, especially the tirostilbin, quercetin, which is widely reported, and we have worked a lot on quercetin in our lab, and also naringenin. Now we are working on rutin and resveratrol. And we have also started working on hesperidin, so which is already reported for many of the neuroprotective action. And sesamol, levodopa, mircetin, and also this hesperidin and piperin. So these are the 10 selected compounds based on their source and their already existing literature data. And based on this, we started working with the network construction. So we have built a PPI network using the string database, and which is mainly available from the Cytoscape, and which we have imported into the Cytoscape software. And we have checked for the confidence levels, and then PPI enrichment test was performed, and all these limits, especially the different nodes up to the 21 nodes, was collected. And this HABA database, which was there, CytoHABA, from this we have generated the enrichment analysis based on this. So we have constructed this particular PPI interaction network on the genes which are involved. But the PPI network, it consists of 21 nodes and 51 edges total overall, and connectivity among these PD proteins which are involved especially for the Parkinson disease. And these PD proteins, which especially we see, especially the alpha-synuclein, that is called as SNCA, and LRRK2 and PRKN and PARK7, and also the SNCA-IP. These are the prioritized genes which we can identify by this CytoHABA. And after this CytoHABA analysis, so we have generated the data on enrichment analysis, especially by checking whether these genes and also the selected 10 compounds are involved in the mitochondrial dysfunction or the proteostasis. So based on that, we can further proceed for the another Swiss ADMET or the egg model. So these are the analysis which we have performed. These are the enrichment analysis based on those particular genes, how much relevant they are falling based on the FDR value, and calculated the p-value for this based on these tests. So these are the enrichment analysis, and we have checked the linkage of these particular genes related to the Parkinson's disease mechanism. So these are the data which is generated from this enrichment analysis, and finally, so we could able to get the statistical data from the KEGG analysis, that is the reactome pathways. So how all these compounds are affecting the different pathways of the Parkinson disease. Especially we can see the Parkinson's disease, mainly the mitophagy, ubiquitin, and also the protein binding and oxidative phosphorylation. So all these particular pathways which are there, so that can be given by these KEGG analysis, what I have represented in the previous slides. And based on these values, we have derived the p-value and also this FTR, that is a false reactivity value, which can be calculated here. So here the input gene set, so like that we have calculated among the 10 best reactome pathways and finalized into the tabular form, and we can see the totally the 21 string nodes was given. So this is top enriched GO biological process, which is also represented in the form of the table. So finally, we have interpreted from this particular data, like how this Parkinson's pathway is involved and what are the genes involved and what are the main pathways we can target by these 10 particular compounds. And finally, we came out with the two compounds, that is the sesamol and naringenin, followed by quercetin and pterostilbin. So this is the Swiss ADME data, so where this naringenin falls out better values with the bioavailability and also the druggability. And you can see sesamol and naringenin. So next is the quercetin and also the resveratrol. So here you can see, pterostilbin, quercetin and pterostilbin. So this is the data which we can obtain because of this Lipinski rule and also the bioavailability score, which is less than or equal to 0.55, and there is no pain alerts are reported. Based on these conditions, we can able to derive two compounds, that is naringenin and sesamol. So this is the egg model. So these compounds, only the 4 compounds, including the sesamol and naringenin, can able to cross the blood-brain barrier. So this is the final interpretation from the boiled egg analysis. Yeah. So it's done. So the last. So these are the conclusions. Mainly, sesamol can be a top CNS candidate here, so that we can further modulate this particular compound for the use, because it is easily crossing the BBB, and also we can enable some of the important studies focused on the organoid and other models. So already we have started those studies in our lab, so using the zebrafish and other models for the sesamol and this particular naringenin. So these are some of the publications which was reported on these compounds, especially targeting studies and docking studies, network pharmacology studies, and also some of the studies in vascular dementia was also reported on hesperidin, quercetin, quercetin, and all these compounds which I used to regularly work. And now there are some more compounds which we are working, like vanillic acid and all, which we used to work on these particular compounds. And these are my previous research journey. I have been as a CEPSIRE fellow at UCSD San Diego for 6 months, which was sponsored by Government of India and SED. And I have presented last month in South Korea for this WCN Congress. And my last oral talk was at IPSCON 2024 AIMS Delhi, and this was my next talk. And my next talk will be at WCP 2026, which was in Australia, Melbourne. And this is my team who has been working with me for this network pharmacology and all. And I thank all these organizations which was supported my travel and also registrations in all the ways, especially from Government of India. NRF has provided huge travel support. British Pharmacological Society for WCP, Scotland, Glasgow. I have attended that congress also. And ASPEC, UC San Diego for the CEPSIRE fellowship, and my university, Chandigarh University, and Punjab University for giving the platform to speak about my work here in this. So such an old university, and we are honored to be here. So this is our university, Chandigarh University. Yeah, ma'am.
Topics also done in this topic under Yes. I was a PhD examiner. So, what further work has been done?
Further work is in progress actually. So this is only the part of work. For this presentation, we have presented the basic work. So still the further work like molecular docking, simulation, followed by models. Yeah. Okay. So we are going for the nano formulations, especially by the combination.
Almost 10 years back.
Yes, sir.
Nano is not new to you.
So because based on this particular data, so we are trying to make a combination.
Clinical indications that you are still planning? That is my question.
Yeah.
Ultimately, the research should be translated into patient care. क्या plan है? Which disease conditions you will plan? कहाँ पे मतलब any clinical situation
to translate this particular work into the next level. But so this is the what I'm explaining the basic one. I can you can repeat the question once again.
Okay. Then you can learn that.
Yeah.
Thank you.
You're planning it for Parkinson's disease and
Yeah.
Alzheimer's, no? That's what you said.
Yeah, this is for Parkinson, and we are working on vascular dementia as well as in Alzheimer's as well. So these are the three areas where I'm working in, and this is the for Parkinson disease, and we can translate this particular work to the other neurodegenerative disorders as well. So we are collaborating with other people who are there in US and also in Malaysia and here in BIP Value. So we are working because still a lot of data has to be derived.
Thank you, sir. Thank you, ma'am. I request Dr. Debashish Hutta, sir, please join the dais. Now, I request the chairperson for this session kindly felicitate Dr. Hemant Kumar.
We should promote young scientists, definitely, because that is the future of India. And we are looking forward to 2047.
Thank you, sir. Next speaker, we have Dr. Avnish Mishra.
Dr. Avnish, I know him personally when I went to Guwahati last August. So he is faculty in the Department of Pharmacology and Toxicology at IPSCON Guwahati. So he is from MD Pharmacology from GNDU, Amritsar, and from Punjab University, Patiala. So he is working excellently in IPSCON Guwahati. He is probably the face of IPSCON Guwahati as far as pharmacology is concerned, and he is always collaborating with people who are in similar areas. So neuroscience, nanotoxicology are his interest areas, and he will talk about unveiling the novel role of ACRCA2B and calcium homeostasis in therapeutic potential in epilepsy. So two areas are very close to each other. One is epilepsy, other one is myocardial infarction and heart failure. So cardiac and this arrhythmias, so they are linked to some extent. So role of calcium channels are always there. So let's start this. So try to maintain time.
Yes. Good afternoon, everyone. First of all, I would like to thank the organizers, UIPS, Dr. Anil, for inviting me here, and for the chairs who has given a kind introduction. Thank you all. So today I will be talking about the normal role of sarcoendoplasmic reticulum calcium ATPase 2B protein in the calcium homeostasis and epilepsy. So as Dr. Hota told, that this calcium homeostasis is quite important in the myocardial infarction as well as in the epilepsy. So this SERCA2B protein has been quite explored in case of myocardial infarction, some with stroke. However, it has not been explored in case of epilepsy. So we are trying to investigate that how this SERCA2B is involved and how they are related to epilepsy. So before I would like to give a brief introduction. What is epilepsy? Epilepsy is a clinical condition where you are going to have at least two episodes of unprovoked seizure with the intermittent, with the difference of 24 hours, or there is one unprovoked seizure will have the more than 60% tendency to reoccurrence. Okay, so if we see the global scenario, it's like the number has increased. 70 million population worldwide is suffering from this, and if we see the number, 80% are accounting from the lower or middle income countries like India. And the major problem with these countries are that the treatment gap. So we account for 75% treatment gap. And if we see that more than 20 anti-epileptics are there available in the market, but still we are having the 60 to 70% of the treatment scope. Rest of 30 to 40% patients remains refractory. If we see that the northeast state where I belongs to right now, they accounts for around 15% of the epileptic cases. So that's why it's quite important to work on the local issues what we are facing up. So if we see around that what India is contributing to the epilepsy research, so you can see the biggest circle on the India is quite high, and that indicates that the evaluation models, the research is almost very big or grotesque in India. However, still if we see the treatment gap, we are accounting for 75% treatment gap. So that's quite bigger difference. So let's see that what has been little explored in case of epilepsy. So as we see that I'm also working on the childhood epilepsy. So mainly I'm working on the calcium homeostasis related to that. So let's see that how the calcium homeostasis is maintained in normal cells. Generally, low level of calcium is maintained in the cell. However, outside, high amount of the calcium is there. So our cells are continuously effluxing them out. So I'm not talking about the surface proteins which are responsible for this. I'm talking about that how high level of intracellular calcium is being maintained. So here is a sarcoplasmic reticulum, and here you can see that this SERCA protein is there. So that continuously, with the help of ATPase, they will be just going to influx the calcium, and they will try to neutralize the calcium level inside the cell. A part of it, there is a mitochondria that will be also going to have calcium intake into the cells with the help of VDAC1, MCU, and sodium calcium exchangers. So a part of it, sarcoplasmic reticulum is having the ryanodine receptors, which also responsible for the calcium intake. Once they are just taking the calcium inside, they are just sequestering them with the help of phospholamban, and they will be storing it for the use. And whenever there is any stimuli using this GPCR ligands, they will be stimulating the IP3R receptor, and that will be going to have a small release of the calcium from inside cell. So once there is an altered homeostasis of the calcium happens, likelihood of epilepsy, there is a grotesque increase in the glutamate signals, and this will be going to cause increased intracellular calcium level. So what happens, the mitochondria will be the first one to tackle that one, because they are using it for their internal homeostasis, in the internal like housekeeping functions. So whenever there is an excess level of calcium inside the mitochondria, they will be just incorporating in the Fenton reaction that will help in the ROS formation, reactive oxygen species. And thereafter, once this ROS is more inside the mitochondria, they will lead to the mitochondrial dysfunction. Mitochondria will be having the pore formations that will be releasing the cytochrome C, which will lead to apoptosis and the death of that particular cell. A part of it, this sarcoplasmic reticulum, there are certain proteins are there. There are the apoptotic markers like GPCR, not apoptotic marker, ER stress, endoplasmic reticulum stress markers, GRP7, PERK, ATF4, and CHOP. These all contributes to the execution of the ER stress, leading to the apoptosis of the cell. Furthermore, these ROS as well as some other intracellular signalings, they are inducing the inflammasome pathway, basically the NLRP3 inflammasome pathways. So they are getting activated, and they are again going to cause apoptosis. So once these cell necrosis or cell apoptosis happens, they will be just making the epileptic foci, or they will be leading to the ectopic foci. So it will be just generating the signals. So now my importance is that how this SERCA2B is involved in the epilepsy. Okay, so I have taken two experimental models. One is temporal lobe epilepsy, and the second one is febrile seizure. So in the first aspect, I will be talking how the temporal lobe epilepsy is related to the SERCA-B, and the other aspects will be the febrile seizure. So this is the experimental model of the cells, how the oxidative stress and LPS or inflammation is leading to the what their effect on the SERCA2B protein is. So I'll just directly come on to the data. So here is the, we have exposed the N2SL neuroblastoma cells with the S2O2. They are inducing the ROS level, which was confirmed by the flow cytometry and the fluorescence microscopy. Further, we try to investigate that what is the level of SERCA2B by the immunostaining. So we identified once there is a S2O2 exposure is there, they will be reducing the SERCA2B immunostaining. That represents that there has been downregulation. So further, we confirmed with the Western blotting, we have identified that SERCA2B expression was reduced in the S2O2 group. And it was also confirmed with the genomic data, mRNA expression, that was also indicating that there has been reduced SERCA2B expression. So further, we were just thinking that how they are linked with the ER stress. So here I think you're not able to see the signals. Here the red signals are there.
So that indicates thioflavin staining. Thioflavin is basically going to stain misfolded proteins. So basically they are going to locate your ER stress markers. Okay, it's an indirect marker. And further, we identified that there has been a huge rise in the ER stress marker, thioflavin T staining. And further, we confirmed with the GRP78, PERK, ATF4, CHOP protein. So these four protein, these mRNA expression is there, and they indicate that there has been rise in these levels. So that indicates that H2O2 is causing the downregulation of the SERCA2b, as well as they are just leading to the ER stress. Further, in the next step, we were just interested to see that how neuroinflammation is leading to this one. So for this, we took LPS. LPS is a lipopolysaccharide. So we induced the neuroblastoma cells with this, and we recorded 4 hours and 24 hours of exposure, how they are resulting in. So both time frame, they just resulted in the increased ROS level, and NF-kappa B is a marker protein for the inflammation. So that was also getting increased. Further, we have seen that the SERCA2b expression was also getting reduced. Here we can see that there has been reduction in the SERCA2b expression, proteomic expression, and this is the genomic expression. So these two aspects, they have been confirmed, and further we tried to validate it with the SERCA2b immunostaining. So at 4 hours and 24 hours, the SERCA2b signals were they are less and down. And further, correspondingly, we have seen that whether they have been responsibly increasing the calcium or not. So we stained with the Fura2M, and this Fura2M signal is giving us idea about that how much calcium is there inside the cell. So correspondingly, the reduction in the SERCA2b and the rise in the calcium level is observed. Further, we try to investigate again thioflavin T staining. That indicates that there has been increase in the thioflavin staining. That indicates the ER stress markers are increasing. We confirmed with the Western blot again, GRP78, PERK, ATF4, CHOP, and we identified there has been huge rise. And most prominent rise was observed at 24-hour exposures. Okay, so that indicates it's a good observation. At lower level, you'll not be able to see the proteomic changes. So that's why it was important to see. 4 hours was having less prominent effect, and 24 hours were having more prominent effect. Further, we try to validate it into the experimental model of temporal lobe epilepsy. In this case, we have taken the pilocarpine-induced temporal lobe epilepsy, in which we have induced a spontaneous recurrence status epilepticus. After that, we have stopped the seizures. Then we have segregated the animals. We have sacrificed the animals at 4 hours, 24 hours, and 21 days to see that at what level, what exposure, what they are going to have. We identified that this is a seizure severity that's a common feature. ROS level was increased, and it was continuously increasing up to the 24-hour duration. After that, it was getting reduced. Further, we have seen that IL-1 beta level and TNF-alpha level, both at ELISA and mRNA markers, both are indicating that there has been increased inflammatory markers. So that indicates that there has been rise in the inflammatory markers. Further, we tried to validate with the NF-kappa B. NF-kappa B is inflammatory protein. So again, their expression has also been increased at 4 hours and 24 hours and 21 days. However, slight decline was there in the 24-hour signals. And correspondingly, we have also evaluated the SERCA2b. SERCA2b was significantly reduced at up to 24 hours, and then it was increasing. So we hypothesized that there might be some kind of thing, initial stages, this SERCA2b is imparting the role, and later on it is recovering. But whatever the damage they are just going to make over there, that is persisting for a long time. And after 21 days, we have also monitored their behavior, so there was huge decline in the cognitive behavior. So that was a kind of one feature that was we were trying to correlate. Further, in summary, we identified that there has been some kind of role. So this was the one aspect. And the next aspect, we tried to investigate in the febrile seizure. So febrile seizure is again an important aspect. Why we are working on, because again, there is a high prevalence of the febrile seizure in the northeast states. So I'll not go to start. I'll just talk about the brief studies here. We tried to replicate the febrile seizure by inducing the heat onto the cells. So when we try to expose the cells, we identified that 39 degrees, 41 degrees, and 43 degrees. We expose the cells. At 39 degrees, we seen the proliferation. However, at 43 degrees, we have seen the decline in the cells population. So that indicates that 41 degrees was the optimum to take it ahead. So we took it again, we have analyzed. Similar way, we identified that 24 hours exposure is quite important in this case. So they were increasing the ROS level, mitochondrial membrane potential that was also getting declined. That indicates the mitochondrial dysfunction. Further, we tried to investigate the SERCA2b expression that was also getting reduced. And then afterward, we have also investigated Okay, there is one more thing that we have tried to reverse with the CDN. We have also tried to explore the therapeutics. SERCA2B activator is the CDN1163. So that indicates the recovery from that one. So that rescued the cells from the downregulation of this one, downregulation of the SERCA2B. Further, we try to investigate in the experimental model of the animals. So we expose the animals with the what we can see that this is the experimental model, how we are just exposing the animals with the heat gun, and then we are going to see the seizures. So these are the rectal temperature is rising, and the seizure severity is also rising. So you may be seeing here that how these animals are just leading to the seizures. So in India, nobody is working on the febrile seizures. That's why I was interested much onto this one. So once we are exposing them high heat, these are the pups at 14 days. So they are just leading to the seizures. So this is a kind of one aspect we are just going to explore further. And then we try to isolate the cortex and hippocampus at different time points, 4 hours, 24 hours, 3 days, and 7 days. So we identified that 24 hours is quite prominent, and then afterward it is going to increase, or it is going to like recover. It is recovering up. Further, we try to investigate in the hippocampus. Hippocampal tissue is also going to show decline at 24 hours, as similar as temporal lobe epilepsy we have identified. So same way, cortex, hippocampus is ROS level and nitrite level, these are there. And inflammatory markers are also rising. And after 4 hours, here decline has been observed in the cortex. However, if we see the IBA is one microglial activation marker. So that was also going to get increased, and it was confirmed by the mRNA expression also. And INOS also get increased. So that is responsible for the nitric oxide production. And nitric oxide is one of the marker which is going to have the retrograde signaling towards the glutamate receptor, and that is going to poke the glutamate receptors along with the interleukin-1 beta to potentiate the release of glutamate from there. So similar aspects has been observed in the hippocampus also. Further, we try to investigate that what is the status at different time point in these animals. At 24 hours time point we have taken, because again, everywhere we were not going to repeat that one. So here we identified that it is going to get increased GRP8 and GRP8 protein, mRNA signals, PERK, ATF4, and CHOP. So all the signals are indicating that heat stress is going to lead to the ER stress at 24 hours. Further, we try to investigate the hippocampus also. Hippocampus also similar findings were observed. Then we also observed the NLRP3 inflammasome formation. How is the response of NLRP3 inflammasome? So we identified the NLRP3 one protein aggregate, then ASC protein, docking protein, and the caspase 1 protein, and IL-1 beta is the end marker for this. So all these things are rising up, and then they are going to get reduced. Same, we try to have the rescue study in the similar way, but here we have one treatment group is CDN1163. So CDN1163 is a SERCA2B activator. So let us see that what they are having the effect. So if we see that the SERCA2B expression has been downregulated in the heat stress, now it has been reduced with the CDN co-exposure. So that indicates that there has been reduction, increase in the SERCA2B expression, and reduction in the ER stress has been observed. So similar profile has been observed in the hippocampus also, and cortex also. So that indicates, and here is the NLRP3 inflammasome pathway, so that has also been declined with the CDN expression. So that indicates that all these activities are belonging to, or they are being responsibly held by the CDN, because we have been rescued these studies. Same way, we have observed the similar findings in the hippocampus tissues as well. So overall, in the end, we are seeing up here that the epileptic brain is having all these ER stress, and this ER stress is making the circuit more vulnerable towards the epileptogenesis. And here we are seeing that if we are going to stop this with the SERCA2B, we are intervening the SERCA2B at the early stage, we are able to mitigate the progression of the disease by culminating the oxidative stress, inflammation, as well as ER stress. So this was a better finding. So later on, we got one publication out of it. And I would like to acknowledge the Ministry of Chemicals and Fertilizers, NIPER Guwahati, my director, Dr. U.S. Murthy, and NSERB, now ANRF, that for the generous support of the funding, and Ministry of the Development of Northeastern State for the infrastructure support. And this is my beautiful campus. I welcome you all over there, and thank you.
So one or two questions from the audience, please.
like to answer your first question first. Northeastern state, there has been a lot more groundwater contamination, first aspect. The second aspect is like they are eating more of the pork. So with that, major incidences of neurocysticercosis is there. So that is one of the major lead over there. So that two things are coming up. Now the next question is seizure severity. So we have followed the Racine scale for that, and manual seizure scoring has been done. No, because again it's kind of basic model. Once they are developing, then we are segregating them in the different groups. So whosoever is successfully showing the stage 5 seizure, we are just going to take them. The rest we are just excluding from the studies. So that's kind of major things. Yes, please.
So every time one time.
No, at pup stage, at 14 days of their life, we are exposing them to heat stress, heat shock by the heat gun, and we are monitoring the temperature up to 40 degrees, core body temperature up to 41 to 42 degrees. If they are reaching, they will be automatically showing the seizures at that point. And once the seizure is stopped, after that seizure starts, then we like remove this heat gun. And then afterward, we will be just going to monitor the animals. And after 21 days, they are not showing the repeated seizure, but they are showing the seizure-related comorbidities like cognitive deficit and others.
Thank you. Down regulation. So the calcium homeostasis is changed. Is there any drug that can rebalance the normal calcium homeostasis?
Sir, first, one drug is there already, ethosuximide, that is being used in absence seizures, basically the childhood epilepsies. Still, I have to search that what is the role of other calcium things. But here I am talking about the most prominently SETA2B, which is intracellular. CDF and istroxine is already like in the phase 3 clinical trial for the stroke and myocardial infarction. So that is a huge development, and if we get some kind of lead, then it will be kind of helpful. But we can also explore it for that.
Very core mechanism you have explained. So ultimately, it will be translated to patient care.
Yes. Now the next scope is taking the patient samples. So we are connected with the IPSCON Guwahati. So we will be taking up.
But I know that people publish very good work in the PhD, then do 1 or 2 publications, then that research comes there, then they go to another institute, start something different. So this research is actually not useful for translational studies. So we have to work here and define your area and work further so that you can reach a conclusion. हम हर बार 200 फीट के 100 कुआं खोदेंगे, 200 फीट का तो खुदाई हो गई, पानी नहीं निकलेगा। तो एक कुआं खोदेंगे 200 फीट का, कुछ तो निकलने की उम्मीद है।
Actually, I chosen this that in the Indian scenario, nobody is working on fibrosis, first of all. And even if I see the global scenario, 2-3 people are there who are just validating this model. So we try to learn from them, and we are trying to replicate very
atypical study that you have mentioned, and
because most of the people are not being successful in the epilepsy. So we are trying to investigate whatever the things are. Let us see how much we are successful. And again, nextly is based upon, as we are on the Northeast biodiversity, so we'll be trying to explore the herbal medicines and how they are going to target the SETA2B. If there could be some leads, so that is
medicine available on Northeast.
So there are, but the claims are there.
Area actually.
Yes.
You have to look forward.
Yes, sir. Yes, sir. There are many more. But still, whenever we are just going to take their claims in animals, humans, they are not very clear. So that's kind of quite challenging. So still, but we are working on some kind of plant extracts, and we are just trying to work on also some specific molecules which are very more on plant.
You kind of extracts find what exactly that.
So we are, with the help of docking, we are targeting the SETA2B molecules. Some flavonoids are there. We are having the promising results. So we'll see next future.
Please give him a big applause.
Thank you, sir. Thank you, ma'am. Now I request the chairperson kindly felicitate Dr. Avnish Mishra. Next speaker we have Dr. Fatima Begum.
welcome Dr. Fatima Begum. The title of her speech is called Lab to Life, Translating Pharmacological Research into Impact. Dr. Fatima Begum is an assistant professor in the Department of Pharmacology at Geneva Pharmacy College and Research University. She holds a PhD and has published more than 30 research articles with her work focused on pharmacological mechanisms in bone healing, diabetes and molecular pathways such as SIRT-mediated signaling. Her research also explores the therapeutic potential of plant-derived molecules, including investigating bioactive compounds for improving diabetic foot ulcer healing. Please start, Dr. Fatima.
Thank you so much, ma'am, for the kind introduction. Thank you, IPSCON, for the opportunity. With the permission of the chair, shall I go there? Because this is basic only. So shall I go there and interact with the students? Thank you. Dear students, the topic which I choose is actually for you all. This is for the young minds, for you all. Did you have any idea about what is translational research? Did you have any idea about what is translational research? From lab to the patient, that is known as the translational research. So all the research which we are focusing in the lab, it should reach into the hands of the patients to produce an impact. The impact is produced. When the impact is produced? Yeah, when the patient gets the benefit. That should be the aim for all the researchers. The benefit of the patient. So that is what is explained here. Translating pharmacological research for the patients. Patient-centric approach should be there. So, the sessions that we discussed today, I'm not reading. Introduction part, what do you mean by translation, then everything we will discuss today. I will shorten and I will discuss. So, coming to the first introduction part itself, I am giving the thought of Louis Pasteur. Have you heard of Louis Pasteur? Who's that? Yeah, pasteurization. So, science knows no country because knowledge belongs to the humanity and it is the torch which illuminates the world. The need for collaboration. Because is the COVID-19 only came in India? No, the whole world. The whole world sees the disease. The whole world sees that lockdown process. So science is globally. That is explained here, and that is my thought only. From the petri dish to the patient's hands, the translation brings the knowledge into impact. You are sleeping? No. Yeah, so that's it. So coming to the pharmacological research, what is pharmacological research?
Sorry to interrupt you, Dr. Fatima.
Yes.
You have a time limit.
Yeah, I will finish my answer. Yeah. So what is pharmacological research? You may be knowing. Pharmacological research is nothing but the drug has to, how the mechanism of the drug will in the body, how it is act and how it is benefit to the individual is studied. And it has role in all the things. Can anyone say pharmacogenomics, what it has role? The pharmacogenomics means the whole genetic constitution of the whole genetic constitution of the organism is taken, and based upon that we are preparing the treatment. The very good example is the precision medicine. Have you heard of precision personalized medicine? There, the whole genomic data will be taken and the genome is analyzed so as to give the personalized therapy. What was the advantage of that? Minimize the side effect, maximize the potency, that is. So pharmacological research has all these applications. The research and the innovation which is there in the bench test. What is in the bench test? That potent molecule which we conduct research, it should go for the clinical development, finally personalized or precision medicine in which I give any example for precision medicine? Because news, so many news are going on now. Updated news are going on. Precision therapy. One important precision therapy is there, in which, have you heard of HER positive breast cancer? Trastuzumab is used, that is precision medicine based upon the individual, the treatment is given. Then comes the global health impact, the impact in which that particular research has, how it maximizes the efficacy and reduce the side effects. Then comes the importance, as I told you, science finds answers and translation always gives purpose for that answer. This is the history. I am not going in detail. This is what you can see. After 1945, in case of penicillin, what is the impact? Global impact is followed. Then comes the translational continuum. What is translational pharmacology? We are using the pharmacological research. The knowledge from the pharmacological research should reach into the hands of the patients. The scientific impact should turn into a clinical outcome. That is what is discussed. Then objective is, you may be knowing, it bridges the basic science, the basic theory with the clinical practice, then predict the response of humans, then impact to the patient, outcomes also. Here what you can see, from the bench to the bedside, the treatment has to reach into the hands of the patients. So what is there in the bench? We are identifying the molecular pathways, we are identifying the molecules, we are studying it, what we are doing in the lab. Then a translational bridge is there, after that which it will move to the clinical trials, followed by the post-marketing surveillance, and finally global impact. So from bench to bedside, what is the difference between basic pharmacology and translational pharmacology is, basic pharmacology always studies the mechanism of action, but what translational pharmacology deals with, it deals with how it interacts with the patients, the dynamic, the kinetics, everything, and how it comes as a clinical outcome. You can see, I am not discussing in detail about the drug discovery process, because all may be knowing that the process of drug discovery starts with the target identification. We have to identify one molecule, which is followed by the verification or optimization of that target. Then third one, what it was, after that one lead or one particular molecule. Target is always the protein. Then our molecule has to be identified, which acts on the particular pathway, which is followed by the next is what, that molecule has to be optimized, which is followed by that optimized kinetic potent in silico studies will be there, and that ADME containing or a potent molecule will comes into the preclinical studies, in which so many studies are conducted in the animal models, alternate animal models, which will finally reach into the clinical trial. So that is the discovery process. Approval, once it is approval, it will reach into the hands of the patients. So this is translation means it is a dynamic continuum. We can say it is linear in theoretically, but in practical it is not linear. It is iterative, it is dynamic, and it is multi-directional. The translational science is divided into T1, T2, T3, and T4, where the first is basic research, converting it into humans, the preclinical studies in T1, which is followed by the T2, in which phase 1 clinical studies with limited patients is done, which is followed by the T3, phase 2, phase 3, and finally T4 studies, in which that particular therapy will reach into the hands of the patients. That is the translational research. The best example I could give for you is the mRNA vaccine. What is mRNA vaccine? Moderna's, Pfizer's mRNA vaccine. It took how much time to reach into the market? It took less than 1 year to reach into the market after the outbreak of COVID. So what I could say here is, by the integration of artificial intelligence, then with the help of machine learning, all what happens, the huge drug discovery time of 10 to 15 years was reduced to less than 1 year. That is the translation in the future. With AI virtual screening, the time period is reducing and we are getting the potent molecule to the benefit of the society. So here you can see the basic research is mRNA. mRNA has been, what happens when mRNA reaches to the body? It gets translated into the protein and viral protein will be produced. Against these viral proteins, antibiotics will be produced. That is the basic research which is followed by the T2 in which T3 as well as finally that research reached into the community. What is the benefit? It is benefit to the whole human organism. Then drug discovery, I am not explaining in detail. You all know about drug discovery process. High throughput screening has revolutionized the drug discovery process. The time has been decreased and the efficacy has been enhanced a lot. Then comes the AI integration, machine learning integration, which I explained in this graph, which is new translational research importance. Clinical phases you may be knowing already we have discovered, and precision medicine also is an important part in the translation. Precision applied to translation give maximum benefit. Precision medicine. Then we can see here human protein, how it reaches into the population. From lab, examples also is given. This is emitinab, which is a drug, which is an anti-cancerous drug that is used. And due to the potency, due to the translational research and the advancement in the field of translation, it reaches into the market and the efficacy is more than 94%. Then regulatory is there, which are the regulatory? FDA, then EMA, all regulatory aspects, CDC, SCO in case of India, all is there. Then comes the last session in which the precision medicine is having an important role in translating the research, and that is very important. Translation, precision medicine is widespread, getting more attention nowadays. Then comes the translational precision medicine, individualized therapy rooted in the molecular science. So the final thing, molecular profiling, what it aims in the targeted treatment. Then comes the machine language uses and AI uses. Finally, what is this impact innovation is doing? Innovation is reducing the impact, the time, the cost, everything. That is it with the help of AI. But even translational research has certain disadvantage. That is the barriers, resource limitations. Then lessons from COVID-19 is saying that both adaptive regulation address the systematic inequality is very essential for the future. And this is translational therapy and reverse therapy. So in concluding the session is nothing but this. The molecule that we studied in our laboratories should not stop with a publication. It should reach into the hands of the patients. That is the top thing I need to convey. So thank you so much.
Stepwise processes for drug discovery, precision medicine and targeted therapy. So this will definitely help you in your Viva at least, because it is what she said is about a 30-40 year program. Drug discovery is a very long and tedious process. From bench to bedside, that takes a lot of time, effort, money and all, and it is a big teamwork. And she said in 20 minutes, so that is not as simple as it looks, but she has made the difficult task looking very simple. Thank you, Dr. Khadi. Any questions from students?
Thank you, sir. Thank you, ma'am. I request the chairperson kindly felicitate Dr. Fatima Bekar. Last speaker of this session we have Dr. Jyoti Upadhyay.
Dehradun. She coordinates Adverse Drug Reaction Monitoring Center. Then she has a lot of interest, including maternal and child health, neuroscience, pharmacology, pharmacotherapeutics. Then she had DST funded initiative to build community COVID resilience resource centers in Dehradun, and a lot of publications for her age. 40 research review publications in various index journals. And her topic of presentation is computational exploration of bioactive compounds from Aspergillus racemosus to postpartum depression.
Thank you, sir. Thank you for the introduction. First, I would like to thank the organizing committee for giving me the opportunity to present my work here. A very good afternoon to all of you. As you know, my topic is computational exploration of bioactive compounds from Aspergillus racemosus for postpartum depression. So, why postpartum depression? As you see, postpartum depression is the onset of depressive episodes after childbirth, develops at a critical moment in a woman's life and can contribute for long periods. If you can see the global prevalence of PPD, that is 10 to 15%, and it occurs in 22% of mothers in India. Here you can see the pathophysiology in figure 1. What is the basic pathophysiology of PPD? That is, it involves hormones, it involves gut-brain axis, it involves neurogenesis, neurotransmitters, genetic and immune system. So whenever, like during the gestation period, there are so many hormonal changes occur in female body. There is sudden rise in estrogen and progesterone. And after delivery, there is a sudden decline in these hormone level, which along with the immune system and other parameters like neurogenesis and neurochemistry, which is being caused by lactation, can cause the episodes of depressive episodes like mood irritation, irritability, sadness, right? And in figure 2, you can see there is a changes in the hormonal level during the gestation period as well as after the delivery. There is a sudden decline in these hormone level, which causes changes in the, you can see the neurotransmitter level as well as there are certain neurosteroids which are responsible for maintaining the mood and behavior in females. So these are the pathophysiology of PPD. Now, why there is a need of this Aspergillus racemosus? As you know, it is shatavari and it is a herbal medicine which is having a lot of effects that helps in like it is being reported that it is used for hormonal imbalances in many of the females. So why I go for this? Because I want to know which phytoconstituent is responsible in regulating the PPD, and I have used network pharmacological approaches and molecular docking to identify which phytoconstituent which is present in this Aspergillus racemosus is causing, an improvement in the PPD. Postpartum depression, right? So you can see the problems with the existing therapies. The SSRI are being used for the treatment of depression, the selective serotonin reuptake inhibitors. But you can say the normal depression, there is no involvement of estrogen, progesterone. Like in PPD, there is involvement of progesterone, estrogen. So the mechanism is totally different in PPD as well as in the normal depression, what a person is having. And the SSRI, which is being given to the pregnant females, it is having moderate efficacy. As well as, like if you can see, 2 drugs which are zuranolone and brexanolone. These are the synthetic allopregnanolone, which are not available in India, and they are very much costly drugs. And how they work, they are the neurosteroid analogs. They help in regulating the allopregnanolone by activating the GABA receptors, which causes calmness in the females. But these 2 molecules are not available or they are very costly. So that's why I want to explore the herbal plant compounds, bioactive compounds, which can have this effect, as well as they can be, further explored for the product development in the treatment of PPD for the females. Now, what methodology I have used? First of all, I have screened the phytoconstituent with the base, depending upon the literature data, what we have, and the database, what is impact. We have screened the phytoconstituents of the Aspergillus racemosus, and then we go for drug likeliness, toxicity prediction, ADMET analysis, and target prediction. As you have seen in the previous sessions, Like the first session you have seen, the sir has used ADMET analysis and network pharmacology for the identification of phytoconstituents, right? Even after that, the network pharmacological approaches has been used where the protein-protein interaction network is analyzed, CAG enrichment and gene ontology databases are being used to identify the proteins which are disease-related and to identify the proteins which are phytoconstituent related, right? Then we have filtered the active phytoconstituents on the basis of ADMET analysis, on the basis of toxicity data. Then we have done the molecular docking and molecular dynamics simulation studies. Now this is the flowchart representing the phytoconstituent screening based on toxicity, drug likeliness and ADMET. So phytoconstituents, you can see we have used the literature as well as the databases impact. Then filtering based on drug likeliness and ADMET. Then filtering based on toxicity. Toxicity parameter, what we have chosen is carcinogenicity, immunotoxicity, cytotoxicity, mutagenicity. And at the end, we have shortlisted 2 phytoconstituents out of 46. After this filtration we have applied. Now the phytoconstituents which are responsible, they are camphorol and asparagine A, right? And you can see the shortlisted phytoconstituent and the key filtering parameters, the molecular weight. We have followed the Lipinski rule of 5, and you are all aware the molecular weight should be below 500. And the quantitative estimation of drug likeliness, which is also very good here. You can see the blood-brain barrier permeation, both are having this property, as well as the bioavailability score. Then we have also seen, is there any interaction with the cytochrome enzyme? So asparagine has some inhibitory effect on cytochrome P1A2 and 2D6. And also the solubility, you can see it is moderately soluble, which is a good parameter. And then the partition coefficient is also good for camphorol. Now this is the phytoconstituent targets. So what we have done, we have like these phytoconstituents, we have identified the protein which are having association with these 2 phytoconstituents, camphorol and asparagine. And through validated targets, we have used database binding DB, and predicting targets, Swiss target prediction we have used. So 268 targets in total for all 2 phytoconstituents have been identified. And then we have also validated and predicted DisGeNet and GeneCard, and we found 910 targets for PPD total after removing the duplicates. Then we have used Venn diagram, and we see how many proteins are overlapping with each other. And you can see here 81 proteins, they are overlapped for PPD specific gene targets. And in the figure 4, you can see the top 20 signaling pathway with related gene found through CAG enrichment analysis. CAG enrichment database will give you the mechanism or pathway which is responsible for particular gene, right? Now, this is the protein-protein interaction. Swiss target prediction is used to identify the protein-protein interaction as well as the number of nodes, right? You can see 10 hub nodes were identified through PPI network analysis, right? And you can see here this one. These are the 10 hub nodes obtained through the degree centrality analysis on the protein-protein interaction by using cytoscape, and this is the PPI network. Now here you can see the proteins, and here the camphorol, it is having very good binding affinity. You all know the binding affinity. After molecular docking, we identify the compound on the basis of binding affinity. You can see here the camphorol is having good binding affinity with PTGS2, which is the, you can say, COX2 enzyme, which is responsible for inflammation. And here also MAO-A, it is also having minus 9.7 binding affinity. You all aware about the MAO-A enzyme, which is responsible for the degradation of the neurotransmitters. Now here, this is the, you can see the docking part. This is the 3D and 2D visualization of camphorol, MAO-A complex through molecular docking. And 3D model, what it demonstrates? It demonstrates that camphorol sits very firmly inside the enzyme active site, and 2D, it shows the hydrogen bond and hydrophobic interactions with the key amino acids. And this is with the PTGS2, which is the inflammatory enzyme gene which is responsible for inflammation. And here also you can see the 3D and 2D visualization the same way, where this is for MAO-A, the camphorol. Now this is the molecular mechanics, generalized bond surface area, and this is the visualization of empty simulation. What this represents, the value of less than -8 kilocalorie per mole, that confirms that these interactions remain strong even under physiological conditions, right? So why we are doing molecular dynamics? Because once the docking is confirmed, it is very important that the surrounding protein can destabilize the docking molecules, the compounds which are responsible. So we need to go for molecular dynamics. We have to check whether the compound is stable or not. So we have to check these parameters. The root mean square deviation of the selected complex simulated for 100 nanoseconds. Here also you can see initially fluctuations, but later on you will find the structurally stable the interactions with the MAO-A and camphorol, and this PTGS2 and camphorol. Now here also, this is the radius of gyration. This is also one of the parameters for molecular dynamics, and it is also representing the presence of camphorol, that it does not destabilize or unfold the proteins. Like it gives you an idea whether it is affecting the protein structure or not, right? Now, this is the principal component analysis, PCA, of best docked complexes from post-dynamic results. The tight clustering of the trajectories, it indicates minimal fluctuations and more stable protein ligand dynamics. So, what I want to conclude from overall this computational approach is that camphorol, out of 46 phytoconstituents, it is one of the best compound which is helpful in treating PPD. And if you have used databases, you have seen there are a number of proteins, right? So it's very easy to identify phytoconstituent and the proteins which is very, the good binding affinity you can check through docking studies that will help you in identifying the novel compounds, right, that are responsible for treating a particular disease or a disorder. And after that, we'll go for in vivo study. In vivo we have done in PPD model, but still we are waiting for the results of this PPD. Now we'll also move for the formulation of that product. Thank you, sir. Thank you, ma'am.
From Salavari. So, as a pharmacologist, I have little bit of only knowledge about Salavari, that it is a very, very active molecule. A lot of molecules are there active. Herb in Ayurveda. So, what is the reason for choosing Salavari?
Because, sir, it's a female.
Do you have any prior
yes, actually, sir, my father-in-law, he is he was also a researcher in CCRS. He said this Salavari, it is having very good effect on female bodies. It is female hormones level. So that's why that idea came into my mind, that why I have to explore the Salavari plant for female related diseases.
But it is hypothesis that postpartum depression is not due to loss of sudden reduction in the hormone level. It's multifactorial.
Yes, sir. Yes, sir.
Only 5% people may be having clinical depression. There may be mood swings after depression. That is why breastfeeding helps in recovering faster from this depressing episode. So we have to actually go deeper into the mechanism and pathophysiology of postpartum depression. It is not related to clinical depression, which occurs without any reason, primary depression symptoms. So definitely this is a very critical work. Now the question is, what is the way ahead? What you are likely to do further?
So
don't stop here.
Yes, sir. My student, she already completed the animal model study, but we done the metabolomics. We ran brain samples, and we are waiting for the results. When we get the results, and we go for we have also patented the methodology. We have patented, and we go for the product development.
Isolation or docking?
Sir, Salavari, we'll show the animal model study. We have not shown yet. We have taken the extension, and we'll prove that this compound is responsible for this PPD disorder, and then we'll go for some product development. Yes, ma'am, because increased level of prolactin increases the dopamine level. There is an inverse association between prolactin and dopamine.
They are being prescribed the Shatavari and Ayurveda. Yes, ma'am. And the results are really good. Yes, ma'am. So I'll explore this one. Let's see.
So I can give you some my thoughts that don't stop in postpartum depression. Also look for the postmenopausal depression. That will be another area where there is a lot of mood swing, even suicidal tendencies there. So that you can share someone's life. So that is more common than postpartum depression. Right. So you can look forward to further areas.
Yes, sir. Yes, sir.
And that cases will be found many postmenopausal depression.
Yes.
Thank you.
Thank you so much, sir.
Thank you, sir. Thank you, ma'am. I request the chairperson kindly felicitate Dr. Jyoti Upadhyay.
Then you isolate the compound, like investigator initiated study के plan कर सकते हैं. Thank you. All the best. And with this, the session is.
Yes, sir. We'll start our next session in another 5 minutes. Now I request Dr. Amita ma'am to kindly felicitate our chairperson. I request ma'am to kindly felicitate Dr. Nidhi Goyal. Ma'am, kindly felicitate to Dr. Debashish Hutta sir. Thank you, sir. Thank you, ma'am.
Campus. And Anil is a good friend of mine since 2000. Ever since I joined this institute. Very nice campus. Yes, sure. Mangalore. You must be having a lot of fish. I like kingfish.
आगे आ जाओ.
Mangalore. Udupi. Net campus. Same complex. We have that place many times, but I have never been so big. There is one sunset point I visit every time. That is what I like. You can see the hilltop. It is a bit scary now. Tiger. Leopard. But I like that place. स्टैंडर्डाइज करना भी थोड़ा सा डिफिकल्ट है, बट पता चले वही मेरा बिगेस्ट चैलेंज
अटेंडेंस तो नहीं लग रही है। हाँ जी
gut-brain infections, modulating mental health, with probiotics, prebiotics, and symbiotics. As we know, there is an increasing importance of the probiotics for the gut health and immunity. So let us hear the interesting talk from the Dr. Kanti on the what is the emerging evidence on the gastrointestinal health as well as the immunity development. Thank you. Dr. Kanti, please.
Yeah. Thank you to the both chairpersons here. And at the outset, I would like to thank the organizers for giving this opportunity to me to discuss about some of the preclinical findings that are ongoing in our laboratory. And a little disclaimer to this conference is like, I'm a microbiologist, but I'm trying to work at the interface of microbiology, biochemistry, pharmacology, and bioinformatics. So in the process, I have been helped by several colleagues, and one of them is sitting here, Dr. Mahendra Vishnu. So I will be discussing about the gut microbiome and its alliance with the brain, how the microbiome contributes to the functions of the brain. So I work at this institute, National Agri-Food and Biomanufacturing Institute. So this cartoon represents the work, in summary, what I have been working. So my overall goal is to improve the gut health by preventing the leakage of the gut. So we all know that there are increasing incidences of non-communicable diseases, and according to a recent Lancet paper published in 2021, which says that in India, the neurological problems are also increasing, and it is posing a tremendous burden on the economy of our country as well as the progress of the country. So as you see here, before there were high incidences of communicable diseases which are infectious in nature caused by pathogens. But over the time, we have seen a steep increase in the non-communicable diseases. And when we say non-communicable diseases, these are like related to lifestyle and brain functions, etc. I am sorry, these are very small images or letters, but the crux of this table is among the non-communicable diseases, neurological diseases are on the rise, and 82% of the neurological diseases are non-communicable in nature, and minority contributes by the infectious diseases as well as injuries. So there are medications which control the neurological functions, but however, there are some side effects, although I don't undermine the pharmaceutical interventions, but they are associated with the side effects. So our overall understanding and aim is to reduce the burden of the therapeutics by developing adjunct treatment or prevention regimes. So when we talk about gut microbiota, so it is total population of the microorganisms inhabiting in the gut. Nevertheless, the entire human being on the surface as well as the internal milieu is occupied by huge diversity of the microorganisms. So on here I have listed some of the microorganisms which are abundant near the oral cavity, some of them near the stomach, and most populated area is our large bowel and the small intestine, which are harbored by trillions of the bacteria. So when they are sitting there, what are they doing? So they are eating basically what is left out from what we have been assimilating and deriving the energy from that. So if you consume a good balanced diet, microbes also eat balanced food, and your gut will be healthy in a layman's language. And the microorganisms in the gut near the lining sits in the mucus layer here, and they communicate with various cells, including the immune cells as well as the penic cells and some of the enteroendocrine cells that produce the thyroid hormones, as well as they also communicate with the nervous system. So we all know that the largest nerve that is running across the length and breadth of the body is the vagus nerve, and it has its innervations. It starts in the brain and has its innervations all over the body, including the gut. So the organisms that are sitting here produce various bioactive molecules and stimulate these nerves and produce or stimulate the release of oxytocin, GABA, BDNF. So there is a bidirectional communication. So molecules produced in the gut communicates with the brain, as well as some of the molecules that are, or the signals that are emanating from the brain gets communicated into the gut. So there is a nice bidirectional communication that happens between the gut and the brain. So there are several and many researchers have reported that any instability or called dysbiosis, loss in balance of good bacteria and the gut, bad bacteria in the gut, leads to or associated with several diseases, for it, including non-communicable diseases like obesity, diabetes, and many others. And in recent past, if you see this slide, there have been increasing studies targeting the microbes and the gut and the brain axis. That may be related to immune function, boosting the immune function, or through neuronal activation, or through by merely improving the gut environment. So the leaders in this area of research, development of gut-based interventions and bacteria that can influence your brain, USA, as you see here, stand alone, and this is our country. So there is a lots of opportunity in front of us. If we can have the microbiome composition of our human guts, so we might be able to decrease the disease burden that is associated with the neurological problems. And along with drugs, standard drugs, we might reduce the burden of the drugs as well. So the basic problem is, although there are so many studies, but most of the studies randomly uses the bacterial strains called probiotics. There is no history like why this has to be selected as a bacterium that can influence the minds. So there is no rational, but what they have understood is by improving the tight junction proteins and leaky gut, so somehow these molecules or bacteria is able to communicate with the enteric system, and the signals that are being generated here communicates to the brain and regulating the brain function. So there is a lots of lacuna that creates an opportunity for us to explore the Indian origin strains to be used for modulating the gut. So this is one of the interesting studies that has been published very, very recently in Cell, Host and Microbe. The basic summary of this is they have engineered a bacterium to produce L-DOPA, and we all know the purpose of L-DOPA. L-DOPA gets converted in the brain into dopamine, and that plays an important role in reducing the Parkinson's disease. So here what they have done, highlighted the summary of that word, oral administration of the engineered bacteria, it releases L-DOPA continuously but not abruptly, and hence it lowers the symptoms associated with the Parkinson's disease. So these are all various experimental summarization what they have done. And in another interesting study, it has also been published very recently, there is a cocktail of bacteria people have identified, and this bacterium is able to synthesize serotonin, a neurotransmitter, using tryptophan. So you see, the bugs that are sitting in the gut is producing the chemical messengers that could either communicate with the enteric nervous system or can cross the gut barrier, enter it, and cross the blood-brain barrier and influences the brain functions. And you will appreciate that majority of the neurotransmitter production happens in the gut. 95% of, for example, serotonin or GABA or L-DOPA is being produced in the gut. So there is a lot of scope where we can identify the organisms which can produce the neurotransmitters and analyze them, how they influence the brain function. So in the coming slides, I will quickly summarize what we are working at the lab. So we have identified a bacterium called Lactobacillus brevi, and this bacterium is a gram-positive rod-shaped bacterium. This bacterium is able to produce gamma amino butyric acid, which is an inhibitory molecule in the gut. So this has lots of industrial importance as well as medical applications, and we have optimized, not yet completely optimized, but we know that under standardized conditions, this organism is able to produce 19.6 grams per liter of GABA. So to understand whether this bacterium is able to prevent the neurological diseases, so one model we have selected is epilepsy model. So when we have done our literature review, many of the people are working on Alzheimer's disease and Parkinson's disease, but there are less reports on this. So we have used this as a pre-treatment a model in PTZ-induced epilepsy in the rats, and according to our results, compared to the standard valproic acid treatment, this bacterium is also able to reduce the severity of the epilepsy, which is indicated in the form of a resin score. Lower the resin score, lower is the improvement from the epilepsy. So we also estimated the short-chain fatty acids in the serum, in the blood, in the colon. We saw that there is an enhanced production of propionate and butyrate, which has lots of applications in preventing the inflammation and various purposes through regulating through the short-chain fatty acid receptors such as FFAR2, which is GPC43 and 41. So these proteins have been, expression of these have been reduced in epilepsy, but we have given the treatment with this bacterium and a dietary fiber rich phytonutrient, so that is able to stimulate the healthy gut bacteria. So as I mentioned here, PTG increases pentylene-tetrazole treatment increases the bacteria which causes or associated with the epilepsy. These are the ones, and the treatment with this bacterial blend decreases the abundance of these bacteria and promotes the growth of these bacteria. Through short-chain fatty acids, we are suggesting as possible mechanism that prevents obesity, and it has also reduced the inflammation in the colon. Most importantly, spine density has been improved in the brain regions, especially in the hypothalamus. So we saw that there is a decreased GABA production in the gut as well as in the cecum in the and the PTZ treated animals in the serum as well. But supplementation with the GABA producing bacterium enhanced or restored the levels of the GABA. So this is just a representation. Can someone speak? Just a few seconds video. This is the PTC treated animal, and this is the symbiotic, and this is the drug treated animal. You can see the difference. So we are also working in other brain functions, which I am not going to do yet. And finally, I would like to thank the IPSCON 2025 for giving this opportunity. I would like to thank my collaborators from Nabi, Mahendra, and external collaboration from Dr. Chopra and Shyam Sharma. And this is the student, Tushar Mandal, is sitting here, who has done this, our collaborative work. And thank you, one and all, for listening.
Thank you. Any questions? No. Dr. Kanti, just for my information, that very interesting data. Have you also analyzed the functional profile after giving the symbiotic to the PTZ-treated animals, along with the standard course of the epithelial?
No, that experiments we are going to do. This is the initial studies what we have.
Okay.
And there are series of mechanism-related studies, and what you have suggested to test.
That would be very interesting finding, because then you can recommend if whatever people are, those who are taking the standard anti-epileptic course, because these comes into the standard literature categories, probiotics. If they modulate certain function through the GABA mechanism, that is beneficial.
Yeah, that's what. Certainly we will take care of that part as well.
Great.
I have one question. So you have studied in only one model?
Yes.
Do you plan to study more than again?
There are various models, but we haven't really gone to this.
But you can explore, because PTZ is represent only the one type of the phenomenon. That is called chemical engine.
Yeah, there are brain injury related epilepsy and other stuff. But we don't have that facility because we are in a small animal house we have at Nabi. But over the time, I think different.
Still, very interesting.
Yeah.
Very interesting.
Good. Thank you.
Thank you, sir. Now I request the chairperson kindly felicitate Dr. Kanti Kiran. Next Dr. Kasif Hanif.
Hello. Our next speaker is Dr. Kasif Hanif. The title of the talk is the fatty acid synthase and emerging target for the cardiovascular conditions. Kasif Hanif is a senior principal scientist in the division of pharmacology at CDRI Lucknow. He completed his PhD from the Institute of Genomics and Integrative Biology, Delhi. His research focused on the pathophysiology of pulmonary hypertension, including the role of DNA repairing enzymes, and de novo fatty acid synthesis and metabolic remodeling in vascular and right ventricular dysfunction. So welcome, Dr. Kasif, and please.
Thank you. At the outset, I would like to extend my sincere thanks to organizers. So my topic, as you see here, that it is the role of fatty synthase, that is the enzyme involved in lipogenesis in the cardiovascular diseases. Next slide. So pulmonary hypertension is a rare hypertension. Generally, we know about the systemic hypertension that we generally have in our family, society. But pulmonary hypertension is increase in the pulmonary artery pressure more than 20 mmHg, and it happens in COPD patients or at high altitude. So this is a pathophysiology of pulmonary hypertension in which there is extensive proliferation of pulmonary arterial smooth cells and the endothelial cells, which results in the decrease in the lumen of the pulmonary vessels, resulting in the increase in right ventricular pressure. So there are number of drugs are already available, and but all of them show some limitations, and that's why the new therapies are needed. So here I am talking about the fatty synthase. This enzyme is responsible for the conversion of acetyl coenzyme A to palmitate, and this palmitate is then used in the synthesis of the lipids, and it is transported into mitochondria by CPT1, where it undergoes the beta oxidation, and that it becomes a part of the TC cycle. So this enzyme is so far its role has been extensively studied in cancer cells, because proliferating cancer cells need cell membranes, and for cell membranes lipids is needed. So this enzyme is highly expressed in the cancer, and in fact one clinical trial is also already going on with a fast inhibitor MV2640, and other fast inhibitor with danifistat and are also under clinical trial for fatty liver. So we try to explore the role of this fatty synthase in our pulmonary hypertension, and for this we developed a model of pulmonary hypertension in which a substance monocrotaline is which is isolated from a plant, Crotalaria spectabilis. It's injected into the animals, and this monocrotaline causes damage to the endothelium of the pulmonary vessels, which after a period of 35 days results in increasing the right ventricular pressure. And we have seen, and on the other hand, for the in vitro studies, we used human pulmonary arterial smoothing cells, and we exposed them to 1% oxygen, thus creating hypoxia. So for as you can see here, that following hypoxia, there is increase in the FAST, and siRNA of FAST is decreasing, FAST expression as FAST activity, as well as the level of the palmitate, which is the product of the fast catalyzed reaction, and melancoenzyme A goes down following hypoxia, but fast siRNA increases this. HIF1, which is a marker of the hypoxic environment, it goes up following hypoxia, but siRNA decreases this. And as you can see here, that following hypoxia, there is increase in the proliferation of the pulmonary arterial smooth cells, and the fast siRNA is decreasing them. And there is a dysfunction of the mitochondria also following hypoxia. As you can see here, decrease in the mitochondrial ROS, and these number red cells show the mitochondrial ROS. So mitochondrial dysfunction is happening, as if further is evidenced by increasing the expression of the TMRM in the hypoxia, and ATP concentration is going down, you can see here, and fast siRNA is improving. So that shows that following hypoxia there is dysfunction of the mitochondria, and fast siRNA, that is siRNA mediated inhibition of fatty synthase, is improving the mitochondrial function. So other markers of metabolic dysfunction we can see here, that pyruvate dehydrogenase, which is a marker of the glucose oxidation, because it is converts pyruvate to acetylglucoenzyme A. So you can see here that in hypoxia this is going down, and following siRNA mediated inhibition of fast it is going up. And other markers of the glutamine, phospho-GSK-kinase, GSK3 beta, they are also going up, indicating that glucose oxidation is going down while the glycolysis is going up. Insulin resistance marker also increased, like AMPK, and AKT went down, PPR gamma went down, and fast siRNA improved them. Now coming to the animal model. So in animal model, after 35 days of monocrotaline, we found increased right ventricular pressure. You can see here that in MCT, in normal rats, there was right ventricular pressure was around 20 mmHg, but following this MCT, there it touched around 40 mmHg. And its pharmacological inhibitor of fast, which is C75, decreased the right ventricular pressure. Oxygen saturation we measured by a small animal pulse oximetry. You can see here it goes down, and fast siRNA is restoring this oxygen concentration. Similar to the in vitro results, you can see here that following in the MCT rats, in the pulmonary hypertensive rats, fast expression is going up. In the immunofluorescence also, but it is following inhibition by C75, it is decreasing, and fast activity is being increasing. The fast activity is also being prevented by siRNA, and the lipids like merocoenzyme A is getting decreased, indicating increased fast activity, and palmitate level is also going up, again indicating fast siRNA, increased fast activity, and all these things were restored by fast siRNA. And you can see here that there is increase in the pulmonary vessels. This is a pulmonary hypertensive rats. You can see that this vessels wall is not that thick, but in pulmonary hypertensive rats the wall thickness is increased, and by C75 is again restoring the thickness of the vessels wall. And this change in the vessel wall thickness is taking place due to the PCNA, that is the proliferation of the cells, which is and PCNA is a marker of that. These are same results that we have shown you in the in vitro, that glucose oxidation is going down in the pulmonary hypertensive rats, which is being restored by C75. Oxygen stress went up in pulmonary hypertension, and fast siRNA decreased that. And then we isolated the pulmonary arteries from the lungs, and we found that there was more constriction of the pulmonary arteries in the pulmonary hypertensive rats. You can see here that this is a normal, and this is pulmonary hypertension rats, the blood arteries, pulmonary arteries of the pulmonary hypertensive rats, and following this C75, the relaxation has increased. So that means that fast siRNA is improving the vasorelaxation of pulmonary arteries. And then we checked the effect of the fast siRNA on the right ventricle thickness. In pulmonary hypertension, instead of the left ventricle, what happens, there is increase in the right ventricle thickness. You can see here in the MCT there is increase compared to this control, and C75 is restoring this. Other marker like right ventricular mass, ejection fraction also improved by fast siRNA, and all the markers of right ventricle thickness also improved by fast siRNA. And apart from us, another group, Chinese group, took because ours was the first group which explored this role of fast in the pulmonary hypertension in monocrotaline induced pulmonary hypertension rats. So from us, another Chinese group inspired, and they also explored this role of fast in pulmonary hypertension, but in hypoxic rats. So they expose the rats to the hypoxic environment, around 10% oxygen, and following that the rats become pulmonary hypertensive. And you can see here that they also found increased right ventricle thickness and increased fast siRNA expression. And there was disturbed mitochondrial function, that there was degradation of mitochondrial crispity, and the C75 restored that. There was also increase in the lipid metabolism marker like DHA and glycerol, glutamine, putrescine, which was decreased by C75. And most importantly, you can see here that there is an increase in the level of palmitate in the pulmonary hypertensive patients. So they also showed that there was increase in the level of the lipids in pulmonary hypertensive patients. That the observation we also saw in our rats. So this work so far here showed that this fatty synthase is involved in pulmonary hypertension, and then we extended our work further and tried to see that whether it is involved in the left ventricular dysfunction or not. So you can see here that we developed a model of the left ventricle by transverse aortic constriction, and there was a deterioration of the ventricular functions. You can see here this after 60 days there was increase in the ventricle wall thickness. And following C75, which is a marker inhibitor of the FAST, there was a decrease in the following the transverse aortic constriction, and C75 improved the ejection fraction, fracture shortening, left ventricular and systole diameter, left ventricular and diastole diameter. They were all the markers of the left ventricular functions were improved by FAST inhibitor in left ventricular cardiac hypertrophy. Again, you can see here the same thing that in TAC animals there is increase in the ventricular wall thickness compared to this, and C75 has restored that. Okay. And finally, this is the last slide where you can see that not only the morphology but metabolic functions were also improved by fast siRNA in the left ventricular cardiac hypertrophy. So our work actually shows for the first time, ours and another group shows for the first time that fast fatty synthase, it is involved in the cardiopulmonary functions apart from cancer. So more studies are needed in the clinical setting to further validate its role in the cardiopulmonary function. And this is the references, including our work as well as others. And that's it. Thank you.
Thank you, Dr. Kasi. Nice contribution.
Thank you,
so, will you also use Bosentan in your modeling system?
Yeah. When we were standardizing our annual model, then we used Bosentan also.
So you haven't compared anything?
That was the part of our preliminary work. We have done that.
Any clinical correlation, like there are a lot of data available now in the pulmonary hypertension?
So that
one figure I showed you, that Chinese group have done that in the pediatric pulmonary hypertension patients. So there you can see that there is increase in the level of palmitate. That shows that there is increase in the fast activity in the patient.
Any Indian context? No, no data available. Because there is a significant
population. That's the lacuna.
Significant population in India with suffering from
actually, I must tell you that there is hardly one clinical trial has been done in pulmonary hypertension in India. There is big lacuna. While India is having the largest patient of the COPD, and our population is residing in high altitude. So pulmonary hypertension can be a big problem here. But so far only one clinical trial, one registry has been done in Kerala.
Thank you.
Any drug under development or
So right now, no drug actually we are exploring from. These are basic studies, and so far no active drug development program is being.
Nice presentation.
Thank you.
Thank you, sir. Now I request the chairperson kindly felicitate Dr. Kasi.
have Dr. Mahendra Bishnoi.
So, Dr. Mahendra Bishnoi is a scientist in the Department of Nutrition Science at the National Agri-Food Biotechnology Institute, it is Navi, Mohali. After completing his M.Pharm and PhD from University of Pharmaceutical Sciences, where he earned a gold medal, he undertook postdoctoral training in nicotine addiction and ion channel research at the University of Florida and Southern Illinois, USA. He joined Navi in 2011 and leads a team of investigating nutrigenomic mechanism of dietary modulation of adaptogenesis, obesity and metabolic disorder. His work has resulted over 55 peer-reviewed publications and he has secured multiple DBT and DST grants supporting it. So the title of his presentation is Microbiotic-Based Therapeutic Bridging, Experimental Insights and Patient Care. Yes.
I think the title was they mistyped it, I think.
Okay.
So that's fine. No problem. I just wanted to make sure that. So the title of the talk is Gatekeeping V1 and A1 Positive Sensory Neuron and Mucin Homeostasis.
So I'll start with what we do as chairman has just explained. The research what we do is around metabolic disorders, and we are connecting metabolic disorders from different perspectives. We work on browning of white adipose tissue, energy expenditure, and also on the gut health, how gut health is essential for the metabolic health. So in this context, we all are aware of that gut dysbiosis leads to endotoxemia, and endotoxemia is responsible for metabolic dysregulation. And one of the important factors which is involved is leaky gut, when the gut is leaky. And gut is leaky because once it is leaky, then toxins go in and that they are causing the damage. And one of the important components of the gut layer is mucin. And if your mucin layer is healthier, your gut layer is healthier, and that will prevent you from inflammation, toxicity, toxin insertion in your systemic organs, and that's how you can prevent number of inflammatory and metabolic disorders to happen from. So we are looking for mucin regulation, how these TRP receptors are kind of ion channel receptors, and
everybody might be aware with capsaicin. The pungency of capsaicin is because of one of the TRP channel receptor. So we are trying to understand, and what I will present in this work is we are trying to understand how these TRP channels
which are present in our colon are responsible for mucin health, why, if they are important, and whether our colon sensory neurons, because these are mainly sensory receptors, so whether our sensory receptors can sense food in a way that they can be responsible for mucin regulation. So as Dr. Kiran already has told you everything, briefed you about it. So gut is very important. I will not take time on this. So in 2015 and 16 we published one paper while we were working around browning of white adipose tissue. So browning of white adipose tissue, how chilies and capsaicin have a role in preventing weight gain, increasing energy expenditure. So one of the interesting findings, along with the findings which we had, like the browning genotype was increasing, hypothalamic satiety associated genotype was improved after capsaicin administration to the animals which were high-fat diet administered. One of the important changes what we saw, and I think at that time this was the first time reported that there is altered gut composition, and one of the microbes, Akkermansia mucinifera, was altered in a very significant way. So Akkermansia mucinifera is a mucin dependent or degrading bacteria, and it is one of the important gatekeepers of our mucus. So we could sense that it is possible that when we were modulating TRPV1, mucin is affected in a way that, so we hypothesized that yes, there might be a connection between TRPV1 and mucin. So should we explore it more, and that's how we started this. Yeah, mucin, as you all aware, I just explained you, it's a sticky gelatinous secretion that lines the mucous membrane, and it is secreted from specialized cell which is called goblet cells in our gastrointestinal tract, and then its function is moisten, lubricate and protect the passage of digestive, and it is also present in respiratory tract. So we will more focus on the digestive part of it. There are number of mucins. Its function is, as I told you, provide protective barriers, provide microbial colonization sites, and it also regulate mucin response. So it is very important. And there are multiple types of mucin which are secreted from goblet. I will not go into detail, but the mucin 2 is which is more important for the gastrointestinal system. And it in the layer of mucin, as you can see in this graph, as we are going towards colon where the microbes are more, the layer, the thickness of mucin is increasing. So there is a close connection between microbes and mucin layer. So we started with some of the literature search from the big data, whether these sensory neurons which we want to work on, TRPV1 and A1, whether they are present in gut or not. We dig through a number of papers which did single cell sequencing and retrograde labeling and then sequencing of the sensory neurons which are going from colon. So we dig into the data and we could see that TRPV1 is prominent in colon sensory neurons, as well as TRPA1 is also prominent. So yes, TRPA1 and V1 both are present on the sensory neurons which are innervating colon. So our next question was, do they have any significance? Now they are present there. Do they have any significance? Yeah. So to understand that, we created chemical knockouts basically. So we used these chemical, one is resinaferatoxin, which is a TRPV1 agonist, but it can kill all the TRPV1 neurons because in little bit higher concentration it will desensitize the receptor and kill the receptor, stop the functioning of receptor. And then there is this capsazepine, which is an antagonist of TRPA1, and in a given concentration it can sensitize TRPA1. So we developed these two models to knock down or to to stop the functioning of TRPV1 and A1 in the whole animal, and then to see that whether these receptors per se have a role in the function which we want to study. So in the first study where we used resinaferatoxin for TRPV1 ablation, now this animal do not have TRPA1, and we checked it by number of tests because TRPV1 is very much involved in pain. So we studied the pain phenomena and then we studied glucose homeostasis to prove that yes, it is not there. The animals who are not feeling any pain, you can clearly see here the hot plate test as well as eye wipe test and tail flick test is showing significant, animals are not feeling pain. That means there is no TRPV1, and the same goes for glucose homeostasis. These are reported effects which we studied to confirm that yes, TRPV1 is not there. And then we studied some of the markers in these animals which are neuronal markers in DRGs and colon to understand that yes, TRPV1 is no more there. So this is what we could summarize from these 3 slides. Behavioral test for TRPV1 dependent pain response, it was not there. Glucose homeostasis was also affected in a way like TRPV1 knockout animal should be affected. And then significantly lower TRPV1 expressing neurons through our gene expression data. So in these animals, then we studied the mucin layer. We did histology for mucin layer, and you can see significant, this is an Elchen blue dye uptake study where you can see significant decrease in the mucin layer. in colon, not in ileum. So in colon, with the knockdown of TRPV1, you could see that the mucin layer was affected. There was no mucin layer. Then we did with the capsazepine also, and it showed us the same result. We did number of different experiments. We did the imaging using SAM and all. We did histology, and it all showed us the way that because if you don't have these receptor, your mucin is lost and gut permeability. Once the mucin is lost, then your gut permeability is compromised. And we did some of these proteins which are involved in gut permeability, claudin, occludin, zonocludin, and tight junction protein PCR we did to prove that yes, once mucin is lost, then gut permeability is also lost. So TRPV1 presence is essential for mucin and all that. If you knock it down, mucin is lost, and then your gut permeability is also affected. Also, when the mucin, we all know short chain fatty acids, these are the fermented products of microbial fermentation in our colon, and they have a lot of protective effect. So once the mucin is lost, the protective effect of SCFA is also lost now. And you see we administered SCFA with capsazepine. So the preventive effect of SCFA, which we could see in the normal animal, was not there when we gave SCFA with capsazepine. So we could say that the capsazepine induced now mucin loss and gut permeability loss is also preventing the good health, good effects of SCFA. And so then we thought that does that have a functional relevance? Does that have a relevance to the disease? So because we are working in metabolism, so we planned an experiment where we gave animals normal pellet diet, high fat diet, then high fat diet with mucin, and then high fat diet with capsaicin. The idea was to compare whether in high fat diet, because high fat diet models are now very well established that there is an inflammation in gut permeability is affected and mucin is affected. So we wanted to see that capsaicin, because capsaicin is an agonist for TRPV1, if we give it, keep TRPV1 activated, whether it will have the same effect as mucin will have if we give the mucin. So we did that experiment for 12 weeks, performed then the metabolic test, and then did a lot of studies, which I will summarize in next few slides. So you can see the metabolic test. I will not take much time, but we can summarize here is that the mucin had its effects. You can see there is control, HFD, then mucin, and then capsaicin. So in every case, almost the high fat diet was able to complicate the matters, or we can say affect the metabolism, weight gain, then OGTT, ITT, and serum assays also, leptin and insulin were affected, and mucin and capsaicin were having the same effect. So it is like capsaicin is doing what exogenous mucin can also do. Yeah, so you can see that various high-fat diet-induced metabolic alteration in mice were effectively prevented by both capsaicin as well as mucin. Then we did some of these imaging studies, and imaging studies was also showing us that the presence of mucin and capsaicin was showing a preventive effect. So you see here the mean fluorescence intensity. In case of high-fat diet, the intensity is gone. So this is the dextran blue dye, which if your gut permeability is affected, it goes into circulation, and you don't see it in your image. When you image gastrointestinal tract, you don't see it. So in case of high-fat diet, it was going down, the intensity, whereas in case of mucin and capsaicin both, it was up. Then we did ELISAs for lipopolysaccharide, IL-6, these are the markers of inflammation and endotoxemia, and we could see that there was the protective effect. Then, as I told you, tight junction proteins we did in the presence of mucin and capsaicin, and they showed us even capsaicin was a better effect than these. And TRPV1 expression was also downregulated in HFD group and increased by capsaicin but not by mucin. We can clearly see why, because capsaicin can activate TRPV1. And then did histology to prove the points further. Both, there are two types of mucin. I will not go into detail, but the mucin, you see, the layer of mucin here is less, and then in case of mucin exogenous administration of capsaicin, it is there. And then we did different type of histological examinations to prove the same point. We did bacterial abundance also to prove that yes, the good bacteria are on the rise, and mucin and capsaicin are showing the same kind of effect. Some of the novel bacteria we could also find. And then, but the question was how they are connected. How do you say that TRPV1 and mucin are connected? So we started connecting the dots, and two of the important things which we could get was CGRP and 5-HT. CGRP is released from sensory neurons, and 5-HT is a serotonin neurotransmitter which is majorly released from gastrointestinal tract. So we can say that there is a crosstalk between TRPV1, CGRP and the mucin releasing goblet cell, which might be responsible for mucin release there. And now to further extend this work, because we have to find out how everything is working, how are we seeing such a good effect when we restore mucin using TRPV1 agonist. So now we have a new project where we are trying to find out the link between gut metabolites and release of mucin. Yeah. And then there are nutritional significance also of our studies. And whatever I told you, I summarized here. Capsaicin or any other TRPV1 dietary agonist, because we get capsaicin from chilies, and there are other dietary agonists act as mucin secretagogue. They release mucin to prevent against disease affecting gut mucus and permeability. We also presented evidence that because SCFA can affect, SCFA's protective effect can be prevented by if your gut is not good. So if your mucin is not good, SCFA will not affect. So I mean to say we could show that if you want to have an interventions, a gastrointestinal intervention using probiotics, prebiotics, and any sort of intervention, it should be done earlier in the age. If once your mucin is affected, your gut permeability is affected, there will be limited advantage of those interventions. That's what I wanted to say. And so this is the future work what we have to do, and I would like to thank both these students also and collaborators also for this work. Thank you very much for your patience here.
So what was the dose you have used for the capsaicin?
It was 2 mg per kg. 2 mg per kg. This dose sir we took because in our previous studies when we worked with the adipose tissue and all these, so 2 mg per kg was most effective. So we wanted to see that whether there is some role of mucin system also in that protective effect. So we used that dose only.
Interesting data, madam. So, what is the correlation between capsaicin and small chain fatty acids? Is there any correlation?
There is no direct correlation, but if your gut microbiome is better, and if because short chain fatty acids are the product of fermented when bacteria ferment the non-digestible carbohydrates, short chain fatty. So if the gut microbiome is better, your short chain fatty acids will be higher. But there is not. There are some studies which say that short chain fatty acids can activate TRP channels, just like capsaicin, TRPV1 and A1. But there is no study about capsaicin and SCFA per se, whether capsaicin administration or not available.
And one more thing, like capsaicin has the dual type of impact. So whatever dose you use, that is maybe the positive correlation with the mucin secretion or something. But in the Indian culture, capsaicin is also considered as a notorious.
Yes.
Notorious, like maybe the lot of people, if they will look into the state-wise data, where the high capsaicin population is suffering from the highest intake of the PPI.
Okay.
So how do you analyze in that category, like capsaicin is the positive impact, is a negative role? How do you like consider the whole metabolism in that consideration?
Yes, there is always a challenge with capsaicin, as you were saying, because it is associated with ulcers a lot. Higher dose of capsaicin will lead to ulcer. As far as these mice are concerned, we did not see any such, because we work with gastrointestinal system, so if there was ulcer and all, we could have easily figured it out. But that is a concern. You have to. That is one of the reasons why we want to extend this project to figure out some of these metabolites, non-capsaicin metabolites in our gut, which can activate everyone. So
because my early days, the research days, when I was optimizing the product, topical product of the capsaicin, we had a huge challenge to optimization, because when you put the high dose, it is irritation. Lot of irritation used to observe. So same thing I think with the sensitive issue like a GI system.
Yes. That should be taken care of before, if we want to. But we have to go away from capsaicin a bit, because this question will always remain, and this is a valid question, even if some people do not have ulcers, some people might have. So at the same dose, sensitivity, if the population is sensitive, that may have the effect. So we have to move away from it to find the alternate ways of keep your retrieval activity.
Good.
We did in our first paper, and we did 1, 2, and 4. In that one, we did not check much of around the rest, because we were more focused on how the non-adipose tissue will activate, and then energy expenditure will increase.
Thank you.
But as far as I know, this dose is quite less, so it should not cause any, because people have used 10, 15, 20 ml per kg.
In topical preparation also we have capsaicin as a
pain, because they desensitize at a higher count value.
I request the chairperson kindly felicitate Dr. Bishnoi sir for his research outcomes. Last speaker of this session we have Dr. Mani Chopra.
Yeah, Dr. Mani Chopra is an associate professor in the Department of Zoology, Punjab University. She specializes in the molecular toxicology, cell biology, cytogenetics, and neurodevelopment, neurodegenerative disorder. Dr. Chopra has led nationally funded research, for instance, investigating oxidative stress, genotoxicity caused by arsenic exposure. She is also actively involved in the mentoring the PhD student and serves as the faculty in charge for her department, internal quality assurances. So welcome Dr. Mani Chopra, and she will be giving some research insights of her work, that is the prenatal stress triggers gut-brain axis apoptosis and associated behavioral deficit, amelioration by gestational moral administration. Yeah.
Thank you, sir. Good evening, everyone. Today I am here to present my research work. Most of my research work presently is based on the we are doing on the maternally induced toxicants as well as different prenatal stress models. As well as we are also preparing a model of autism, but here today I am dealing with the prenatal stress. As the prenatal stress, we know that prenatal time, it is a time of psychological, physical and physiological stressor for the mother. When during pregnancy, these stresses, as they are aggravated due to some of the reason because of the due to the environmental, social or personal factors, then it would cause the influence on the mental health of the mother. That would it would cause changes in the intrauterine fetal development as well as long-term outcomes of the child. And this prenatal stress, it could be outcome as the preterm birth as well as low birth weight or impaired development in the offspring. So much of the research it has now it is very clear that the approximately 10 to 20% of pregnant women, they experience some kinds of mental health issues like anxiety, depression, and during the critical period. So and they are directly related with the increased levels of cortisol, and which is linked with the impaired cognitive impairments as well as ADHD and autism spectrum disorders. When this due to the maternal increased levels of cortisol, it could pass through the placenta and it could impact that of the HPA axis of the fetus. That would increase that would cause the hyperactivation of HPA axis in the fetus. That would directly influence the brain maturation as well as the different psychological outcomes could be there. Moreover, with the psychological stress, there would be hindered, there would be different microbiome would be altered. Moreover, catecholamines as well as inflammatory mediators would be increased. That could they pass through the placenta, they directly influence the brain maturity, as well as through the gut change in the gut microbiome. That would be transferred to fetus, and that influence the gut-brain axis of the fetus. That can also influence the brain development. So, as we are doing a lot of work on the plant-derived compounds, one of the plant-derived compounds that we are working on, that is the morin. And we have also different publications around multiple other plant-derived components like the Nigella sativa. This we have tested in that of the adult model of anxiety. Moreover, we have also tested the fistine for that of the different behavioral abnormalities in the autism. This work it has got very good publication, as well as we have also secured the one ICMR project on this. So presently, we prenatal model, we are working presently on the morin. As due to its antioxidant and inflammatory properties, we are testing it for this, and multiple other studies have also tested morin for the other neurodevelopmental conditions. So here this is the design of the work. We have in the rat, we have Vista rats, we have given the psychophysical stress for gestational day 8 to 16. And we are proposing that when this stress, it would cause as the cortisol would be higher, it would be transmitted to the fetus in the F1 generation. And the hyperactivation of this HPA axis in the fetus, it would increase the levels of cortisol in the fetus, and thus through the activation of this pathway, there would be inflammatory markers would be high. This could cause the gut inflammation, and with this gut inflammation, as there would be different metabolites, microbial metabolites are there, as well as altered gut permeability is there, and there would be gut dysbiosis are there. When these metabolites are altered because of the gut microbiome changes, these altered gut microbiome changes can, as they are the neuroactive molecules and they are responsible for formation of the neurochemistry of the brain, so thus they will impact the brain, and thus there would be a vicious cycle between the gut and the brain that is acting as the gut-brain axis, and thus we have targeted this whole pathway with that of the morin. Now coming to the results, we have given different types of stress during the gestational day 6 to 18, and this we have given, as we want to give, this is predictable stress, different restraint, different cage tilting, noise stress, light stress, and on different days we have given different types of stress, and as well as when after the delivery. We have also the behavioral tests we have done, as well as different organs we have studied. Colon, cerebrum and hippocampus have been studied. First of all, for validation of that the mother has the stress or not, there is increase in the anxiety as well as There is increase in the anxiety levels as well as in the depression in the mother. So after that we have validated about the F1 generation. There is increased level of cortisol in the fetus. Moreover, there is also the anxiety levels, they are higher. There is less learning as well as the memory in the F1 generation. Muscle strength is also low. So with these tests we have validated that the prenatal stress model has been created. And after the behavioral validation, we now move to the molecular validation. So first of all, we check the ROS levels in the in cerebrum, as well in the colon, cerebrum and hippocampus. There was increase in the levels of reactive oxygen species in all these in the PNS groups. Moreover, when we checked the NRF2 signaling, that was down-regulated in PNS model. Moreover, there was an increase in the lipid peroxidation, decrease in all the antioxidants. That validated that when the stress is there, that they cause decrease in the NRF2 signaling because of the ROS. And further it led to the increase in the oxidative stress in PNS group. But when the Morin was given, it caused the significant decrease in all these groups, and moreover it further reinstated the levels of these antioxidants. Moreover, the ATPases were also checked that they are the major marker for the checking the plasma membrane permeability, mitochondrial activity, as well as other markers. So these were also reinstated by that of the Morin treatment. Further, we wanted to know about the inflammatory markers. Now, different inflammatory markers, they were assessed we checked the mRNA expression of TAC1, IL-1, as well as TNF-alpha, and they were much significantly elevated in colon, cerebrum, and hippocampus. And these all the inflammatory markers, they were increased. On all the tissues of gut as well as in the brain. So but Morin treatment, it reduced the levels of these the mRNA expression. Moreover, when the proteins were seen by the IHC, or this TNF alpha, it was seen in almost all the cases in the cerebrum, hippocampus, as well as colon. It was increased in all the tissues. So, but that was further lowered when they were treated with that of the Morin. So Morin, it limited the ROS production. First of all, I can say when it reduced the ROS production, then it helped in the alleviation of the inflammation in the gut as well as brain tissues. So further, we wanted to check about the permeability of the tissues. As in the brain, there is blood-brain barrier, as well as there is gut integrity is also, intestinal permeability is also there. We checked it with that of the Evans blue, and then it indicated that there is increase in the blood-brain barrier permeability, as well as in the gut permeability has been significantly increased. Moreover, we also checked, the sir also talked about the occludin and claudin. So we also checked their mRNA levels, as well as their genetic as well as protein expression was also seen in the different tissues. It was seen that the tight junctions that are majorly made up of claudin and occludin, they were significantly decreased in case of colon, cerebrum, and hippocampus. And when the Morin treatments was given, then because it reduced the inflammation, thus it also increased it reinstated the permeability and improved the levels of occludin and claudin on all the tissues. So the Morin, it affords this barrier protection via its anti-inflammatory potential. Further, these results, we wanted to see the functionality of the gut. So different tests, they were seen by the charcoal meal test. This simple test, this test informed that the gut transit time was much more decreased in the case of prenatal stress, as well as gut transit rate was increased. And this is clear indicator that the rats, they are having the IBS like symptoms, or we can say they have leaky gut. So, and this led to but Morin treatment, it improved these results.
Further, we wanted to know about the connecting link between these two. So we assessed the different serum metabolites as these secondary metabolites, they are made by the different gut microbiome as well as different cells of the gut, and we see that there is increase in certain these secondary metabolites like lactate, propionate as well as the butyrate, but certain secondary metabolites like GABA, glutamine as well as butyrate, they are markedly decreased. It means they are showing that whereas these neuroactive components that are synthesized in the gut and that are mainly precursors for the neurochemistry of the brain, so it automatically it affects that of the behavioral aspects as well. But they were I can say they were then further they improved on that of the Morin treatment. So that all the treatments of increased oxidative stress as well as increased inflammation, that led to the apoptotic increase in the apoptosis of the colon, cerebrum as well as cerebellum. The increased apoptosis was seen, and there was increase in the markers of apoptosis, that the pro-apoptotic Cas at BAX, they were significantly increased. The anti-apoptotic BCL2 was markedly decreased. So these levels, they showed that there is increase in the apoptosis of this tissue, but it was all the markers, they were improved with that of the Morin. Further, different histopathological markers, the histomorphometry of the gut also proved that there is much more evident changes in the colon, as well as there are different mass in the cerebrum as well as in the hippocampus. These changes, they are in the prenatal stress caused these changes as well as, but Morin it was able to rescue the structure of these structures. So coming to the key finding of this study is that the prenatal stress, it resulted in the hypercholesterolemia, and that due to the high cholesterol, the NRF2 signaling must have weakened. Due to NRF signaling suppression, it caused the reduced antioxidants, and that further led to the increased inflammation which triggered the apoptotic cascade. So IBS-like symptoms and the neurobehavioral impairment, they are the results of this alteration of gut-brain axis. But the Morin treatment, it is very much effective. In antenatal treatment is effective, as well as it was able to reduce this NRF, increase the NRF signaling, as well as prevented the inflammation and apoptotic changes. So, and these are all this, they are published in recently last month in the Biochemical Pharmacology. So thank you so much. This is my team, and most of the work, most of them they have settled. One is Inspire Fellow, other is postdoctoral. She is Madhu has done most of the work in her PhD. This is I haven't touched about the gut microbiome. We are also this is under analysis, and most of this data is unpublished. So we'll show in next presentation. Thank you.
Good data. So, largely explore the role of the Morin in the clinical stage.
Yes.
Are you planning also for the postnatal stage?
Yes, sir. We are also multiple as we are done mostly prenatal stress with the FIS-team. Now we are extending it to Morin. In the FIS-team, we have already done the postnatal stress, but in the Morin, we are planning further. We haven't done yet.
Morin is like a flavonoid.
Yes.
Is there any impact on the reproductive markers or toxicity? Is it safe?
Yes, sir. It is safe. There are multiple papers. The Morin treatment is safe in the reproductive health. Yes. So as we have in our study we have given it antenatally during the pregnancy. So during pregnancy time we haven't seen any artifact of that.
Characterization for the pregnancy?
Not we have just chosen the specific the pure Morin we have taken.
Thank you.
Thank you.
Can I ask question from the audience? Yeah. Please, you said from the audience. I just want to know at what stage you sacrifice at what offspring?
F1 offspring.
What is stage with
So after the delivery was done, that was they were given total. That was after 21 days. When the delivery was there, then they were feeding on the mother. Then after that, after the 24th to 35th day, all the tests they were given. They were taken, and after that, after 35th day, they were sick.
Thank you. Any question? Gopal? Thank you.
Thank you, ma'am. Thank you, sir. I request the chairperson kindly felicitate Dr. Mani Chulia. Now, I request Dr. Amita Sarwal kindly join the stage and felicitate our chairpersons. Ma'am, kindly felicitate Dr. Naveen Jain. Kindly felicitate Dr. C.S. Patil. Thank you, ma'am. Thank you, sir. Coming forward, now I hereby request you all to the next and last scientific session of this conference under the theme Advances in Mechanism and Therapeutics for Complex Diseases. I request Dr. Satnam sir kindly join the stage. Dr. Satnam Singh is an associate professor in the Department of Pharmacology at the Adesh Institute of Medical Science and Research, Batinda, Punjab. He holds the PhD in pharmacology and has specialized training in pharmacovigilance, drug discovery, cancer biology. Dr. Satnam is a committee member of Institutional Animal Ethical Committee, Academic Council and Board of Studies in Pharmaceutical Sciences. His research interests include the molecular biology, cancer research, microbiology. Dr. Singh has authored numerous publications, has 126 citations and H-index of 4. And he has co-authored a textbook on novel drug delivery system. His work reflects a strong commitment to advancing pharmaceutical education, research and student development at both national and international level. For this session, we have first speaker, Professor Tapan Bahel.
Good evening. I didn't get the proper response. Good evening to all of you. Tea and coffee is available outside the room. So be attentive. So all of you are required to be attentive. So the next session is going to be very important. And today I have the honor to introduce the next speaker, Professor Dr. Tapan Bahel, by Professor Dr. Satnam Singh. So, Professor Dr. Tapan Bahel is an accomplished pharmaceutical scientist and academic leader, currently serving as professor and head at the MIT School of Pharmaceutical Sciences, MIT University, Mohali. Dr. Bahel's research expertise spans diabetes and its complications, molecular pharmacology, neuropathic pain, obesity, and rheumatoid arthritis. He has contributed extensively to scientific literature with numerous research and review publications, international books, and multiple patents to his credit. Patents to his credit. His laboratory actively investigates molecular pathways and therapeutic strategies for chronic metabolic and inflammatory disorders. So, with all this, I would like to invite Dr. Tapan Vahel to share his valuable piece of talk with you people. So, Dr. Tapan, please continue.
Thank you so much, sir. So, first of all, a warm good evening to all. So, indeed, it is a pleasure moment for me to be here among the budding scientists, among the budding pharmacologists and the researchers who are doing wonders in their field. And definitely we are there to learn from each other, and I hope the session which we are going to have, this particular now, will predict the basic wonders which our ancient Indian drugs are doing. So I will be talking a little bit about the VEGF, which is a wonder molecule. Why I am saying it a wonder molecule? Because you will come to know how mysteriously it is going to act in the biological systems, and then how actively it has taken into the action the further preventive measures in one of the most deadliest complications associated with diabetes, that is diabetic retinopathy. So first of all, the title for the presentation is Peering into the VEGF Vault, that is New Pathways in Diabetic Retinopathy. So why I have chosen this particular topic? Because much of the work has been done in diabetes and everyone around the globe is doing work on diabetes, but not any one of them has scratched so much of the diabetic field, including me. But definitely there is a grant which we received from the WHO for peering into this particular thing, that is VEGF role in diabetic retinopathy. So coming to the introduction, so diabetic retinopathy is first of all the most common deadliest complication of the diabetes, of course the microvascular complication that leads to damage to the small blood vessels of the eye, and eventually if not treated it can lead to blindness. And it progresses from the stages of non-proliferated, moderate, and then mild first, then moderate, then severe, and finally to a proliferative stage. And then when there is an auto-oxidation of the glucose, there occurs a number of mechanisms, namely the auto-oxidation of the glucose, impaired antioxidant defense mechanisms, protein kinase C activations, and the alterations in the mitochondria level. So definitely it is not the only one cycle which is going to be affected, rather it is going to be the harbinger for the number of complications that can eventually lead to the damage to the very minute blood vessels of the eye, leading to either the microvascular complications or macrovascular complications. So first of all, when we are talking about any of the chronic diseases, as the theme of the session is there, it is always a nexus, it is always a network that is already associated with oxidative stress, inflammation and angiogenesis. So more specifically, I will be talking here more about the angiogenesis because it is that under scratched field which is not as of now scratched one for searching the new avenues in the field. So oxidative stress basically plays a major role in the diabetic complications, and it is further amplified by a continuous cycle of metabolic stress that leads to immediately the free radical scavenger mechanisms. Furthermore, inflammation plays a very dominant role that leads to inflammatory responses, downstream regulatory pathways that contributes further to the diabetic retinopathy stages. Last but not the least, angiogenesis, which is the mainstream targeted molecule now. So it forms a proliferative diabetic retinopathy, which is the most dangerous stage of diabetic retinopathy that can even lead to blindness, and it leads to the formation of weak and immature blood vessels that can immediately lead to the oxidative stress induced damage. So why I have chosen this particular slide? Because angiogenesis is always an unexplored domain in diabetic retinopathy. Much of the work is done in oxidative stress domain, much of the work is done in inflammation, because we all link oxidative stress, inflammation with one or more other metabolic disorders. But as of now, little work is done on the angiogenic pathway. So angiogenesis as such, we know that it is both of the physiological and the pathological mechanisms. It is very much needed for the body when we are associated with the growth of the body, but at the same time, for example, if I am talking about the cancer cells, right? It is nothing, it is just the uncontrolled growth of the cell. It is the angiogenesis that leads to sprouting of the new blood vessels. So definitely there is the activation of the vascular endothelial cells, there is the proteolytic degradation of the endothelial cells, then degradation of the extracellular matrix, vascular proliferation, recruitment of pericytes, and then deposition of new basement membrane. So definitely the new blood vessels which are going to be formed, they are going to be formed of the leaky nature. They immediately discharge their contents into the endothelial basement membrane that got ruptured, and ultimately the haziness and dullness appears. So more picture will be cleared once I will be coming into the preclinical part from the fundus and the retinal pictures. So definitely angiogenesis, I have mentioned earlier, it is the differentiation and growth of the cells which is kept control under the anti-angiogenic factors. There are two factors, one are the pro-angiogenic factors, second one are the anti-angiogenic factors. Pro-angiogenic factors are very much essential for the body because they do play an important part in the growth of the body, right? But when anti-angiogenic factors are there occurs a dynamic equilibrium between the pro and the anti-angiogenic factors, but somehow this equilibrium gets disturbed, as a result of which the blindness can occur, the mortalities can occur, which can further lead to the various mortalities and the modalities issues, which leads to the formation of the capillary-like structure. And anatomically, the ophthalmic artery, which supplies the blood to the corneal region, is subdivided into smaller arteries known as ciliary arteries, which are further subdivided into more smaller capillaries, and they get eventually damaged, and thus they formed a pericorneal limbal plexus region. And during the process of angiogenesis, a pathological condition called overstimulated proangiogenic factors cause the endothelial cells of the pericorneal limbal plexus region to proliferate in an abnormal manner. Earlier they were proliferating, but definitely there was an equilibrium which was existing between the pro-angiogenic and the anti-angiogenic factors. But now that equilibrium is getting disturbed, and that's why the complications are occurring. So definitely the VEGF now comes here to the picture, because if we are talking about the if we are talking about the angiogenesis, and if we don't mention here VEGF, it will be a big mistake. So definitely we have to consider whether VEGF, which we have considered this in the study, is either a friend or a foe. So basically vascular endothelium factor is a cytokine growth protein responsible for the series of events that lead to either the physiological and the pathological events, and there are basically in the 7 identified members are found: VEGF A, B, C, D, E, F, and PIGS, that is placental growth induced factor. Then there are receptors which act through this, and these are mainly VEGF R1, R2, and R3 receptor. So the most important among all the receptors is the VEGF R2 receptor, which plays a very modulatory role in the genesis of diabetic retinopathy. So definitely when there is a pathological condition occurs, there occurs unchecked angiogenesis, because the anti-angiogenic factors and that pro-angiogenic factor equilibrium is disturbed now, and that leads to the scratching attributes of diabetic retinopathy. So this is one of the content which is taken from my own paper. So definitely when the VEGF binding takes place, the dimerization of the receptor takes place. When the dimerization of the receptor takes place, there is the autophosphorylation which occurs, that leads to the activation of the several transduction mechanisms and molecules. This activation can either occur direct pathway about the phosphorylation and VRAF, that is receptor activated protein pathway molecules are involved, whereas the indirect pathway involves the SRC regulated pathways. And when activation of the VEGF receptors occurs, there occurs the proliferation and differentiation of the endothelial cells that mediates the downstream signal transduction pathway. So this is how the VEGF receptor takes into action and how it modulates the further down modulatory regulatory pathways. So when there is a overactivated PKC, when we are talking, this is basically the condition when the diabetic retinopathy is about to occur or it has already occurred. So there are a number of compensatory mechanisms which do take part in the body also, but when the overactivation of the PKC occurs, we all know that normally in the normal physiological conditions, the extent of activation of PKC is basically controlled by various factors, which keeps the concentration of the substrate required for the formation of the PC in the normal amount. But when there is an increased amount of the glucose in the diabetic condition, we all know that diabetes is basically hallmarked by the elevated level of the glucose. In that particular condition, a significant increase in the concentration of diacylglycerol occurs. So how this diacylglycerol is going to play a prominent role, because during this process the dihydroxyacetone is going to play this dihydroxyacetone is going to formed. This dihydroxyacetone undergoes reduction to form the glycerol 3-phosphate, which undergoes acylation to form lysophosphatidic acid, which further undergoes acylation to form phosphatidic acid, and then the triglycerol and PKC activation occurs. But here the difference is, here the magical thing is that this PKC is getting overactivated. That is leading to the new complications, and that ultimately leads to the formation of the increased amount of the glucose, as a result of which the complication further occurs. So this is how normal glucose, under normal conditions, the amount of dihydroxyacetone which was being mentioned this way, this is in the normal conditions. But somehow in the hyperglycemic condition, the amount of dihydroxyacetone which is produced is excessively high, and as a result of which the diacylglycerol contributes to the activation of the protein kinase C. So now the protein kinase C is activated, but it is overactivated. That's why the number of complications occurs. So normally oxidative stress is a condition where there occurs a dynamic equilibrium between the formation and destruction of the free radicals. Normally this process is very much regulated. But in the condition of the metabolism of the glucose, they basically occurs by the glycolysis and citric acid cycle, and which are responsible for the formation of the reduced forms of the NADH and FADH2. Finally, they play an important part in the electron donating role in the leading to the generation of ATP, and then increase in the concentration of NADH and FADH2, which are the reduced form, they leads to the formation of more of the free radicals. So this is how the whole picture is coming to action, that ultimately first of all the PKC was getting overactivated, then the inflammatory cascade was coming into action. So that's why I mentioned in the very initial type that it is actually the nexus between the oxidative stress, inflammation and angiogenesis, that all contributes to this getting attribute. So then there is the auto-oxidation of glucose which comes next, that occurs by the glycation and oxidation reactions that leads to increased production of the amatory products, advanced glycation products, and they further act through the receptors of the AGEs. The activation of RAGE regulates the protein kinase C further. This is how the protein kinase C is getting overactivated over and again in this particular condition, that leads to the conjugation and PKC activating pathways, resulting in the overactivation of PKCs. Then activation of RAGE is also responsible for upregulating of the tumor necrosis factor as well as TNF alpha beta, that contributes to the NADPH oxidase and ultimately leading to the contribution of the free radical scavenger mechanisms. So normally in hyperglycemia, the condition is excess glucose is there. There is the metabolism, glycolysis and citric acid cycle is basically responsible. And in this particular condition, when there is the overexpression of the AGE, then there is a activation of TNF alpha and beta, stimulates NADPH oxidase, and then reaction with the nitric oxide occurs, and then ultimately contributes to the formation of the free radicals. So it also contributes to the formation of the intracellular cell adhesion molecules, MCPs, also COX, that ultimately contributes to sticking of the more of the cells into the peripheral types of the endothelial layer, that ultimately gets leaked into the endothelial membrane, and that causes the damage, severe damage, I can say this. So it also induces the matrix metalloproteinases, because they are the extracellular matrix components which are basically responsible for the degeneration of the various components, and they are involved in the cellular signaling pathways, and they are also involved in the basically secreted in the inactive form called zymogens, and their activity is regulated by the tissue inhibitor of matrix metalloproteinases, that is TIMS. So normally the level of MMPs is controlled, but when the devastation occurs, when the pathological condition occurs, this balance gets disqualified, as a result of which the VEGF is regarded as the one of the main agents which is responsible for this disturbed equilibrium, and that leads to the enhanced formation of the MMPs 2s and MMP9, that causes liver damage to the barrier due to their proteolytic property, and eventually the leakage of the contents into the endothelial membrane occurs. So definitely when there is the hyperglycemia, overexpression of VEGF occurs, overactivation of hypoxia-inducible factor 1 alpha, increased expression of the matrix metalloproteinases, then there is a blood retinal barrier damage, proteolytic activities occurs, and that all leads to the macular edema condition, that ultimately leading to the inflammatory cascades. So now I will be little bit touching about the wonders of the Indian drugs that actually has been done with our own very Indian drug, which is called as almond badam, and we have studied its effect on the its common name is Terminalia catapa. So we have used this particular study, and this is a preclinical studies for the angiogenesis. These are the basically images from the retinal images of the rats. So you can see that at the 0 week, this is a 12-week long study. From the 0 week, it is just a clear structure and appearing like a moon-like surface. But starting from the 2nd week and then progressing to the 4th week, 6th week, it is quite dark because the opacity is arising from the peripheral region to the central region. And then it coming to the 8th week, that is grade 3, dense nuclear without clefts. There are no clefts which are occurring here, but here you can see a X-like structure which is coming in between, and in this it is grade 4. So this is how the diabetic retinopathy progress, as a result of which the vision get hampered, there is a fussiness, there is a black spots which are occurring into the action, and they are immediately leading to the cataractogenesis. So then there were the lenticular images which is being done with the glabenclamide as a standard drug, and we have taken the 3 doses, 20, 30 and 40, and we can see that whatever the dose we have taken, be it the 20, 30 and 40, especially in the 40 mg, that the highest drug, the wonder which happened is there is a reversal of the diabetic retinopathy stage. Just because it has completely halted the progression of the angiogenic pathway, it has led to the grade 0 progression from grade. Here you can see that in the diabetic control stage, it is progressed to grade 2, and in this particular, grade 5, sorry, and in this particular with the treatment of the test drug, it has reduced to grade 0. So definitely there is a progression which was there in the diabetic control group, but with the test drug administration, it has significantly reduced the progression of the diabetic retinopathy, and that was definitely comparable to the standard drug. So coming to the conclusion part, so diabetic retinopathy is one of the most scratching attribute, a sight-threatening complication that is associated with the diabetes, of course, that leads to the formation of the leaky blood vessels, and newly formed blood vessels which are formed, they advance their growth into the vitreous chamber, and when they leak out their contents, causes vitreous hemorrhages. And it is a vital protein which is playing a very important role, and it acts as a very crucial factor. Why crucial factor? Because either it is this way or that way. When it is this way, it is okay, pro-angiogenic factors are there into action, and when it is that way, the anti-angiogenic factors, they too play important role, and then the disequilibrium occurs. So in diabetic retinopathy, asset of VEGF transformed into liability. So definitely the asset transforms into liability, that contributes to the further overexpressions, and molecular events are there, but definitely the anti-VEGF therapies like bevacizumab are there, which are there in the market to combat its progression, and ultimately we know that one day there will be the things which we can be found out from the Indian origin drugs also, which can be targeting this angiogenic pathway. That's all from my side. Thank you so much for your patience. These are the references. Thank you so very much.
Thank you, sir.
Thank you, sir.
Thanks a lot for a wonderful piece of information. And my question is related to your dose of that
Terminalia catapa.
Yes. Is there any particular trend which was formulated in the dose?
No, sir, there was no as such trend, but the thing is, what we noticed in the initial study, that when we were giving this dose, the rats were getting, mortality was very high in the very initial time. Why? Because of streptozotocin, which is the drug used to induce the diabetes. So when we have done the literature review, we see that number of papers were there which were reporting that they have given the dose as compared to us in the very high dose even of the streptozotocin, but mortality was not reported there. So we came to know from one of the German scientists that there is a study which has shown that if we are going to induce the heme insulin in the very starting hours of the 36 hours, that mortality is getting reduced. So then the next study was to... Yes, I am coming to that, sir. So the next was to how to get into this particular dosage, right? Right.
And a particular source of that, from where you procured that?
Okay, you asked about its procurement. So it was procured from a dealer, sir, with the certificate of analysis was there. Then the particular component which was there, saponin content was there, it was extracted out and then it was evaluated out. It was taken from a certified dealer, procured from certified dealer.
Okay, what is the active constituent?
It was basically the saponin content, sir. It was, and it was the catecholamine which was there present in it. capillary, which was actually responsible as per our knowledge.
Do you think when this editing will given alone, will the same effect will be there?
So of course, the studies under the, like we have been provided with the, you can say, patent for this also. And
most of the time, sir, they are working in a synergistic manner.
Yes, I agree with you, sir. Of course, you are very right. They are acting in the synergistic manner, but when we are talking about the angiogenic pathway, right, it is not only because we have studied its action even in the synergistic pathways also, we have also seen its pathway when it is acting alone, all alone, because there were 3 separate groups which were alone significantly enhancing its effects. So that's why we are very much sure that it is 99.9%, it is very much because of that. Yes.
Thank you very much.
Thank you so very much, sir. Pardon, sir? Yes.
Have the similar protective
Yes. Because see, that's what I have said, sir. Because we have studied its effect in the glabenclamide alone group also. We have studied its effect in the 20, 30 and 40 separate groups also. And there was a group which was used in conjunction with the glabenclamide and the terminal catapa. So in terminal catapa 40 mg per kg, it has shown the most protective effect. Of course, the effects were there in the low doses also, but the effect which was there in the low dose was not that significant as compared to the highest dose. It reduced to from grade 5 to grade 3. But in the this 40 mg, it reduced to grade 1, and even in the final stage, it reduces to grade 0. Yes.
Thank you, Dr. Bihar. Thank you so much. So I will now request our chairperson of the session to please felicitate Dr. Bihar. So we now invite our next speaker of the day, Dr. Pragyanshu Khare.
So the speaker for the next session is Dr. Pragyanshu. Dr. Pragyanshu is currently serving as an assistant professor in the Department of Pharmacy at IPSCON Pilani, where he leads research on biology of temperature sensation. His work focuses on understanding the molecular basis of temperature sensitivity and exploring how these mechanisms can be modulated to influence the fundamental human physiological processes for disease prevention and therapeutic innovation. Dr. Pragyanshu has published more than 40 research papers in high-impact international journals, reflecting his strong contributions to the sensory biology, pharmacology, and translational research. Thank you very much. So with this, I would like to call upon the stage Dr. Pragyanshu. Welcome, sir. Please continue.
Good evening, everyone. So, thank you very much for this opportunity. And today I will be talking about vasomotor tone and its implication against metabolic complications. Currently, I am working in IPSCON Pilani. This is our campus, and my office is situated somewhere here. And my whole research area, since my PhD is working around temperature sensation, its impact, and its association with the metabolic disorders. So basically this is the normal physiology, and we know that obesity is increasing in a very rapid way, and now we can see that, and this is data from 2019 where 24% of the people is obese in India are overweight, and this is a very bad situation for us, because this obesity and other metabolic complications are associated with so many of the disease. You name any disease, those are happening nowadays, and somewhere obesity and reduced metabolism is associated with it. So main cause for this is energy intake when exceeds to the energy expenditure. That is why it is said that you have to somehow maintain a balance between energy intake and energy expenditure. This is happening nowadays because of this motorized system that we have in our house. We have washing machine that can wash our clothes. We have other instruments and the vacuum cleaner and so many things that are those things are added in our daily life, and we have plenty of food. Those are very high enriched in energy, and all together we are now surplus of energy, and that is actually the main cause of metabolic disease. Now here I will point out one very important factor, which is the thermal influence of energy expenditure or energy balance. We all know that nowadays this global warming is also happening. Other than that, we are also living in a very controlled environment. For example, in this room we are sitting in an AC. If you see this figure where you see this temperature, which is called the thermoneutral zone. Thermoneutral zone is a temperature at which our body needs to work very less for the maintenance of its basal metabolic rate. If you are living little higher side, then evaporative heat loss, basically from the sweat evaporation happens, and that actually impart a lot into the energy expenditure. Similarly, when you will go down side of the temperature, then non-shivering thermogenesis, which is associated with the brown adipose tissue, as well as shivering thermogenesis, which is regulated through the muscle, is happening, and this actually increase a lot of energy expenditure. So without doing any exercise, if your environment is actually helping you somehow to increase the energy expenditure, that can also add a lot in your well-being. Nowadays, global BMI has increased by 0.4 to 0.5 milligram per kg, and that is happening per decade, and there is no as such correlation that has been done throughout the world. But if you see in a very layman thing, then you see that the global temperature in which we live, which actually include the air conditioned environment, from 18, so we have reached to 18 from 13 degrees Celsius from in UK, and in USA the people are living at 24.6 degrees Celsius from 18 degrees Celsius. That was the time when there were not many ACs and other things were there. In India we don't have such kind of data, but I'm sure that if you will look into that data, then we will see that in the colder environment we are using AC or other type of different thing, heaters or other type of different things, and if you will see the summers, then we are living into the AC condition. Altogether it is decreasing our energy expenditure, which is the main cause of current, I can say, a kind of pandemic situation throughout the world. If you see the normal physiology of body, whenever you expose yourself into the colder environment, so my more focus will be toward the colder environment now in this slide. So if you expose yourself into the colder environments, these are the things that can happen. The first defense is vasoconstriction. Our body generally constricts the blood vessel to prevent the contact of blood to the outer surface of the environment. A second step is non-shivering thermogenesis, which happens through the brown adipose tissue. Third thing is comfort environment seeking. So we generally look for a very good environment. We look for sweaters. We look for a warm environment. So many other things happen. Third, if nothing is happening, then shivering starts. and if this is also not able to maintain the core body temperature, then hibernation can also happen, but it is not the case for all the animals or all the. In some animals this can happen. Now, all the things are very highly explored for the research, except vasoconstriction or the peripheral vasoconstriction, I should say. Here, in this slide, you see that the non-shivering thermogenesis and shivering thermogenesis, as well as increased activity. So this is also one of the things that happens when you expose yourself to the cold. These things are very protective in nature in terms of cold. But other things like comfort environment seeking behavior, increased food intake, this we all know that food intake also increases in the colder environment. Similarly, peripheral vasoconstriction. All these three are not are actually the impart the positive energy balance, and these two impart the negative energy balance. So meaning here is, if you directly expose yourself into the colder environment, then both the things will happen, and ultimately you may not reach to a definite negative energy balance, which is very, very important for the solution of this problem. We have, when I was working in Navi under the guidance of Dr. Mahendra Vishnoi, we published very good papers where we were actually talking about how we can increase the TRP M8 activity so that we can increase the non-shivering thermogenesis, which is very, very important target for this. And now we have reached to a conclusion that yes, you can increase non-shivering thermogenesis. But other things, which is this one, has not been explored anywhere in the literature. If you will see this, you will not see any data. Anything has not been done in this case, and this is the target for this. So I am targeting this in my lab, and in general, this is our if you see an animal where these are the blood vessels, and they have generally enough supply of blood into the periphery. But when you expose them in a colder environment, then these blood vessels constrict so that the contact of outer environment and this blood reduces, and you can somehow achieve a positive energy balance. And this is what I think we can target in this. This is a research gap basically. If we can target this and if we can achieve something in this, then probably we can get something. So we started with one important target, which is alpha 2b adrenergic receptor beta. So I will not go very deep into this because time is a limiting factor. But alpha 2 is adrenergic receptor 2. So alpha has adrenergic receptor alpha has two subtype 1 and 2 itself has 2. Alpha 2 itself has three variant: alpha 2a, alpha 2b, and alpha 2c. Where alpha 2a and alpha 2c are the primary modulator of this peripheral vasomotor tone, and this is a very mild mediator. We have chosen this because of a very important purpose. If you block other mechanism, then probably you may see a kind of hypotension, and this is not a desirable target for us. That is why we have taken this, and the reason of choosing this is because the knockout of this ADRA2B is not a hypotensive animal. So finally we have taken this as a model, and we try to reach to a conclusion if modulating this can lead to negative energy balance or not. So we started our experiment with the knockout of knockout of this ADRA2B receptor. When we knock this out, we have seen that this is the animal, and if you see this is the ADRA2B knockout, and this is wild type. You will see in this mouse that this you will see little brighter in color, and here you will see dark color. This bright color is actually indicating a more blood flow toward the periphery, and these are the quantitative analysis of that. So meaning with this experiment is, if you will knock out ADRA2B, then in the normal environmental condition. Normal environmental condition means is the condition at which we perform the experiment, that is 22 degrees Celsius. In our case, it is a thermoneutral zone. So at this temperature, the blood flow toward the periphery generally increases, and that is what we wanted to see. So we confirm this that this is happening if you somehow knock this channel out. We expose these mouse into different temperatures from 28, 30, 31, 32, 33 and 34, and you will see in all these figures that these temperature changes actually are not impacting the vasomotor tone similar to the one which is happening in the wild type mouse. Here you will see this is the wild type animal. If you increase the temperature, blood flow toward the periphery is increased. That is very common understanding. But in ADRA2B mouse, this is not happening. The reason for this is all because the vasomotor tone is impacted and animals are not able to modulate the peripheral blood flow in terms of change in the temperature into the periphery. Since this happened, that is why we try to see what happens to their thermal sensitivity. And in this is a figure where we put animal into different environmental conditions, and in this experiment we could see here that these animals are actually preferring little warmer side. The reason is very obvious. So ultimately in all these figures we somehow quantified that these animals are not behaving normal in the different environmental conditions, and their peripheral blood flow is high. To again justify it or to reach to a meaningful conclusion, we used a pharmacological tool so that we can give a treatment solution to this, and we used a ADRA2B antagonist, which actually showed us the similar kind of result, in which the same result we have seen, that this is ARC239, which is, so you see here the color, this color and this color. So this is blue and this is bright red, bright yellowish. Yellowish means peripheral blood flow was little higher in these animals. We perform similar tests for the thermosensitivity also, so we see similar kind of results here in these. Interesting point here is, since thermal sensitivity is changed, peripheral blood flow is changed, but not the compensatory food intake was not actually altered, and which is a very important point here to note, that even after blood flow to the periphery was high, but the compensatory food change was not happened in that case, and that is a very important finding we observed here. In the last experiment we used this antagonist in high fat diet fed animals, and we performed all those experiments, and where we have seen that in high fat diet animals hyperphagia was reduced when I used this ARC239 treated animals, as well as the weight gain was also significantly changed in these animals. You see these are the animals over HFD without treatment, and the weight was significantly increased. But here if you see in these animals, then this weight change was not too much. I have seen a lot of variation in the results, so we have already repeated it twice, but to confirm it we are repeating it one more time, but we are almost sure that this is happening. Similar thing if you will see in this glucose disposal, then we have seen the almost same results. So conclusion is that if you somehow prevent or increase the peripheral blood flow, then your energy expenditure can increase. One more point here is, if you expose yourself into the extreme environment a little bit or try to avoid the AC, then also you can achieve some kind of metabolic control. Thank you very much for your patience.
Thank you, Doctor. My question is that what did you knock out that receptor? How?
So basically, this first study we performed with the collaboration with our German collaborator.
basically the whole story
Just a minute.
is related to the heat dissipation.
Yes, sir.
Basically, heat dissipation model.
It's the last slide. I forgot to show that.
No, it's okay.
Acknowledgements.
That's how it is
Last
worked
one,
out
last
by,
slide.
with the tools and the pharmacological methods. First, you said that it was knocked out.
Yes, sir. Yes.
Yes.
So initially we performed this experiment with our German collaborator. She is Katharina Zimmermann. She is the one where these knockout experiments were performed in FAU, Germany. So we didn't knock out directly. We bought it from the Jackson laboratory. However, we changed their so they were actually not C57 knocked out. Then we changed their lineage and we crossbreed them with the C57 animal so that they can become the same animal. So that is what only we did.
Secondly, sir, you have said that in case of heat dissipation, where you have created a model where the blood flow, peripheral blood flow has been increased, so no food intake was increased.
Yes, sir. This is very strange.
Why the energy consumption is more, but why the food consumption is the same?
This is important point, and that is what our catch is. This should happen actually, but it is not happening. So probably the answer is this IDRA2B is actually playing the role of compensatory increase in food intake, and that is what we are saying. If you block this receptor, maybe the compensatory food intake is prevented, and maybe you can get some kind of negative.
Catch.
Yes, basically this is the catch.
Thank you very much. Any
Can I ask a question?
Yes, sir.
So if following the question what we just had, if you say this is compensatory, so would you think of also that how it will get energy from? In that condition, shouldn't the animal be energy deprived, or is it the animal?
Sir, energy deprivation is our actually goal. So we want them to be energy deprived. That is what we are saying. If you are obese, so there are so many methods we are using. We are using exercise to make us ourselves energy deprived. Here I am saying, or our results are saying that compensatory food intake increase is not happening, and probably this is the catch which can actually making the person energy deprived, and maybe this can lead to a weight reduction.
So you mean to say, I think it is now correct in my mind that when we feel cold, we eat more.
Yes, sir.
So we are trying to figure out why we are eating more, so that we can stop it.
Yes, sir. Yes.
So we feel cold, do energy expenditure, but don't eat to compensate.
Yes, sir.
To get that heat from.
But this will happen only in case where the peripheral blood flow is much more, as it has been knocked out in this species. Otherwise, blood flow will be.
No, sir.
In the same way.
Sir, we have done two types of experiments just because to answer this one. One was knocked out, and other was simply antagonist, pharmacological.
This is wonderful. Very, very good.
Thank you for the excellent work. I think this type of work need to be pursued by the Indian scientists, and Pragyansu, who is working with us, is one of the finest pharmacologists, young budding pharmacologists. See the level of work. Actually, this kind of work which is not even think of, because we expected this, but this alpha-2 is a ideally discovered presynaptic receptors which regulate the release of noradrenaline and adrenaline in the synapse. And the subtype would be doing wonder, and one of the interesting findings that if you block this, you can increase the consumptions of energy without even having the food intake. So that would be one of the key which would be eventually in the future become the success for controlling the obesity and possibly metabolic disorder. So I congratulate, thank you very much.
Thank you so much. So now I request our chairperson of the day to please felicitate Dr. Khare, and I would request Dr. Mahinder Vishnu to please join us. Please join us.
पैरा तो पार है, मेरे जैसा बंदा जो वेट कम कर सके।
Thank you so much. So now I would call upon the last speaker of the day, Dr. Rajiv Talia.
So, welcome Dr. Rajiv. So today is this session's last speaker, and it is very difficult to be the last candidate, whether it is a Viva seat or it is another task. So without taking much more time, I would like to introduce Dr. Rajiv. Professor Dr. Rajiv Talan is the professor and head of the Department of Pharmacy, Division of Pharmacology at BITS Pilani campus, Rajasthan. His research spans neuropharmacology, cardiovascular pharmacology, and epigenetics, with a particular focus on molecular mechanisms in neurodegenerative disorders, ischemia, and reperfusion, or ischemia, reperfusion injury, and epigenetic regulation of diseases. He has authored numerous high-impact publications, including in pharmacological research, aging research reviews, and molecular neurodegeneration. And he is actively involved in institutional review boards, Human and Animal Ethics Committee at BITS Pilani. So I would like to call upon the stage Dr. Rajiv. Please come and share your valuable talk.
Thank you for the nice introductions, Dr. Satnam. And thank you very much for the organizer for giving the chances to present a piece of work. See, the BITS Pilani, Department of Pharmacy, is one of the oldest institutes in India. When the pharmacy program started in India, among them the BITS Pilani is also one. The founder is the same who started the pharmacy program in India, Mahadev Lalsro. He started the program in BHU as a 3 years degree program, followed by 4 degree, and the same founder has started the BITS Pilani campus in Rajasthan. So let me give you some background, because if you see the level of research work is what's going on in BITS Pilani pharmacy. As one of our young pharmacologists, Professor Bhagyansu have mentioned, how the energy intake could be manipulated in such a way that the patient is getting benefit directly. So let me show you some very advanced level of research which are related to gene reprogramming. Whenever there is stress, continuously, chronic stress especially, your gene started to have a special reprogramming in which they would try to either allow the transcription process or sometimes replace the gene in such a way that the product which are getting formed may be altered. And it would be eventually sometime resulted to be involved in pathogenesis of certain serious clinical problem, including cancer. So in this, let me just start without taking much time, because I do understand this is the last lecture, and although I am not very happy to see the audience, because the student which are supposed to be more, and the lecture I understand is last, so let me show you very quickly without taking much time. This one? Yeah. So this is the campus BITS Pilani, you can see very quickly. And we are very proud that last many consecutive years we are just having put by the National Indian Ranking Framework in 1 to 5 category. This time we are on 2nd position. We have got several projects, including DBT Builders, which is 9.02 crore project, Sathi project, which is university-wide project of 60 crore, Biosist, which is around 125 crore project, which is supported by the government, and Department of Pharmacy, even this year, is supported by 2 crore by DST. So this is our departments, because as a head of department, this is my moral responsibility, and I just touch upon to look how the BITS Pilani is. BITS Pilani started in 1950, and we have regularly updated our curriculum based on the need, because our integrations to industry is enormous. We have very strong relationships with industry, and our syllabus is also modified based on the need. You see some evidence by which you can understand the quality of our graduate student to whom we are grooming and giving the training. You see, even not only the faculty which are recognized by the Stanford University in 2% category, or even our student who's recently passed out, they are also recognized as 2% scientists. These are some data. And one of the interesting data which are related to the best ranking criteria, QS ranking, in which we are on 84th position. Now let me start the discussions related to my talk, which are focusing on the epigenetics and gene delivery. So before I go down to this, the student need to understand basically how the nervous system have been classified and how the brain is getting connected to get the message from the periphery and convey the message. So very quickly you see, already you are aware that brain is classified in one way or other way to get the message through peripheral nervous system, basically, because your support to and fro by the periphery and message conveys through sensory neurons and motor neurons, and this would be divided into autonomic and somatic nervous system. So actually the peripheral nervous system, when you use the word, it would be comprising by somatic nervous system, because somatic nervous system is actually true peripheral nervous system, because those activities which are under your will control and supported by skeletal muscles are controlled by somatic nervous system. While you see the name autonomous, that means you cannot control it. It would be automatically readjusted because it is a highly dynamic process. Now let me come down the CNS, how it is getting receive the message, especially the brain, with the help of the sensory neurons. So you see the neuronal communications and the message which is getting received by the brain through the spinal nerve. The spinal nerve from the both sides of spinal cord is emerged out like a stem, and which is having several branches. These branches is further making the connections through plexus and ganglia, and then they will be spreading throughout your body, and that way they are getting the message. Now you see one of the very serious problem, which is very much prevalent in not only in developing country, even developed countries having more evidence related to CNS problem, like Parkinsonian disease. So our focus to find out some solution, because there is no treatment so far for this very serious clinical problem, that is Parkinsonian. So far, whatever the drugs we have developed, they provide only symptomatic relief. There is no cure for this problem. And not only this, most of the central nervous system problems are unfortunately not curable, but what so far we have understood that there are slight changes in the neuronal architectures in terms of structural damage, in terms of the chemicals they utilize, like neurotransmitters. So what we try to do, we make some drug which eventually increase the level or decrease the level, and in that way we try to control the symptom. But unfortunately, the progression is continuously there. Therefore, our focus to get some targetable site which could have some benefit in terms of providing the progressions which could be targeted and controlled. So recently, I think those are not aware, epigenetics is one of the interesting process in which the gene, without modifying it, change the response, and this process is known as epigenetics. This epigenetics is right now is a gray area, and most of the advanced institutes are focusing to understand. So initially, what we did, we focus on this epigenetic changes which are very much explored in cancer, and there are several drugs which are available clinically, which are treating several types of cancer. So this epigenetics is one way or other way, when the stress is continuously there, your genes is getting affected because one of the proteins which wrap the DNA is histone, and this histone is having a positive charge, and because of that regions is tightly wrapped the DNA. And this would be getting affected because this is a dynamic process. Your gene transcription is needed. So it would having certain enzymes which are dynamically balanced, like histone acetylations, which is with the help of acetyl transferase, and deacetylase, methyl transferase, and even several other, including nucleations, phosphorylation, which would also be getting participate to make it as per the need. But what happens when the stress is continuously there, the process is getting impaired, and sometimes, say, because acetylation is needed to relax the DNA and DNA transcription is started, but sometimes hyperacetylations may result in the problem, and the products which are getting formed is not correct, it would be abnormal. So in case of central nervous system problem, because we know there are several proteins which are getting accumulated and maybe sometimes not able to clear, and even your apophysic process is also not able to clear them because they are abnormally formed and they are start clumping. So one of the interesting part related to this epigenetics, which we come so far based on our earlier study also, that this epigenetics is regulating certain genes in which SNCA gene, which is very, very important genes, those students are aware, it would regulate the synaptic vesicle transport. It would trimming the neurotransmitter which is before finally it is getting released into the synapse. The synaptic proteins which is getting also modified, generated, also getting affected by this SNCA gene. So under stress, these genes mutations or modifications you can say where would be there that would affecting the movement of the actual neurotransmitters, and sometimes the modifications in this particular genes may result to affect alpha-synuclein. This alpha-synuclein is very, very essential and very much needed for releasing of the neurotransmitter into the synapse and to affect the proteins which is having involved in neurohumoral transmission. So neurohumoral transmission is a process through which your neurons communicate to each one. So that is getting affected. So our interest is getting started when we look for whether it would be possibly because of the epigenetic modification. And the next part is related to, because in our last study we have found that FGF21, which is a metabolic hormone, and very effectively regulate energy consumptions and energy expenditure. So we earlier observed that is FGF21 is getting affected, and especially in metabolic disorder, like when someone is having insulin resistance, type 2 diabetes mellitus, obesity, the expressions of this FGF21, which work like a hormones, expenditure hormone you can say in one way or the other because it regulates the energy expenditures is getting affected. So our objectivity to first establish whether this epigenetic would be involved or be having any involvement in the pathogenesis of Parkinsonism, and second, because earlier we are having evidence related to FGF21, but it is a gene, so could it be delivered like a drug? So we have attempted the effort to deliver this FGF2 gene into the brain and then see what are the response of this FGF21 when we deliver in the brain. The objectivity of this study is dual. First is to look for the epigenetic involvement, and the second to deliver the gene. So see, we have taken the neuronal cell. So research ideally conducted to initially preclinically. Nowadays, because several government agencies emphasize please minimize the use of animals unnecessary, so you just focus to get the idea using the cell lines, organoids, and especially the organ system like ex vivo organ system is also in very much practice nowadays. So this study first focus on in vitro part, in which we have taken this anti-neuronal cell lines and see whether this epigenetic modulators, the drugs that is decitabine, DNMT inhibitor, would work or not, or to prevent the injury of neurons or even prevent the damage of neurons. So you see this the neuronals, the cell, when they are getting generated. So this is just before the sprouting of the axons and dendrites, and clearly indicate the nucleus. That means the neuronal cells which is getting generated are healthy and could be taken further for study. We have first look the Bible assay and see whether the cell is getting protected or not, and then we have confirmed using different assays. We have induced the Parkinson-like toxicity using 6-OSDA, and then see the effect of the drug using decitabine at a dose of 0.1 and 0.5 mg, and found that it really significantly affecting the survival rate. Now, because this would be a very rough idea, if you want to go to further to confirm it, you have to focus on the biomarkers, which would be giving a clue whether your target is workable or not. So in case of Parkinson, because I'm just presenting, this is a good piece of work, I guess, you can believe it. And we have established this using the tyrosine hydroxylase enzyme, which is involved in synthesis of dopamine. The another very important markers for Parkinsonism is the dopamine transporter actually. The dopamine is getting transported, stored in the dopaminergic neurons, and then it is utilized. So dopamine transporter is also one of the important biomarkers if you want to go for the study related to Parkinsonism. The third is alpha-synuclein, obviously, which is very much involved in the pathogenesis, and very interestingly, we are not even expected that alpha-synuclein level is getting affected by this decitabine, but epigenetic modifications also affect alpha-synuclein, which is very interesting finding. And we have not wasted the time, so we have further planned and then see the imaging system, which clearly indicate the healthy neurons, pycnotic neurons, whether they are getting protective or not. So we went for ICC and see the expression of tyrosine hydroxylase proteins and its gene alpha-synucleins. Not only alpha-synuclein total, we even focus on the phosphorylated alpha-synucleins, which is the major problem clinically. And from this cartoon, you can see from this figure, actually, you see here in 6-OSDO, and when we have treated with decitabine, it was very significantly declined, giving a very, very interesting result. Now, I think because the time is very limited, I don't know. That's fine, because even the audience is hardly 10 to 15 students, so that's absolutely fine. But I need to share that sometimes you need to do the effort and even take the challenge, like we have taken the challenge to deliver the gene like a drug, and we are very successful. If you see our result in the brain, first you see the transfection efficacy of gene, and then see the results based on cell line assay, and even we have done few in vivo animal study in which we have successfully delivered the gene in the brain, and we are found very, very interesting result. We have published several papers based on this. You see all these very interesting, very advanced gene level biomarkers which we have done. And from this ICC analysis, you clearly see the expressions of this FGF21 in this lipid nanocarrier based formulations, and when we have combined it with decitabine, the combinations is clearly having a very strong synergistic response, which is really interesting. That's why we have immediately moved forward to check it using animal study, and we have confirmed it through behavioral study, by biochemical assay, and even imaging based assay, which clearly indicating the benefits. All biomarkers focusing on neurochemicals, including the pro-inflammatory cytokines, oxidative stress, and specific biomarker like alpha-synucleins, brain-derived neurotrophic factor, etc. we have done. Even we have checked the level of dopamine, because we found tyrosine hydroxylase enzyme expression increase, so obviously the level of dopamine need to be increased, and it was very correct as per our earlier study. So in that way we have done this, and overall this study is the first study which we have conducted first time, and we indicating that decitabine could be used in Parkinsonian disease. The first time these combinations we have tested, we have filed the patent and published very good journal. One of the paper is under considerations because it is under revisions in one of the best journals. And molecular neurodegenerations, which is one of the Q1 journals, and its impact factor is around 17.5, in which it is under considerations. First revision we have received. So hopefully this paper would be published. We have even filed one of the patent on this finding. So thank you very much for all these. Before I come down, just see the research group, the acknowledgement to all government agency which supported the research. These are some research scholars which already done the work. And very interestingly, if you see this Dr. Rajiv Ranjan, tomorrow he will get the best PhD thesis award by Government of India. He is a joint supervised student who did with series. He is in USA and the thesis is accepted for best thesis award by Government of India, and tomorrow he will not in presence but on behalf of his series will receive the award. Thank you very much. Last group, this is IPSCON campus. Thank you very much. If you are having any questions, I would love to answer any doubt, any question.
Thank you very much, Dr. Rajiv. Thanks for sharing the wonderful piece of work with we people. Just one question.
Yes.
Sir, the parameter, behavioral parameter which you have selected, would you like to explain something? And the change?
Behavioral parameters based on the disease need, like in case of Parkinson's, motor impairment is the problem, muscle coordination is the problem. Because the part of your brain that is working in circuit. Brain is something which is not independently working. It would having a circuit which is having one part connected to the XIP, the other part is related. So it is dynamically balanced always. Always remember, when you just affect any part of brain, there is no single symptom. It would be having multiple symptoms. It is not possible that if you are having anxiety, you must have depressive action. When you are having depression, anxiety, you must have some kind of behavioral change which is similar to psychology. So it is because of the circuit. Like in case of Parkinson's, the circuit is related to basal ganglia, started from substantia nigra. Substantia nigra utilized directly and indirectly to affect the cortex to thalamus. So if the thalamic part is getting affected, if you ask me why it's getting affected, I don't have any answer. But possibly because of the neurodegeneration started due to the aging, our defensive system is getting declined. Like our best defensive system which are related to oxidative stress is antioxidant enzymes which are abundantly present in healthy cells. When the aging started, the decline of these defensive systems is gradually started, and then the problem started. The second important point, if you just look related to why the oxidative stress is much, it is because of this basal ganglia regions which utilize phantom reaction mediated generation of antioxidant species. So iron abundant part utilize this because it needs to handle this dopamine, which is metabolite, and during this metabolism, it will sometimes generate the oxidative H2O2 and other free radicals. So it may be because of phantom reactions is abundantly involved in this process. That's why recently, if you look, this iron chelating agent is tested and found clinically very significant response to control the progression. It is because of one of the reasons. And the second question you asked related to behavioral change.
Because that was lacking and due to
so the best one is grip strength test because the muscle coordination and the strength of muscles, it would depend on the grip of animals. That would be one of the best tests. Second is the movement of animals on the road, which again indicating whether the muscles are balanced or not. So they are directly indicated the problem. Thank you. Thank you.
Because of constraint of time,
thank you.
Anyone else? Okay.
Yeah, please, Professor.
So this, the drug which you use, decitabine,
yes,
it's an anti-cancer drug?
Yes, absolutely correct.
So if we go by anti-cancer drug system, anti-cancer drugs will stop the propagating of the cells.
You can ask.
Yes, propagating of the cells.
Yeah. And why?
When we say Parkinson's or any other neurodegeneration disease, that is exactly opposite.
Yeah.
Degeneration of neurons. You want them to grow.
This is really very, very good questions because if you really think from this point of view, you just need to understand. This is related to actually epigenetics. We are not focusing on drug initially. We are looking whether this epigenetic modulations actually would affecting this process. Like in case of cancer, it would affect tumor suppressive gene very clearly. It is well known, and that's why this decitabine have been developed.
But by doing so, this is parallelly affecting the acetylation also. This is already known.
No, my question is very simple. So, because here we have developed a 6-OHDA model.
Yes.
And that model will also raise multiple questions. That's separate. But then it's exactly opposite. Means even if it is a genetic or epigenetic.
First I will to clarify. This 6-OHDA is well validated, well accepted. Other than MPTB. MPTB is the first choice. 6-OHDA the second choice. So model is not having any question. I do agree to your concerns related to why the cancer drug would be repurposed in Parkinson. Yes, this is really valid question. But if you see, you need to understand that sometimes one drug which we have approved for something may be having the benefit in other conditions. So my work started in 2030. I just look for the first epigenetic changes when the drug is very much focusing on cancer. I started the work looking for the possibility whether this acetylation total or hypoacetylation, how to affect the gene transcription process. So the journey started from HDAC and eventually we moved to DNM. We found, and even 2 students already worked, professor, and it's really interesting. We first time established that metabolic disorder not only increase the risk of heart and cardiovascular problem, they equally increase the risk of neurological problem. And we have even published several very good research papers on that. And now if you see ample evidence is available which are even in that direction. And very recently, before 1.5 or 2 years, we even project on the same concept on epigenetics. Some researchers are focusing on cancer, some researchers are focusing on neuro, and even malaria. We are looking whether this epigenetics would make the resistance which are related to not killing these parasites. So this would be because of programming. I think Professor understand that how it would affect eventually your transcription process, because this is the key. Everything is done by this transcription process or your nucleus. So this is why we have moving from that to that direction. And based on our vision, we are very confident that this is working. Although there are concerns related to one part you might have related to toxicity.
Thank you very much, sir.
Thank you.
Thank
you, Dr. Rajiv. I would request the chairperson of the day to please
yes, sir.
felicitate Dr. Rajiv.
Please. Because come se kam ek to
So now is the time to felicitate our chairperson of the day. I would request Dr. Mahendra Vishnu to please join.
One by one. हम तो one by one लेंगे. अब मैं ये पकड़ लूँगा. नहीं सर, I will take it.
I thank everyone for being a wonderful audience, and I would request you to join for the general body meeting of pharmacology in Hall 1. Thank you.
Yes.